procedures. So, can you see my slide already?
Yes po,
Yeah.
Doc.
Okay. This basic life support is some sort of being mandatory on two things. One is to enhance, three things. One is to enhance the capability of the pre-hospital care provider when it comes to addressing emergencies, particularly cardiovascular in nature, whether it is in agonal or with agonal breathing or choking or what. And it is the bridge towards advanced cardiovascular life support. So that's one thing. Number two, the first intention of basic life support, for your information lang, no, give you a little history, is also to capacitate the lay people, yung mga tao, other than the healthcare providers, sa labas na marunong sila paano gagawin kapag merong insidente, no, cardiovascular incident sa loob ng pamamahay nila o sa kalye. So parang ito ay pre-hospital care dogma and life skill. Although mas maraming trauma kaysa maraming nag-cardiac arrest, no, that needs to be resuscitated or kailangan magkaroon ng compression, naging mandatory siya. So pag sinabing mandatory, even in the in the workplace, naging mandatory din siya under the DOLE, Department of Labor and Employment. Kaya tatlo yan. So healthcare, lay people, and then sa workplace, no? Kaya kasama sa first aid. Now, it is but timely and right for us na matutunan ito kasi ito yung ating way on addressing to how we imbibe the resilient culture. Alam niyo, dito sa Manila, ngayon, makulimlim nga ngayon. 2022, sa World Risk Index, number 1 na po ang Pilipinas. Ibig sabihin, sa lahat na uring sakuna, meron na tayo. Ang wala na lang, anything about snow and ice, no? Kompleto na. That's the sad reality. Numero 1 din tayo sa Southeast Asia as accident prone. Ano ibig sabihin nun? Suki tayo sa mga vehicular accident. Sino nagsabi? Ayan po yung statistics na ni-release kung anong meron tayo ngayon. Kaya, welcome to the country along the accident and disaster corridor. Grabe, sikat. But on in our own highway as healthcare providers, we need to be refreshed kasi hindi ibig sabihin na kahit gumraduate tayo, kahit doktor, na yung unless sa medical school ngayon medyo aggressive na, tinuturo na talaga ito. Hindi katulad ng panahon namin, parang madali lang yan. So actually, it's not, no? Kasi meron kang required speed, merong required assembly of the code blue team, no? Kung sa hospital based siya. And then lately, merong mga how to do CPR pag nalunod na merong style lang, no? At paano mag-conduct ng CPR, maggawa ng compression sa low headroom, mababa ang headroom. Kaya hindi ka makaganon, stretch ng kamay. Yan, no? Although hindi ko siya ituturo kasi that's a separate topic. Paano mag-CPR yung person with disability? By the way, people, you don't call it PWD. No? Kompletohin mo talaga, person with disability. Or, make it more nice, hindi pa uso sa Pilipinas, tinatawag na DAP or differently abled person or people. So, yun po yung mga bagong terminologies natin ngayon. Pag ikaw ay amputee, walang paa, walang binti, putol, no, dito sa middle third of your thigh, hindi ka talaga makastraight ng ganito, mag-compress. So, paano yun? Yung tinatawag na ulnar line CPR. Ulnar line. Pag amputee ka naman, dito wala ka dito sa middle third ng, sabihin natin, double amputee ka sa middle third ng humerus. Paano mag-CPR? Wala kang braso. So, wala kang kamay. Oh. So, mayroong solusyon po. Okay? So, yan po yung mga adjustments. Although, hindi natin pag-uusapan yan kasi special ano yan sa mga amputees. No? So, tinuturo lang namin yan sa United Nations International Strategy for Disaster Risk Reduction. I was tasked by UNISDRR to teach survival and life skills to persons with disabilities, elderly, mga ganyan. So, noong July, inikot ko buong Pilipinas. No? Wala akong pahinga. Ang tulog ko lang, taxi, aeroplano para magturo sa mga persons with disability on basic life support ng mga unique. No? So, by the way, I'm Dr. Ted Esguera. I'm not the doctor who walks around the hospital with a lab gown and a stethoscope about the neck. So that's not who I am. My area of operation is the field. So I'm a flight doctor. I'm also a disaster uh, a rescue doctor who addresses issues in the disaster zone. So tulad kapon na I was interviewed, no, parang pag may disaster, doon lumalabas yung beauty ko, no, para akong anghel ng kamatayan. Na pag nakikita yung pagmumukha ko, ang naiisip ng tao, disaster kaagad. Medyo umukay na ako doon. Now, I'll give you a bad news. So in the introduction is a bad news. The bad news is, ipunin ko yung mga namatay sa Aleppo in Syria. You don't know where Aleppo. Isama ko yung Ukraine ngayon. Isama ko yung Marawi. Isama ko yung sa Iraq. Ipunin ko yung lahat. Tatapatan lang na 3 or 4 na araw. Ha? Ilang years yun, ha? I think, 4 days yata. Tapatan lang ng 4 days sa dami ng namamatay sa cardiovascular incident. So you are more worried. Dati pagdating ni COVID, taranta tayo lahat, no? Taranta because it's a new or a novel virus. Ako nagka-COVID ako, muntik din ako nadali. Pero sa COVID, hindi ka kagad namamatay. Pwede ka pa mag-TikTok. But in cardiovascular incident, massive stroke, massive MI, wala, diretso ka. And people are not scared. As if, okay lang, hindi ka na maka-TikTok doon. And World Health Organization said, it's a global scare. Matatakot ka kasi madami eh. Hindi siya nababawasan. Hindi siya nagpaplato sa statistics. Dumadami siyang dumadami. And the ugly reality here, people, is pabata ng pabata ang nadadali. So while I'm talking to you right now, there are quite a handful of people right now na namamatay because of cardiovascular incident. You have to note that because the practice of medicine is always the preventive side. And hindi siya naka-fully take off. Kasama din ako doon. Hindi na ako nag-exercise for so many years. Konti-konti lang. Pag hinahamon, yun. Pero yung daily requirement, naku, patamad-tamad na rin ako. The issue here is there are triggers that can cause cardiovascular incident. So, number 1 is, of course, uncontrolled hypertension. Merong alta pressure na hindi pinansin, ayan, madadali ka. Pangalawa, yung with no consultation na hypercholesterolemia, poor compliance to medicine sa hyperglycemia, yung may diabetes, yan, kandidato. Another, ito medyo masakit, no? At siguro yung iba dito guilty. Smoking, hindi ko maintindihan. Hanggang ngayon, grabe naman yung campaign na ang smoking, malaki yung kanyang contribution sa cardiovascular incident, pero ang dami pa rin nag-smoke. Ano pa? Of course, sedentary lifestyle, yung paupo-upo lang, pakuya-kuya lang sa gilid, patamad-tamad. Obesity, ano pa? Ito, medyo mahirap talaga, no? Kasi ito, sakit ko rito eh. Stress. Yan. No? Kung lalo na pag nandito kayo sa NCR, magmaneho lang kayo sa labas. Stressful na, no? So, para hindi kayo ma-stress, huwag kayong tumingin sa salamin. Biro lang. Now, another bad news is, despite the fact na meron tayong 911 emergency number, hindi siya naka-fully take off. Kasi, halimbawa, kung nasa Hulu ka, tatawag ka ng 911. Sa Manila kasi ang ang main line eh. Hindi katulad sa US na per mega city or per state. Dito, Manila lahat eh. Tatawag ka sa Cebu, pupuntang Manila. Tatawag ka sa Davao, pupuntang Manila. Pero sa Davao, meron sariling 911. Kung pwedeng city-owned siya, mas maganda sana. Pero hindi naka-take off ganyan sa buong syudad sa Pilipinas. The best is Davao. Na grabe, naka-take off sila. Na may sarili silang 911. Ipipiggyback lang sa national. Para hindi na pupunta sa Manila, ang mag-a-address mismo, Davao Control. Hindi katulad sa ibang lugar, no? Majority sa lugar natin, wala silang ganung system. Yung iba, ibang number naman. Papunta ka ng Isabela, sa Kawayan, ibang number sila. Pero merong ng National 911. Pero hindi siya naka-take off fully pa. So our objectives is to describe what basic life support is, and let's look at the chain of survival as its storyline. Yan yung storyline niya. Yung sunod-sunod, hindi pwedeng mauna yung pang-apat. Yung sunod-sunod yan, parang ika nga, grade 1, hindi ko pwedeng grade 6, grade 1, grade 2, grade 3, grade 4. Ganun. Silipin natin yung in-hospital cardiac arrest versus out-of-hospital cardiac arrest. Tapos, ano yung interim guidelines of 2022 with emphasis on COVID. Emphasis on COVID. Kasi I would like to give the picture to everyone, to you, na na-release po ang 2020. Pero nang ginawa ang 2020, nag-start po yan sa 2018, 2019, and partly Filipino, they refined it on 2020. So, nang nilabas nila yan, wala pa si COVID. So, the time nag-roll out si 2022, si 2020, kasagsagan ni COVID, nag-release kaagad ang American Heart Association o one-page declaration or one-page support to COVID bago mag-compress sa dibdib ay nakatabon yung mukha ng patient with mask. Mukha, yung nose and mouth area. Para yung aerosol, hindi. So, hindi nakasama sa libro, pero ginawa nilang soft copy insert. Biglaan. And then they designed the 2022 na. Yung tinawag na interim guidelines. So, yun yung itutulong ko. Kung hindi nyo pa narinig yan, makikita nyo. But I will not read them kasi medyo mahaba-haba si interim. Hindi ko nabasahin. Pero if you want to read it, my slide is available. I-send lang ni Ma'am Joy sa inyo. Para may ma-review kayo or makita na, ito pala yung interim guidelines. Paano naman tayo sa Pilipinas ay updated and upgraded. Ang problema sa Pilipinas, mahina tayo sa updates and upgrades kasi una, wala tayong pre-hospital care law. Tapos, I'm so sad na hindi nga tayo gumagamit ng Utstein style, UTSTEIN, Utstein. Even yung mga teaching bodies natin, yung Red Cross, hindi gumagamit ng Utstein. Philippine Heart Association, hindi gumagamit ng Utstein. Ang Utstein is the Bible used by the pre-hospital care providers agreed by several countries. So nag-usap sila doon sa Norway yata, yung Utstein Abbey. Kaya ginawa siyang Utstein style. So nakakalungkot, no? Na hindi tayo sanay. Despite the fact, nakasasabi ko lang kanina, numero 1 tayo ng pinakamaraming disaster ngayon, simula 2022. Kaya there are sad realities happening around. It's because meron tayong mga individual, particularly doctors who are adept, particularly sa COVID na trained sa abroad. Pagdating sa Pilipinas, hindi ma-sustain yung expertise nila kasi wala tayong facilities. Kulang. Saka nakakita na wala tayong bio-level 4, which can handle Ebola, Hanta, Marburg, no? Mga ganong klaseng mga deadly na hemorrhagic fever yung wala tayong ganon. So, ang galing ng isang tao, alam niyo ang medisina kasi dalawa yan. 50-50 yan. 50% ang tao at dulong niya. The remaining 50, the other 50% are lahat ng gamit na ginagamit sa science in the practice of medicine. So, halimbawa, ikaw, gumagamit ka ng stethoscope or tansya-tansya ka para magkabit ng central line. Ako, meron akong ultrasound at talo kita. Yun yung point ko. So, kailangan meron tayong kagamitan na sakto. Pagdating ni COVID, na-realize natin, kulang tayo ng serological backing, katulad ng RT-PCR. Ang ilan lang. Kasi hindi siya, ang RT-PCR, hindi lang naman yung pang-COVID eh. Ginagamit niya sa ibang viral ID. Pero sumikat siya kasi yun yung pinaka mas tugma na makikita natin si corona. So sumikat si RT-PCR. Hindi tayo ganong sa serological expertise, ilan lang, the likes of St. Luke's, yung mga malaki. Diyan natin nakikita na kulang tayo sa logistics when it comes to the ideal practice of medicine. So, sayang yung galing. Galing ako sa abroad. I'm well trained with all the high-tech. Pagdating sa Pilipinas, wala. Tapos, nabitawan ako dito ako nagpa-practice, wala akong gamit, di para akong sira ulo. So, you call me an expert, pero wala ang gamit. Hindi siya walang sustainability. Parang sa pre-hospital care ako, bumili ako sariling gamit. May sarili akong ultrasound, pang pre-hospital. Meron akong, ito sa likod ng laptop ko. Ayan o. Capnometer. Kahit hindi gumagamit ang Pilipinas ng capnometer, so meron ako. Ito yung capnometer na gumagana kasi yung ituturo kong capnometer sa ACL nasira na yung mahal yun, 90,000 nasira. So that's the point. So anyway, here in basic life support, there's not much gadget except yung thumper. Nasira kasi yung thumper ko. Meron akong thumper dati luma. Mga pinakaunang prototypes. Pero wala na, nasira. Then, let's look at the stations of compression, rescue breathing, foreign body airway obstruction management, operating AED. Itong pag-operate ng AED, hindi siya rocket science. Pero sige lang, isinama na lang sa batteries of learning ng basic life support. But I would like to remind everyone listening to me as healthcare providers, hindi po tayo nag-AED per se sa ospital. Ang ginagamit natin, kasi tayo po ay professional, ang ginagamit natin ay manual defib with AED override or baliktad. AED with manual override. Katulad sa akin, mayroong manual override. Kasi ang AED, for the information of everyone, hindi po yan ginawa para sa nurses, doctors. Ginawa po yan para sa lay people. Okay? Sinama na natin, sige, pati sa EMT basic. Pero ang paramedic, dapat manual defib na rin. EMT paramedic. So yan po yung mga minsan sa Pilipinas, hindi natin naintindihan kasi pag nagbasa tayo ng manual, naniniwala kagad tayo. Pero lagi hindi tayo nagdi-deep dive into understanding situations. Ang dapat sa hospital ay manual defibrillator. Bakit? Kasi hindi lang naman tayo yung definitive care. Ang AED, intended siya for field lang yan. Tayo ay definitive care. Bakit ka mag-AED? So, kailangan manual defib kasi baka hindi naman arresting case yan. Baka naman tachyarrhythmia yan o na kailangan ng cardioversion. Ang AED walang cardioverter. May heart block na bumagal yung pitik ng puso, kailangan pala ng pacer. Ang AED walang pacer. O, ayan, kita mo? Ang AED walang 12-lead ECG para makita ko talaga saan yung MI. No? So that's the big problem. Kaya tayong healthcare professional, huwag tayo mag-request ng AED na, kasi yun yung nakalagay doon sa manual ng AHA. You are not getting the point. So the point there is, the first intention why BLS is made, other than you, is for the lay people to know how to save lives in the streets. Pagbagsak ng tao dyan sa pamamahay mo, tumatakbo na yung taximeter. Yan yung essence ng medicine, kaya ginawa yung chain of survival. So basic life support is an intervention to a arresting case, no? Yes, when you have an cardiac arrest, unconscious na yung individual mo, whether he's adult, child, or infant, pwedeng walang pulse and respiration, or meron namang pulso pero agonal breathing, or may pulso, merong agonal breathing pero may bara yung airway, or meron siyang poisoning or overdose, particularly with opium, no? Opioid overdose. And basic life support is performed by trained personnel. Kaya meron kayong certification. Ang certification niya, according to standards no, na nilay down ng ILCOR sa kanang AHA, ay 2 years kasama sa ACLS. Pediatric Advanced Life Support, Neonatal Resuscitation Program, Basic Life Support, Advanced Cardiovascular Life Support. 2 years ang buhay niya. Ang 3 years ay, I think, ITLS, 3 years yata ITLS. Ang Advanced Trauma Life Support ng para sa mga doctors, 3 years din. I don't know with the Advanced Trauma for Nursing, PHTLS, I don't know how many years. So meron siyang time frame na dapat nire-renew para skills update and upgrade yun. Now, the batteries that we will learn is, I will not read the 2020 protocol. Paano ginagawa yung compression, i-demo ko na lang yan. AED operation. So, maya-maya, the second phase is about demonstration of all these batteries I mentioned. Then, how to do the foreign body airway obstruction, yung tinatawag na abdominal thrust, and then rescue breathing, hindi siya mouth-to-mouth, gumagamit tayo ng bag valve mask. Sa interim guidelines nga, hindi na ini-encourage yung mouth-to-mask bag valve mask. Kaya meron kaming bag valve mask na maliit lang na papapakpak, lumalaki siya. Parang accordion. Tawag nun cyclone. And then, very new sa lahat is naloxone induction. Alam niyo, pag nagbigay kayo ng naloxone, pag pronunciation is naloxone. Dati kasi pag nagbigay tayo ng naloxone, through IV. Ngayon, gumawa sila, no, hindi na IV, atomizer na, yung dito sa nostril. May pang-push na, ano. We call it atomizer, although, because when you release it, because of yung mga spray, the aerosol, it's like you atomize them. Basic life support, ladies and gentlemen, is a requirement for ACLS. Requirement talaga siya. So no one gets into the level of advanced cardiovascular life support without taking BLS. So malabo yan. Pero sa ATLS, PHTLS, ITLS, MOET, ADLS, AMLS, WALS, except for WALS, kailangan marunong kayo sa basic life support. Okay? It might not be a requirement, pero yung mandatory, pero kailangan marunong kayo ng BLS. Hindi yung hahanapan kayo ng resibo or diploma na hindi ko pwede mag-exam. Dito, pag kunwari, take ka lang MOET, pakukuhanin ka MOET, hindi na sisilipin. Pero kailangan, at the back of your mind, kailangan marunong ka kasi arresting heart pa rin, babalik ka pa rin sa compression. So yung nagre-require na mandatory BLS ay ACLS, PALS, NRP, at saka WALS, no, Wilderness Advanced Life Support. So there are now 6 items in the package. Dati 5 lang. So ano yan? Pag-aralan ng chain of survival, compression, foreign body airway obstruction, rescue breathing, AED operation, naloxone. Actually 7 yan ngayon eh. Pinapa-review sa atin yung hindi ko pa na-update to, 7 to. Pero paatras, yung number 1 hindi na chain of survival, yung number 1 yung tinatawag na BLS ACLS protocol with the interim guidelines of 2022. Hindi ko lang siya sinama kasi actually hindi naman siya skills-based eh. Hindi siya skills-based. Nagbibigay lang siya ng introduction what BLS is all about, sino nag-coin ng word, ganyan, little history. So gusto nila ipaalam kasi masyadong abuse na yung word ng BLS. Pero actually, ang gumawa ng word na yan, ang kiniklaim ng American Heart ay sila. So gusto lang pinaparemind sa mundo, aking amin yan, ano man naman si And then, number 2 is chain of survival. Ayan. Tapos, down the line. Ang pinakahuling na ilagay is naloxone induction. So here now is your chain of survival. So, ang ginagamit natin ay yung pinakaitaas kasi inside hospital kayo. So, ang pagkakaiba lang naman nito, itong bungad, no, for adult. So, in hospital, early recognition and prevention. Kasi yan yung drive ng medicine. Yung global practice of medicine, preventive talaga. Diba? Tama yung lumang dictum, an ounce of prevention is better than a pound of cure. So, ang medicine, katulad din sa amin sa disaster, meron kaming tinatawag na DRR, Disaster Risk Reduction. Ang pinakabulto na trabaho ay paano i-prevent yung ugly things. Ganon din tayo. Kaya meron tayong tinatawag na mga uh, modifiable sa non-modifiable traits, paano natin i-modify, for example sa modifiable traits, hypertension, o di hanap ka ng magpakonsulta ka sa doktor kung anong klaseng hypertension, no, ano yung trigger bakit may hypertension ka. So, depende anong pwedeng ibigay sa'yo. So, depende kasi, hindi yung one size fits all yan, no? So, magpakonsulta para bumaba. Pag meron kang hypercholesterolemia, magpakonsulta, pakpunan ng dugo, tingnan natin gaano kataas. Itugma natin kung anong klaseng ibigay, fibrates ba or statins ba, mga ganyan. Then, we have high sugar, hyperglycemia, most often, mainly it's caused by diabetes, at yun ay tumataas ngayon at papata yung tinatamaan. Kaya, pakonsulta din para alam natin anong ibibigay. Kasi merong klaseng diabetes na hindi lang basta tumaas ang sugar. Pwedeng wala kang insulin or merong insulin pero wala siyang garahe. Walang garage because you need to transfer the sugar from intravascular to the cells, no? Because the sugar is needed by the cell para sa production of the adenosine triphosphate. Kaya ngayon nakikinig kayo sa akin, alive kayo, kasi gumagana si mitochondria. Tatlo lang kinakain ng mitochondria, tubig, oxygen na 21%, at saka glucose. No? So, saan pwedeng pumunta si sugar? Doon sa cell para magamit siya. Pero if it stays so much in the intravascular area, tatamaan niya ibang organ, ma-overwhelm niya. For example, retina, masisira niya mga capillaries na maliliit doon. Kidney, yung glomerular apparatus, masisira. So, pinapababa natin yan. Depende kung anong klase. Kaya kailangan magpakonsulta. Ano pa, obesity, yun. Maraming, depende anong klaseng, magpakonsulta kayo kasi may mga tao mali-mali yung pag-intindi nila. Yung iba talagang literally nag-fasting na they want to drop get rid of the fats right away. You don't have to be aggressive, magkakaproblema ka dyan. So, tinatanong po natin sa doktor, kaya nga nag-aral yung doktor para makita yung wellness ninyo. No? So, may tamang paraan, dietary intervention. Siyempre, una yun, behavioral, dietary, saka exercise. Ayan. Smoking, mahirap tanggalin. Pero, pwedeng ma-institutionalize talaga, malagay sa batas. Ngayon, medyo stricto tayo, meron lang smoking area. So, it becomes also an epidemic. Mas madali mamatay ang tao nag-smoke during COVID. Madali siyang, science is there, pero ang pagiging stubborn ng tao, mas mataas kaysa sa pag-iintindihan ng siyensya. So, yan ang minsan pangit, no? We know that it's bad, but we commit it and we lose the will to get rid of it. No? Kung ano man it's not only in smoking, but it's anything that is detrimental to the body and to the society. Ano pa? Stress, well, I also live a very stressful life. Ako lang, minsan makikinig lang ako ng music or maglalaro lang ako ng chess sa sarili ko. Inaaway ko yung computer. Mananalo ako, matatalo ako. Get rid of stress lang. Ganun. So I cannot really prescribe something about stress because I'm not the good guy there. Because I also live a very stressful life. So yan po yung mga modifiable. Yung mga non-modifiable natin ay pag-edad, katulad ko ay 55 years old. Siyempre, medyo masakit sabihin, no? Palapit na palapit ka sa hukay habang umuusad yung panahon. So, siyempre, allow me to use it. in a very laymanized term. Parang tumitigas din yung blood vessel kung hindi siya compliant or baka nakagarahe na sobrang marami ng cholesterol deposits or what. Ano pa? Gender. Ang lalaki mas madali makakuha ng myocardial infarction kaysa sa babae. Kasi although hindi na-describe in some books, but anthropologically speaking, ang lalaki kasi siyempre testosterone ang nire-release. Testosterone is a warring hormone. So alam naman, pag war, talaga yung wear and tear mabilis. So, doon ko binasa sa perspektibo ng anthropology. And then ano pa, hereditary. Pag nasa lahi mo, wala na tayong magawa dyan. Kaya kayo, bago kayo mag-asawa or magkaroon ng relationship or what, tanungin niyo muna, may diabetes ka ba? Just kidding. Lalo ngayon, mahirap na kasi halos karamihan tao nasa family lineage, may sakit sa puso, cancer, yan. Sabi ko sa inyo, very common na siya. Okay, so ang pagkakaiba dito sa in-hospital, yan, sa out of hospital, ang nadagdag lang is the ambulance. So dito sa Pilipinas, uso yan. Pero merong bad news, dalawa ulit, no? Bad news, no? At the start of the morning, bad news kagad ang sinasabi. Number one, wala tayong pre-hospital care law. Mahina. Maraming ambulansya, labo-labo yung mga ambulansya natin. May mga ambulansya dyan, sorry lalo na yung mga government run, kung sino-sinong driver pinagkukuha na walang emergency vehicle training, no? Hala, kung magwangwang sa kalye, parang kanya yung kalye, no? So, hindi marunong. Saan siya sa kalye? Kung 2 lane, saan siya? Pag 3 lane, saan siya? Merong style yan. Anong category ng wangwang niya? Category 1, 2, 3. Depende yan. Depende sa kaso na kinakarga mo. Nakakarga ka lang, nakaupo lang yung pasyente, may asthma, pero ang wangwang mo, pati all throughout, bawal yun. No? Yung iba, nagwawangwang pa, ang karga lang, mga empleyado, i-transfer lang. Hindi mo makikita, nakatim, may mga kurtina. So, mabibwisit ka. No? You create attention in the streets. Why? Yung driver ambulance mo, pinagdudukot nyo lang dyan sa lintik na motor pool. Katawa-tawa tayo sa mundo. That's number one, no? Hindi sila marunong. Number two, because of the absence of pre-hospital care law, wala tayong tamang designation sa loob ng ambulance saka sa labas. Kung ano nung pinaglalagay natin, ang worst case scenario, nilagyan pa ng mukha ng politiko, no? Bawal na bawal yun sa isang, parang hospital, bawal lagyan. Ganon yan ng mukha ng politiko yung sasakyan, ng ospital. Ganon din sa ambulance kasi may kinalaman sa sagip ng buhay ng tao. Sagrado yung and then there's the face of the politician or the name. Bawal po yun. Pati mga design. May Star of Life. The Star of Life is the logo of the pre-hospital care. Ginawa po yan sa US ng Department of Transport. Nako, dito sa Pilipinas, pinagbabago yung kulay. Mayroong kulay pula. Hindi. Ang kulay niyan, royal blue. Because the royal blue color of the EMS Star of Life signifies yung digal ng profession na pre-hospital care provider. Yun. Hindi mo pwedeng baguhin. Ang pwede magbago lang yan ay sundalo. Kung nasa uniform. Alam nga naman, royal blue. Tapos target practice ka ng kalaban mo kasi kumikinang. So, ang tawag nun, subdue. Kung kulay black, iba-black mo rin yung Star of Life. Subdued color tawag. Sangay. Sundalo lang pwede. Pero sa civilian medicine, bawal magpalit ng kulay ng Star of Life. So, dyan mo makikita na mahina ang ating ambulance program sa Pilipinas. Hindi siya So, ito lang naman, preventive, no? Ang dinagdag lang natin itong panghuli, which is the recovery. Nakitaan kasi according to evidence-based medicine na napagaling ng ospital, pag-uwi sa bahay, hindi natin naisama ang pamilya. Pagdating sa bahay, stressful yung environment, walang magbibigay ng gamot sa stroke victim, napapabayaan, kasi lahat nandiyon sa cellphone, nagtitiktok, mga ganun. So, nakita nila na mabilis ang balik sa ospital. Nagkakasakit ka agad. Hindi lang yan sa cardiovascular, kahit sa mga psychiatric cases, kahit sa mga CKD, chronic kidney diseases, no? Psychiatric cases, anything chronic. Nakita ngayon ng mga specialties ng medisina na ang bilis ng balik ng pasyente. It's because in the house, nagkakaroon ng poor compliance because the family is not cooperating. So, ngayon, bago i-discharge yung pasyente, kinakausap yung family at pati community na, halimbawa, galing sa na stroke, kailangan mag-wheelchair. Pag uwi mo sa community mo, walang rampa for wheelchair yung sidewalk mo. Bakit? Yung sidewalk mo, ginawang tindahan mo. Puro tindahan sa gilid. Paradahan ng tricycle na hindi na malakaran yung sidewalk mo. So ngayon, doon ka mag-wheelchair sa kalsada. So dalawa ng issue. Expose ka sa elements, no? Araw. Pangalawa, hazard ka sa kalsada. Bakit? Wala ng sidewalk. Hindi siya person with disability friendly sidewalk. Yan. So, yan din yung isang malaking problema natin dito. Ito naman yung sa pedya. Pero hindi naman tayo nagpe-pediatric advanced life support. Halos pareho lang, except sa pediatric, in-emphasize, bakit sa pediatric, ang in-hospital is preventive. Bakit dito sa out-of-hospital, preventive pa rin? Oh, so may nagtanong sa akin yan. Sa daming course, may isa nagtanong sa akin. Sabi ko, ganito po ang sagot niya. Hindi po ko pwedeng sagutin sa medical science. Sasagutin ko ulit sa cultural saka sa anthropological perspective. Ang tao, between the adult and the child, mas mabigat ang way ng child when it comes to the stigma. No? Ang isang batang madisgrasya saka sa adult madisgrasya, ang tao by culture, mas may simpatiya dun sa bata. Parang, sus, kabata pa niya. Pag ako, mamatay sa heart attack, medyo kaya ng mundo. Matanda na kasi yan. Pero yung bata, grabe, bata pa siya, ganyan. No? So, it's because the anthropological bias, the cultural bias is there. So, ang ginawa natin, sang-ayunan natin yun. Kaya ang mundo, ipiprepare natin na maayos ang mundo para sa kabataan. Sabi ng isang senador sa akin, si former Senator Magsaysay, alam mo, Dr. Esguerra, malalaman mo ang isang bansa, ang bayan ay progreso. Kapag ang bansa na yan ay ang kanyang serbisyo ay na itututok doon sa mga may kapansanan, sa may mga sakit, sa mga bata o kabataan, sa mga kababaihan, lalo na yung mga nursing mothers, sa mga matatanda at sa mga katutubo. Napakagandang linya. Pero it was not political for me. It is the right thing. Ang lipunan dapat magbigay ng kalinga doon sa mga it's not allowed to use the word marginalized sector now. Although it's not right to use it anymore. Kaya bakit tayo nag-aral ng BLS? Simple. Para sa mga tao may cardiac arrest. Isipin mo, we will spend Saturday, Sunday learning BLS at require pa kailangan sa passporting ko dito sa pinagtatrabahoan ko, kailangan may basic life support. Ganun yan. Kasi ito yung tama na emphasis para sa mga tao may kapansanan. Punan natin ang kanilang pangangailangan. Okay, so the rundown is scene survey and then assess responsiveness. Tapos activate emergency response, no? Or sa hospital, I don't know, hindi ko alam anong activation nyo inside the hospital. We call it the code blue. Kung hindi nyo pa na-organize, wala kayong code blue team, magtayo na kayo ng code blue team. Then, cover the patient with mask kung pre-hospital or cover the patient with bag valve mask kung tandem rescue kayo. Or cover the patient with non-rebreather mask before starting compression. Bakit? Kasi assuming may COVID dyan, hindi lilipad yung aerosol. Yan lang yung point. Okay. So, yan ang, actually, it's in the interim guidelines of 2020. Now, why we must execute from compression? It is to push blood to the brain. So, even if you do an all compression, you are still pushing oxygen. O, kita, makinig kayo. When you do all compression or all hand CPR or tinatawag namin nung nag-aral ako sa Singapore, CCR, cardiocerebral resuscitation. Yung all compression, nakakapagbigay ka ng oxygenation na brain kasi bawat recoil ng thoracic cage mo, ang hangin pumapasok. So pumapasok sa lungs, kaya nagkakaroon ng diffusion of oxygen to the blood vessels. Kaya ang blood vessels nagkikarry ng oxygen to the brain without you stopping. Kaya mas effective kung nag-solo rescuer ka, mas effective ang continuous CPR. Kaysa hinto ka at nagbibigay ka ng rescue breathing through your mouth. Kaya medyo maraming nainis sa akin, hindi nainis, kinukutya ako. Kahit ako ngayon, kinukutya ng mga ibang, isipin mo, EMT. Kala mo kung sinong magaling, kasi ka-doktor-doktor ko, tapos ang specialty ko, pre-hospital. Pero kung magsalita yung EMT, doktor kasi yan, TV personality, ganun. Ginagano, hindi naman ako pumapatol eh. Nagtuturo kasi ako ng CPR. Sa low headroom, ang ginagamit ko ito. Kasi hindi ka nga makaganon. So nag-react. Yung mga EMT na they think they are genius when they work abroad. Siyempre ako, nag-work din. Nagtatrabaho ako as contract rescue doctor sa abroad. Sa ngayong September, papunta akong Ukraine to teach Ukrainian soldiers and firefighters on how to save lives ng mga bleeding control sa September. Kaya nagkinausap ko ni Ma'am Joy, ano daw ba camping time ko. So I gave my schedule because I'll be in Ukraine. I am quite busy. Tapos kinukuha din ako ng Malacanang mag-undersecretary for Interagency Task Force sa Executive Order 24. Hindi lang ako nag-yes kasi hindi ako bagay mag-undersecretary. No? Kasi una, malakas pa ako, mapapakinabangan ako ng bayan as a field doctor, hindi yung parang politician na nakaupo. I don't find glory, sorry in any person sitting down. If you want to make history, you have to walk the walk there, walk the talk. You should be in the field doing it. For me, that's history. If you want to change the world, hindi ako naniniwala sa itaas. Napakasimple lang ng aking paniniwala. I will do it in the field. That's how I will change the world. Although, sabi nila sa itaas, halimbawa, kung presidente ako, iutos ko lang, I can change the world. Well, tama din sila, pero sa akin lang yun. Hindi ko naman sinasabing tama. So, I'm very busy teaching people, not only in the Philippines, but I go out. I just came from Malaysia to teach disaster management and some austere environment life support. Doon, iba-ibang nationalities yun. Ngayon, papuntang Ukraine. Then, papunta akong next, Taiwan. I think, November, Taiwan. To prepare there, baka daw gigira. Hala, sige. Masarap yun. So, ito makikita mo ngayon, pag hindi na-oxygenate yung brain, in a tropical country. So, ito yung na-release ng libro. Pero ang libro, ang author ng gumawa nito ay nakatira doon sa torrid zone, mga malalamig na lugar, na kung saan ay ang cellular protection ay mas okay kaysa dito. Maglagay ka ng karne doon ka sa malamig, doon ka sa Finland. Mag-iwan ka ng karne sa labas. At dito sa Pilipinas, ang karne sa Pilipinas na iniwan mo sa labas, mas madaling mabulok kaysa doon sa malamig na lugar. Ganon din yung brain. The brain or any body na pag nasa malamig, mas delay siya mag-decay. So, itong nakikita niyo sa slide ko, it does not follow. Kaya i-adjust ko. Wala akong statistika or data, pero i-adjust ko. Ang sabi dito, more than 10 minutes. Ibabagsak ko sa Pilipinas, ang sasabihin ko lang, more than 8 minutes. So, babawasan ko lang. So, wala akong evidence, pero to give justice, dahil tayo ay mainit na lugar, kaya mas mabilis mag-decay ang isang tissue na exposed. So 0 to 1 minute, tama yon. Cardiac irritability. 0 to 3, brain damage not likely. 3 to 5, brain damage possible. 5 to 8, brain damage very likely. So ganun lang. So 8 minutes ako, hindi ako nag-10. Now, in this picture, what happens to your heart if there's no intervention with compression and or with defibrillation and with defibrillation. So wala, tigok ka, 0. Dito, arresting rhythm, nag-ventricular fibrillation ka. Aba, may defib. So, meron certain percentage no, natsambahan. Dito may compression, late defibrillation, umangat siya ng certain percentage. Dito, na kompleto lahat, tumaas na. Kinumpleto mo lahat, actually hindi na yan 30%. In certain age category, it was found out na umakit ng 70+%. Wow! Ang galing. So that's from 16 years old to 16 or 20? 20 to 40 years old. Agad talaga ng 70. Galing. So defibrillator, ladies and gentlemen, is one of the greatest inventions of man. Yeah. Other than duct tape. Welcome to the interim guidelines of 2022. So 2022, wala namang pinagbago sa mga CPR mechanics. Merong ano lang na bawal na mag-mouth to mouth, face to mouth, face to mouth, mask to mouth na yun. Yan. So ang emphasis mainly ng 2022 interim guideline is kailangan naka-levels 4 and ano ba tawag nila? Levels 4 and 5. Levels 3 and 4. Kasi merong ibang merong hazmat level, no? Merong COVID level at saka merong MOP, military posture force, chemical, biological, radiological, nuclear, explosive. So dito tayo sa COVID, 3 and 4 yung ang 4 fully para ka fully enclosed ka or encapsulated. I'm not really encapsulated. We don't use the word encapsulated. You're fully closed. I mean, you're closed circuit ka nga, no? N95, naka-visor, whatever. Ang problema, nagbaba na tayo ng emergency level kaya medyo hindi niyo na ito ma-appreciate. Laging nahuhuli si libro. Pero sige lang, for the sake na kung nasa critical care unit ka, mag-practice ka pa rin ng mga kahit siguro maximum level 3 na lang to give justice to it kasi yung katawan natin kinakaya naman. But there are quite few surges para malaman nyo lang dito sa ospital ng Sampaloc. Mayroon silang mga tumataas na konting cases. So hindi naman mawawala yan. Parang si influenza, si Spanish flu, na-weaponize siya. Ayoko magsabihin kung weaponize si COVID, I leave that to your investigation. Basta sa position ko, akin lang yon, kasama sa position ng mga military doctors ng mga counterparts ko sa US, mga medic, sa amin lang yon. I will not say anything. Pero it will stay there forever. Kaya na ng katawan. Ganun naman ang katawan natin. Starts from the APC or antigen presenting cells, ipipresent niya sa mga natural killer cells natin, hanggang hinahinay, full ID na siya, then we can create our own soldiers for that specific antigen. So kaya na. Parang ganun din. Ang bilis nga ng vaccine, no? Wow. It's really a wow. Kung mag-aral kayo ng how to create a vaccine or medicine, 20 to 30 years yan, no? Grabe. Meta-analysis eh. Ngayon, boom, COVID, hindi umabot ng 2 years, may vaccine ka agad, no? Napapag-isip tuloy ako, bakit may mga ganong kaagad? So pala isipan. Versus, pag gumawa ng vaccine takes 20 years versus 2 years. Galit. Super genius na talaga tao. So yung unang kailangan malaman natin, naka-PPE ka. Dati, pag nag-BLS, maximum maximum 3. Maximum 4. Wala pa akong ACLS, maximum 4 ang mag-address. Ngayon, hindi na. Kung ideal meron kang airway, maximum 3. So nilimit ang personnel. Tapos, gamit tayo ng tamper. Yung, para wala na mag-compress, tamper na lang. Yung machine na oxygen supply. Siya, intrinsic machine. Siya nagpapasipiat. Pero again, sa tamang height lang kasi wala pang pang-baby na gano'n eh. So, tama lang na size, height, and weight requirement. Okay? So, yan lang yung full emphasis. Now, yung iba ay structural. Hindi na ako pwedeng makialam sa structural kasi madugo yan. Halimbawa, sa hospital, parang negative room ang style mo. Meron kang inlet ng hangin, gagawa ka ng wind corridor, may outlet. Hindi na ko compromise sa aircon. Yung aircon mo, hindi na ang filtration system. So may mga filters siya, mga HEPA filters. So yun, hindi ko papakialaman yan kasi baka magalit sa akin yung inyong logistics supply officer. Yung mga, lalo pag ibid pa, sablay na. So, ang isa lang, mamaya pag nag-ACLS kayo, makikita nyo, meron lang adjustment sa ACLS when it comes to airway management. Okay? So, hindi ko na yan. Ito yung mga interim guideline na ito yung deep dive niya. I will not read it to you. You can have my slides and you do your own reading. No? So, ito yung pinakabagong ACLS, BLS algorithm for basic life support and as a bridge into advanced cardiovascular life support. So, titingnan natin. Una, hindi scene survey. Dati, proceed survey. Ngayon, hindi. Or victim unresponsive, mga ganyan una. Ngayon, hindi. Don't PPE and limit personnel. So, kung merong exam at isasama yan sa exam, the first consideration in the algorithm of basic life support is always the two. Don't PPE and limit personnel. Yan. That is your interim guideline of 2022. 2020 siya ginawa, isiningit sa interim guideline of 2022. Yun. Okay. Bago ka mag-victim is unresponsive, activate cold blue, no? And then, before you start, pag-activate mo, pag-activate sa cold blue, meron tinatawag na, mamaya i-demo ko, yung tinatawag na, grabe, I lost the word, no? It's not override, it is parang merging, ganito yan. Pagtabik sa tao, hey, are you okay? Patient is unconscious, activate code blue, sisigaw. Pero pag activate code blue, habang sumisigaw ka, yung daliri mo ngayon, kasi healthcare provider ka, nakapunta sa, Tagalog ko, sablay, no? Bisaya kasi ako. Nandun na sa carotid. Pag carotid, code blue, bed number 2, code blue, bed number 2. Code blue, bed number 2, bed number 2. So yung nasa nursing station, code blue, bed number 2, surgical ward. Code blue, bed number 2, surgical ward. So, pag tawag ko sa code blue, kunwari ako yung tumatawag sa code blue, I am on the side of the patient. Code blue, bed number 2. So, kailangan nag-eyes to eyes, ang tawag doon shout distance, no? Or talk distance, takbuhin mo. Paki-announce diyan, tawagan ng operator sa bedside phone yan. Ang kamay ko ganun. Then my counting, depende sa haba, my counting will start at 3,000 or 5,000, depende sa haba. Pero pag nagtawag ka ng code blue, then you start at 4,000. 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000. Patient has no pulse, pakilagay ang bag valve mask muna bago mag-CPR. So, ang delay natin ay 3. Ito yung medyo delay. So, pagbasahin mo yung interim guidelines, may 3 delay. First delay, depende sa ng pasyente, sa bed, ibababa mo ang tinatawag na CPR platform. So, lahat ng bed, meron niyang lever. Depende kung makabago yung hospital bed. Lever na nakamarka doon, nakapula CPR. Pag ganun mo, hindi naman babagsak tagag. Bawal yun, no? Wait, gaganon na siya. Mabilis, wait. That's 1 delay. Number 2 delay. Kung nag-iisa ka lang, lagyan mo ng non-rebreather mask. Okay? Isa ka lang, non-rebreather. Pangatlong delay yan. Pangalawang delay, sorry. First delay is ibagsak wag sabihin ko word ibagsak, baka ma-misunderstand ako. Ibaba ang bed, head part, for a CPR ready configuration. Number 2, can somebody tell me what's number 2? Delay. Tingnan ko kung medyo sensitive kayo pag merong nag-a-arrest din sa hospital. What's the number 2 delay? So number 1 delay, pabagsak. Kasi ilang segundo niya, no? Sabihin natin 1 to 2 seconds, 1,000, 2,000. Second delay. Walang nakasagot. Cardiac board insertion. Boom! Ngayon, kung trauma pa yan, patay tayo. Assuming trauma, involving spine, patay. Paano kaya yun? Siyempre, di mo basta maano kasi pag nag-CPC ka dyan, clinic namatay yan, kunwari namatay. Pag nasilip dyan na namatay pala kasi merong involvement ng cervical spine, patay na tayo ngayon. Komplikado. Paano siya ngayon? So, grabing delay yun kasi hindi mo pwedeng iangat yung cardiac board kasi ano siya, titigala siya. Kung merong cervical spine fracture, di paano ang angat mo during CPR? Patay ngayon. Hindi mo naman pwedeng hindi mo lagyan ng cardiac board kasi pag nag-CPR ka, naglundog, gaganon din yung ulo mo. Grabing delay yun, no? Pangatlong delay is to put something. Kung nag-solo ka lang, non-rebreather mask. Pag may kasama ka, ilagay mo na ang bag-valve mask bago siya mag-CPR para sasaluin. Ngayon, ito ngayon ang pangit. Another bad news. Papalitan nyo na ang inyong bag-valve mask sa ospital. Bakit? Kaya ang requirement ng bag-valve mask ngayon ay dapat merong HEPA filter sa exhaust para yung exhaust ng pasyente, na exhale ng pasyente na aerosolized, matatrap doon sa filter. Hindi rin lilipad. So anong requirement pag nag-CPR? Meron tayong structural change. Ang structural change, dapat doon sa bed, meron siyang wind corridor. Higop, buga. Para walang matrap na microparticulates sa loob ng room. Parang semi-negative room. I hope you understand negative room. Ang negative room, pag pumasok ka, higop yun. Higupin niya. So meron pa siyang catchment. Hindi ka diretso sa isang room. Sa negative room, merong isang area na ano ka. Pagpasok mo, parang control area niya. So, diyan na magsisimula, no? And then, pasok ka. Itong dito, just to change your things or what. Pagpasok mo sa room, ready ka na. Tapos, puro siya negative. Higop lang siya, nagigop. Walang na, ano. Saan siya kukuha ng hinigop niya? Doon sa catchment area. Sa catchment area, meron siya konting pasok to drive the aerosol outside. Habang pagpasok ka, merong i-drive niya. Okay? So, airtight siya. Drive, pag lock mo sa loob, no? Bihis ka. So, meron siyang buga, meron din siyang higop konti para merong exhaust. Kasi, or else, magtutulak ka ng hangin sa loob kasi papasok sa loob. Pagpasok mo sa loob, parang there is papatay mo na siya saglit. Pug! Automatic. Tapos pasok ka sa loob, higop lang yun. Medyo complicated ang negative room. Sa atin, hindi tayo ganyan. Ang sa atin lang is wind corridor. So, higop konti, malinis na hangin. Hindi yung closed circuit. Sa aircon kasi kayo lumalamig, umiikot lang yung hangin eh. Ikot lang yung hangin, pinapalamig. Wala siyang, hindi siya humigop. So ito, meron siyang higop, palakasin mo lang yung aircon para hindi mainit. Tapos meron siyang outlet. Kaya ang lamig ng aircon, hindi mo makukuha kaagad kasi merong higop ng dumadaang hangin. Kaya kailangan malakas yung aircon. Very consuming lang talaga sa electricity. So yan po yung mga structural change na. Ngayon, nang chinek mo, kunwari, ang pasyente may normal breathing, may pulse, then observe lang natin, ano kayong dahilan? Bakit nag-react or tumawag ng ano? There's a distress. What if the patient has pulse, pero may agonal breathing? So, ginagamitan na nila ng bag-valve mask na merong filter, tapos tight seal talaga, ituturo ko. Kasi dito, nagkakamali. Doctor or nurse dito, nagkakamali on bagging. Meron talagang gano'n. Kasi hindi siya na-emphasize. So, one breath every 5 to 6 seconds. No? And then, along the way, you can already activate emergency response system. And then, you continue rescue breathing while checking pulse. No? Usually, nilalagay natin yan sa pulse ox or sa yung sabihin natin mga limb leads lang, cardiac monitor. So, habang nag-assist tayo. Ganyan lang. Pero ang ina-emphasize dito is a closed circuit system in a basic format. Ano yun? Tight seal. Letter C and letter E. Sa demo ko na ituturo yan. So, yan lang yung konsepto ng basic life support. So pag tawid mo dito, halimbawa, the patient has no pulse, no breathing, so you can start CPR. But before starting compression, begin cycles of 30 compressions and 2 breaths using bag mask device with filter and tight seal. Or you can continuous compression with passive oxygenation using face mask. Ang point dito ay para ang aerosol hindi lumilipad. So, hindi siya na deep dive. Ganito lang yan, ladies and gentlemen. Unahin mo muna yung, hindi ka nag-drive ng airway, patong mo ng airway. Pag patong ng airway, tight seal, compress. Hindi una ang boob bag, no? Compress. Doon lang siya. Pero nakabukas ang 15 liters per minute. Kung naka-mask siya, Hudson mask man yan or ideal is a non-rebreather mask, naka 15 liters per minute. Bakit? Ang hangin pumapasok sa lungs by virtue of recoil. Ang pumapasok dyan, pag naka non-rebreather mask at taas, umabot tayo ng 85 to 90. Pag bagbal mask, 90 to 95 yun. So, mabilis ang pag-heal ng, kung walang hangin, mabilis ma-oxygenate ang brain because among all organs in the body, the most sensitive to hypoxia is always the brain. Yan. So, employ ako ng CPR, and then si AED dumating, makikinig ako sa AED. So, ito lang gusto kong i-remind. Si AED ay may sariling mundo. So, pag binuksan mo si AED, dalawa yan, pwedeng through cover, magbubukas siya, or by virtue of yung power button. Pag nag-power button yan, hindi yan diretso compression. Unit, okay. Apply, patch. Pero compress ka na. Sige. Minsan, ito pang AD, ginawa ka pang totally grade 1. Unit, okay. Check responsiveness. Pero nag-compress ka na. Alam nga namang hinto ako, i-check responsiveness, tapos ako, huwag mo nang pansinin. Open patient's bare chest. Oh. Okay, sige, habang nag-CPR ako, inaanak, wag mong bitawan. Huwag kang huminto ng CPR para mag-open ng ano. Yung isang kamay mo, ang open mo, kung nag-isa ka, palit. Kung nag-isa ka lang, open. Huwag mo na i-open lahat. Kung wala, guntingin mo, mabilisan. Kung wala, puloy ka. Makinig ka lang, open bare chest, bitaw, gunting lang, isang lagaring, isang ganun, ito lang. Tapos tuloy CPR. Meron pa, ganito. Check responsiveness. Nag-CPR na ako. Call for help. Nag-activate ka na nga ng code blue, alang hinto ka pa. Mga ganon, no? So, depende sa AED, huwag mo nang sundin yun pag naka-compress ka. So, sundin mo na lang yung pagdating ng metronome. Ang metronome, ayun yung cadence. That's not the right English word. Yun yung count. Begin compression. Pip, 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 pip. O, yun ay sundan mo. So, kunwari, naka-head start ako ng 1 minute and 30 seconds, I will have another 2 minutes. Kasi yung pip, pip, pip na yan, 2 minutes yan. So, isipin mo, 3 minutes and 30 seconds ka. Kaya mo ba? Ito ngayon ang problema. Kasi lahat tinuturuan BLS, hindi ma-attain ang quality compression. Bakit? Ngal-ngal na eh. Kapagod eh. Karamihan sa mga healthcare providers, hindi nag-exercise. Walang exercise. Kasi ang tingin nila, may immunity sila sa wellness. Maraming healthcare provider na matay. Kahapon, pinag-usapan na natin, batang doktor, mas bata pa sa akin. 44 years old, patay. Kasayang. Yun pa naman yung mga taong kailangan ng society. Pero unang nangamatay. Yan. So kailangan may wellness din tayo. Kaya, galaw-galaw naman para hindi pumanaw. Galaw-galaw para hindi pumanaw. So yan mga nakakalimutan. Walang program on wellness para sa mga healthcare providers. Mahina tayo sa ganun. So, ayan. So after 2 minutes, sisigaw si AED. Analyzing, bitaw ka ngayon. Kasi bawal hawakan ng pasyente. Kasi pag nag-analyze yan, tinitingnan niya ano yung electrical activity of the heart. Kung, tingnan niyo sa slide ko, lipat ko lang ito. Kung, shockable ba or non-shockable? Yan. Assuming, shockable. Sasabihin ni AED, stand clear, shock advice, stand clear, shock advice, stand clear. So, iilaw yung gitna, yung may lightning. So, kung meron ka ng kasamahan, nagdating ka na, mag-chant ka. Pag wala, mag-chant ka pa rin para masanay ka. One I'm clear, taas lang ka. One I'm clear, okay? Siyempre, huwag ka mag-2 your clear. Baka isipin nila, sira ulo kasi yung kinakausap doon sa airway, nag-iisa lang siya. Clear, everybody's clear. Baka mga multo yung nakapaligid doon, no? Baka sabihin nila, meron ka hallucination. So, pag nag-isa ka lang, sigaw ka lang, one I'm clear, push the button, shock given. Depende anong utos ng AED. Continue CPR. Pwede ka mag-continue CPR. So, yan yung kabuunan ng ating basic life support in the aspect of compression and AED operation. Yan. So, ito lang yung algorithm. Pag tingnan natin sa slide, parang ang hirap. Hindi po. Hindi siya mahirap. Tingnan nyo lang, i-imagine nyo, pikit na mata ko. Una, ganun lang ang tingnan nyo ako. Una, don't PPE daw, leave it personnel. Assuming, nag-iisa lang muna ako kasi nasa peripheral hospital ako. Then, check responsiveness ng pasyente. Pag nag-check ka, may kakaibang check na yun. Pwede pa rin yung dalawa. Pero lalagyan mo na ng trapezius pins. Ganito po ang trapezius pins. So, tingnan nyo sa video yan. Isilin nyo yan. To elicit pain response. Trapezius muscle yan eh. I-pins mo. Hindi siya masakit pag gawin mo sa sarili mo. Wala. Pero gawin mo sa iba, sapakin ka talaga. Pero kung merong camera, hindi siya, hindi masakit sa madla. Pinagbabawal ang sternal rub. According to American Heart Association, bawal siya. Baka ma-technical tayo pag nag-sternal rub. Marami pang gumagamit ng sternal rub. Pero pinagbabawal na siya ng American Heart. Okay? Simula, I think, 2015 or 2010. Find it, try to look at it in history. Nakalimutan ko. Bago nag-COVID, alam ko bawal na siya. Bawal na ang Selix maneuver. Isa sa pinagbawal Selix maneuver. Bawal na yan. Marami nang pinagbabawal. So ano pa ba pag na-check, sir, tapos trapezius pins, that's one. Patient is unconscious, activate code blue. Paki-code blue dito, bed number 8, male ward. Male number 8, surgical ward lang, or whatever. Or psychiatric ward. Bed number 8, psychiatric ward, kunwari. Ganon. So, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000. Patient has no pulse, pero habang nagka-count ka, nag-iisa ka, pumosisyon ka doon kung saan merong lever. Ang lever kasi ambidextrous, two-sided yun eh. Boom, binaba mo na. So habang nagka-count. Yan yung tinatawag kong interfacing. Interfacing of trees. Para hindi mabagal. Kasi ang objective ng compression, nandun pa rin yung main tree. Push hard, push fast at 100 to 120 per minute. Number 2, adequate recoil. Although sa 2020 guidelines, pinagsama na yung dalawa. Push fast, push hard, push fast at 100 to 120 with adequate recoil. Number 2, avoid interruption in compression. Number 3, avoid hyperventilation. 4, shifting of the compressor every 2 minutes. Yan yung mga ganun kahit rundown. Hindi pa rin nawawala. Lalo na yung main tree. Push hard, push fast of 100 to 120, adequate recoil, avoid interruption. So, gagawin ko. So, pag patient is unconscious, activate code blue, bed number 2. Activate code blue, bed number 2, pero ang kamay ko, 4,000, 5,000, 6,000, binaba ko ng bed ko. Kita mo na, 3. 9,000, 10,000, cardiac board. Paano kung nag-solo ka, o sige, angat, insert cardiac board. Pakilagay ng mas, bilis, mas, starting compression, 1, 2, 3, 4. Yan. Okay, AD. Or sige, pilito, manual AD override. Puro nursing. Nurse, ayaw mo na mag-manual, AED override sila. Kaya pads, uy, mabalahibo pala si tatay. Ala, shave muna, shave. Pabilis, shave. Tuloy lang. Ready na ang magpalmas, converting to backal mask. Okay, standby, bitaw konti, kasi huwag ka mag-compress na hindi walang mask. Tanggal ang mask, palit ng bagbal mask, tuloy compression. Okay, 30, bigay ng bagbal mask na 1, 2, okay. Compress. Wala pa akong kapalit. No? Si Bagmal Mask, nandun pa rin. Shock advice, stand clear. Si Airway, papatayin niya ang Airway. Pero si Bagmal Mask, nakapatong pa rin sa, no? So, ang Airway, from 15, baba 0. Okay. Binigay ang shock, boom! Shock siya. Continue CPR. On si Airway, yung compressor, bago na. Compress siya. Umikot ngayon yung compressor doon na sa machine. Siya ngayon yung electrical therapy. Yan. Ganun lang. Ang palitan. Ang hindi pwedeng palitan si Airway. Ha? Kasi ang tawag natin closed circuit assembly, hindi na, kung si Airway na-contaminate ng COVID, siya kanya na lang. Hindi na pwedeng magpalitan pa tayo, nagka-COVID tayo lahat. Okay, this is for pediatric. No? And ito yung pediatric. This is the old one. Another old one, mga 2015. 2018 yata to. This is 2015. This is 2010. So halos walang pinagbago except lang yung speed. Dati 100, ngayon 100 to 120. Plus interim guidelines na kailangan may mask bago mag-compress. Ito luma na to. Most of them are still kung kaya niyong merong witness collapse, no? Witness the collapse. So depende pag child and infant. Pero dahil ito ay hospital-based, minsan hindi natin masusunod kasi meron namang bedside telephone. This is 2010. Okay. Itong role ng bawat rescuer or code blue team, no? Saka ko na yan. Ito yung insert sa 2020. So gumawa ng insert si what do you call this? Si American Heart. Kasi na-release na si 2020, biglang nag-COVID ngayon, di wala siya magawa. Gumawa siya ng insert. So it is supposed to be part ng sa libro. Pero sa online lang nila nilabas, pwede mo siya ipaprint para kung may libro ka, i-insert mo siya doon. Ito rin yung bago. Paano ang sistema. Ganon din. Now, that is why I'm not really an advocate of a mouth-to-mouth. Kasi matagal na to, I think this is before 2010. Ito yung gap. Pag maganda ang CPR mo, umaabot ka ng 140 to 160 millimeters of mercury pressure. So, pag maganda yung pressure, maganda yung oxygenation to the brain. Bigla kang huminto. Ayan yung black. To. Wala, zero. Zero oxygenation. Kahit pa nagbigay ka ng mouth-to-mouth, zero pa rin. Bakit? Hindi tumatakbo ang dugo. There's no oxygenation to the brain. That's the point. Okay? Itong choking na to, I'll do more demo. Although ngayon, ginawa na lang simple. Mild obstruction, makakarinig ka ng breathing, pero merong mga sound like wheezing, tapos maganda pa yung coughing. So, i-demo ko mamaya. Tapos mag severe obstruction, halos weak or no pulse. Minsan, hindi na wala nang air entry. No? Total blockade or merong little na parang kung meron, stridor na talaga. So dito na tayo mag-abdominal thrust. Dati ang tawag sa abdominal thrust ay Heimlich maneuver. Okay, so i-demo ko siya. Pero on the recent past, tatlong classification siya. Okay. May tinatawag na mild obstruction, ina-encourage ang cupping, stay on the side of the patient, enhance cupping. Dalawa makikita mo dito, mayroon tayong tinatawag na American Heart Association saka American Red Cross. Sa American Red Cross, mayroong back slap. Ang backslap, ginagamit natin sa child, hindi sa adult. Pero sa American Red Cross, meron silang backslap. Kasi baka merong train sa inyo, American Red Cross, magulat kayo, bakit walang backslap? Kanya-kanyang paningin yan. Siyempre ako, doon pa rin ako sa AHA kasi ang AHA, grabe ang research nila. Sila talaga yung sabihin natin, the totem pole. So, i-demo ko yan. Again, backslap, back blows, ginagawa sa American Red Cross. Sa American Heart Association, walang ganyan. Now, in the recent past, demo ko lang yun. Gumagamit tayo ng mild obstruction. Tapos, severe obstruction with poor air entry. And then, severe obstruction with total blockage. So, yung poor air entry, encourage breathing, merong slow in and then burst out. Hindi pwede, pag biglaan mo, di lalong masuksok yung, medyo nakakalito sa layman, ginawa na lang mild and severe, dinalawan na lang nila. Now, let's go into AED. AED operation. So, depende sa AED. Ang AED kasi, dalawa ang kanyang on and off. May AED brand na ang on niya ay yung lead. Pagbukas mo sa lead, unit okay. May mga, yung iba walang unit off. Ang Zol meron para malaman mo kung okay pang battery. Unit okay. Kasi nangyari yan sa akin, may nag-arrest ng pasyente, yung AED ko matagal kong iniwan sa sakyan, deplete yung battery. Nang inon ko siya, replace battery. Replace battery. Siyempre yung nakikinig tao, nag-arrest yung, buti lang may manual override. Pag manual override, yun, nagamit ko sa cardiac monitor at the same time na pag-defib ako. Sa manual override, pwede ka pa mag-defib ng last 10 fire bago ma-deplete yung battery. So, ganun ang nangyari sa aking defib. So, turn AED, tapos makinig sa voice prompt. Tapos, dalawa kasi ang makikita mo sa AED. Voice prompt, saka visual. Then you put the pads on the chest, dito sa sternum side, dito sa right, at saka sa apex on the left. Then, along the way, after instruction of CPR, it will tell you to analyze. So, titingnan ko ang rhythm ay shockable versus non-shockable. Pag it is shockable, shock is advised. So, ganyan lang. Okay? Pag may mga medication patches, tanggalin. Pag basa siya dahil nalunod, i-dry mo yung chest. Pag mabalahibo, ang AED, most AED may kasamang razor. I-razor na mabilisan. Pero habang nag-razor ka, huwag mag-delay ng CPR. CPR lang yun, habang nag-razor. Even sa paglagay ng pads, huwag huminto. Tuloy-tuloy lang yung CPR habang naglalagay ng pads. Ayan. Meron pag sa bata, yung iba sinasandwich harap likod. Sa adult, sternum and yung tinatawag na upper right chest, below collarbone, and then one goes to the lower left side of the chest. Okay. So, pag marami tayo, 3-level champ. One, I'm clear, nakatingin ako sa akin, sarili, na hindi ako nakatap sa patient. 2, you're clear, nakatingin sa airway. Kung sa totoong buhay, pag tingin sa airway, tinitingnan ko yung oxygen na kasino. Tandaan nyo, electricity yan. There are 3 things to start a fire. There must be fuel, there must be heat, and there must be oxygen. Eh, nag-spark. Heat yun. Oxygen. So, pwedeng yung materials, pwedeng for whatever it is, mayroong fuel pa. So, pwede tayo mag-start ng fire. Sabi ko sa inyo, ang fire mag-start even as low as 16%. Yung ating air, itong nilalagap mong hangin ngayon, 21% yan. According to Dalton's law. Pero, ang fire pwede mag-start as low as 16%. Eh, yung nasa oxygen lumalabas, no, via bagbal mask, nako, 90 yan. Ay, sabog kayo dyan sa loob ng ER. Kaya, one and clear, pagtingin sa airway, 2 year clear, be sure, hindi nakataas yung bag, ang mask nakataas, or else yung mga aerosolized, mga dagta ba tawag yan? Secretion, sorry. Secretion, dagta pala sa puno pa yun. Secretion, no? Pwedeng malipad, yan. So, naka-down lang yung mask, ng bagbal mask, tapos patay siya. 2 year clear, sasagot si airway, clear. Tingin sa lahat ng periphery ng pasyente. Everybody's clear. Sigaw lahat, clear, including si airway. Then shock. Yan yung 3-level chant. 1 and clear, 2 year clear, clear. 3 everybody's clear, clear. Then you apply shock. Okay? So pag-apply shock, ang AED, shock given. Check for pulse, pwedeng ganun. Or shock given. Continue CPR, depende kung anong instruction. Okay? Anyway, there are 4 kinds of rhythms na mababasa niya. Number 1, shockable rhythm, 2. Pulseless ventricular tachycardia at saka ventricular fibrillation. Then another 2 non-shockable rhythm, yung flatline natin, which is the asystole, at saka any abnormal beat na may mga wide QRS, whatever, parang it looks like a heart block, pero walang pulse. Ang tawag doon, pulseless electrical activity. And it's a non-shockable rhythm. So, pagbigay ng AED, hayaan mo na siya. Huwag mo siya i-turn up dahil nagbigay ng shock. Kasi magre-recalibrate ulit yan. So, just leave it be. Pero maganda sana, ang gamit nyo, yung may manual. Kasi professional tayo. Tawanan tayo ng mundo na ang ospital gumagamit ng AED sa loob ng ospital. So, every 2 minutes ang kanyang command on that. So, pag nagko-compress ka, 2 minutes rundown yun. Unless along the way, biglang may signs of life, nag-ROSC ka, return of spontaneous circulation, then no need to stop AED kasi ang AED hindi ang pusa magsashock. Makikita ko sa pelikula, no, ito nakakatawa, no? Hala, nasa ospital, nag-away, tapos ginamit yung defibrillator weapon. Number 1, it takes time to charge it. By the time nagsuntukan kayo, kinuha mong AED, pog! Ginanon mo, hindi totoo yan. Kasi mag-charge ka pa, i-on mo pa yung machine, hindi naman naka-on yan all throughout. I-on mo pa. Pag on yan, takes time, magre-recalibrate machine, tapos pag pindot mo sa charge, ting, kunwari, kasi maximum joules mo, 200. Ang mga bagong AED ngayon, 200. Oh. So, ilang suntok na, ilang saksak na umabot sa katawan mo bago gawin mong weapon. No? Katawan din yung mga tao na ginagamit weapon. Yung AED, meron pang isa, AED mismo, ginawang weapon. Hindi, ang AED po ay hindi yan magsashock. Kung gusto mo, sorry kung gusto mo mag-suicide, gamitin mo ayoko na sa mundo, gusto ko manang umalis, nilagyan mo sarili mo AED. Gusto mong magpakamatay, gamit mo AED. Mamamatay ka sa buwisit, hindi magpa-fire sa AED. Bakit? Because automated external defibrillator is only, can only deliver shock if the rhythm is a shockable rhythm. Naka-NSR ka. Paano shockable rhythm? Wala. No shock advice. Check responsiveness. Kasi nakaka-detect siya ng pulse. No shock advice. Check responsiveness. Lagi siya mag-check responsiveness kasi nakakaramdam siya ng tibok puso, nakakuha siya ng ang puso, maganda yung dynamics, hindi siya magulo. So, pag hindi siya no shock advice, yung button hindi talaga magpa-fire yan. AED and children, may mga pediatric pads at saka pediatric paddles. Pero sa AED kasi pads lang yun. AED and wet person, kailangan dry. I-dry natin bago mag-apply ng AED. AED and hairy chest, kailangan tanggalin yung hair. AED and pacemaker, hindi magkatamaan kasi ang pacemaker ay nasa upper left. Ang AED pads ay nasa right. At ang isa ay nasa lower left. AED and bra, basta walang metallic yung bra, no? Pwede mo putulin. Kung hindi mo lang paano tanggalin ang bra, putulin. Tapos, nakabulat-lat lang, lagay mo yung pads. AED and jewelry, okay siya. Unless ang jewelry sobra talaga, parang mga kadena na ano dyan sa katawan mo, tanggalin. No? Okay, so, nabanggit ko na. Now, let's go into naloxone. Sa naloxone, okay, sige, I'll give you 7 minutes break. It's 9:30. Sige, 7 minutes break muna kayo. Inom kayo ng kape. Naloxone na intranasal spray. So ito yung bago kasi because of overuse or intoxication, not intoxication, abuse of opioids and its derivatives. Respiratory depressant yan. And most often than not, it can result into cardiac arrest. So from respiratory arrest to cardiac arrest. So kahit gano'ng katikas mo mag-CPR, pag ang opioid and its derivatives ay umiikot sa katawan mo, hindi mo talaga mabuhay ang tao. Baka magtanong kayo, Pilipinas naman to, Dokted. Wala namang opium dito. Totoo yan. Pero dahil yan ay standard, susundin natin kasi sa manual ng BLS, nandyan yan eh. That's one thing. Yes, agree. Hindi natin kaya yung mga ganong klaseng droga, no? Doon lang tayo sa poor man's amphetamine, yung shabu, methamphetamine, pang mahirap, no? Gets no? Gayang-gaya tayo sa mga western style ng kanilang way of life na mabisyo. Hindi naman tayo ganun, yung mga ancestors natin, hindi naman tayo ganyan. Pero ginaya natin yung way of life. Pati sa abuse, hindi naman natin kaya. Anyway, so meron tayong dalawang klaseng gamot. Parehong intranasal spray. Ang tawag ko dyan, atomizer, tawag namin. Although hindi nakalagay dito. Isang Narcan, familiar tayo sa Narcan kasi meron tayong IV Narcan dito, saka isang Cloxado. So mataas lang ang dosing ng Cloxado kasi 8 siya, yun. So, actuation. Sa ano naman, sa Narcan, 4 ang max. No? Namatay. Naloxone, hindi siya considered advanced kasi ang advanced life support may IV. Ito wala tayong IV. Sinusuksok lang yan sa ilong. So, in-spray mo siya sa isang taong uh, merong suspected or known to have opioid overdose. So, meron siyang respiratory depression. It can lead into respiratory arrest. So, bigay natin kaagad para ma-reverse natin or else hindi natin siya mabuhay kahit mag-AED compression, AED compression. So yan yung kanyang mist. Kaya tinawag naming atomizer. Sinapakaliit ng kanyang spray. Mist yan. Lakas ng ulan. Grabe. So sinusuksok sa ilong, ganito ang forma niyan. Yan o. Ewan ko maintindihan drawing. Ito siya o. Ito yung driver. Suksok sa ilong, sa nostrils. Tapos pindot mo, yan, talabas yung mist. So depende sa you can ng presentation ng patient. You can do repeat dosing, but you have to ask MC or medical control para mag second dose ka. Dahil hindi uso sa Pilipinas, bigyan ko lang kayo ng highlight. Once you give naloxone, be sure to kung nasa pre-hospital nasa streets kayo although hindi yun ang jamming, pero meron lang kayong a little understanding. Kailangan may kasama kayong pulis. Kasi kahit ako lango ako dahil na opioid overdose ako. Tapos na-reverse sa naloxone. Binasag niyo yung trip ko, sinira niyo yung trip ko. Pahirapan ko pong kinuha yung opioid para ma-high ako. Ngayon, ni-reverse ninyo. Pwede kayo saksakin. Yan ang nangyari sa US. Kaya sa US, pag nag-a-address sila into overdose, may police na kasama. One, for legal purposes. Number two, pwede kang atakihin. Kasi wala naman sa pag-iisip yung mga nag-adik-adik na yan. Inisip nila, yung pala, arresting na sila. Hindi nila alam, mamamatay na sila. So, 2 to 3 minutes interval para mag-additional dose ka. Then you have to get guidance from your medical control. So, yun lang naman yung sa naloxone. Now, I'm gonna bring you into my world. American Heart Association published the 5C, 5C. Hindi ko po sinasabi magaling ako kasi sa akin 10C. Hindi po ito sa galing. Wala pong kinalaman yan. 5C, check responsiveness. Sabi ng Philippine Heart, check responsiveness. Call for help, compress. Check responsiveness, call for help. Cover with mask the face, the mouth and the nose. Compress, connect to AED. 5 yon. Pag nag-aral kayo under PHA 5, ako ginawa kong 10C para kumpleto. Okay? Ito yung out of hospital. Kasi hindi naman pwedeng tayong mga doctors or doctor nurse tayo, tapos sa hospital lang tayo, biglang may bumagsak diyan sa kapitbahay ninyo. Alangan namang sabihin mo, ay, 6:00 ng gabi na po, hindi na po ako pwede. Oh. Nung ikaw ay gumraduate sa nursing or medicine, yung mukha pangalan mo, binalandra ng pamilya mo. Nang pumasa ka sa board exam, binalandra ulit, di kilala ka ng community. Biglang may emergency sa community, patay ka ngayon. Kasi ang utak mo ay pang in-hospital. Kaya kailangan meron kang out-of-hospital talent or skills. So ito yung tuturo ko sa inyo. Number 1C, pag nag-responde or nakakita ng victim, number 1C, consider it to be COVID positive. Yan. Ingat. 2, magpakilala ka. Ang tawag namin dyan sa incident command system, check-in. Kung ako rescuer, hindi ako pwedeng, kunwari, may rescue sa Pampanga. Hindi ako pwedeng dediretso sa Pampanga. Magre-report ako doon sa IMT, Incident Management Team. Magpapaabiso ko, oy, ako po ay si Kulasa, member ng Rescue 1 International. Paano ba kami makatulong? Yan po ang tawag yan, check-in. So ginamit ko lang yung word na check-in dito. Mag-abiso ka sa community kung sino ka para to create a formality. Sa legal medicine or sa ethics natin, kasama yan. Yan yung consent. So kahit implied consent ang mangyari doon kasi arresting yung pasyente, pero meron kang informed consent sa community. Ay, ako po si Ted, rescuer po, baka po makatulong. Ang word sa Pilipinas, baka po makatulong. Huwag kang magsabi totally makakatulong ka. Kasi iba ang paningin ng Pilipino sa ganyan. Kung namatay yan hanggang pagburol, dapat bayaran mo. Or na-hospital yan, na-ICU, bayaran mo. Nag-promise ka, tutulong ka. So sa kultura hospital, sir, sa rescue po ako, baka po makatulong. Ano po nangyari dito while you approach the pasyente? Number 3, siyempre ang Pilipino, around the world, osyusero. Nagyera na doon sa Iraq, ang mga Pilipino na OFW, nandun sa ibabaw ng building, nanonood ng gero, lumilipad yung missile. Kung sumabog, mga srapter, magliparan papunta sa'yo. Hindi magawa, osyusero talaga ang Pilipino. So, ayoko naman na napaligiran ako ng sakatutak ng taong osyusero, baka naman may COVID doon, magiging super spreading event yon. So, pwede ko sabihin, sir, bigyan niyo ako ng hangin, pinakmagandang way, hangin. O, mag-distance yan. Hangin lang po, luwang lang, luwang. Yan. Yan yung pinakapahit kasi habang ginagawa mo yon, ang mga cellphone nakalabas, kinukunan ka. So, crowd control yan. And then 4, check hazard. Anong dahilan bakit siya bumagsak? Nasagasaan ba yan? Nasa gitna ka ng highway? Huwag ka sa gitna ng highway yung CPR. Baka ikaw naman sunod masagasaan. Nakuryente ba yan? Huwag ka dyan. Baka ikaw yung sunod makuryente. So ano yung dahilan? Nasa gitna ng init? Nag-collapse? Because of whatever is nag-MI because of heat trigger. May mga taong ganun, no? Ang reporting sa Pilipinas mali. Namatay daw siya sa heat stroke. Hindi. No. Hindi namatay sa heat stroke. Kahit mainit yan, bumagsak ka dyan, hindi yan heat stroke. Kasi ang heat stroke, hindi ka mamamatay kaagad. Pamali-mali pa tayo mag-diagnose. Pero inintindi ko na lang kasi hindi uso ang environmental emergency sa Pilipinas. Kaya hindi sanay. Nagkataon po, hindi naman ako genius. Nagkataon ng specialty ko, wilderness medicine. Kaya alam ko ano ang heat illness pag-manage noon sa field. Only in the field. No? So, I can deep dive into heat stroke versus heat exhaustion. Number 5, diyan ka na mag-check for responsiveness sa topic. And then, trapezius pains. If the patient is unconscious, call for help, which is number 6. No? Then, cover with mask and nose or clip mask, cover with mask and nose. Cover with mask the nose and mouth of patient. Kung sa pre-hospital, para pag CPR mo, hindi lumalabas yung aerosol. 8, compress. Okay. So 100 to 120 per minute. Then 9, kung mayroong AED, wow, connect to AED and follow voice prompt. And then, ginamitan ko ng number 10. Kasi nung kasagsagan ng COVID, mahirap kumuha ng ambulance. Katulad dito, merong nadisgrasya, hindi nakakuha ng ambulance. So, kumuha kami ng pick-up. Ang tawag po dyan, case evacuation. Case evac. So, yan. Kasi walang ambulansya. So, pwedeng sa tricycle. Kaya nagtuturo ako paano mag-CPR sa tricycle. Ganyan. So, yan po yung ating field CPR. There is a buzz that in basic life support, kailangan alamin natin paano ma-prevent yung stroke. So, ang sinama ko na ID, hindi ko ma-prevent. Ang pag-prevent ng stroke ay nandoon pa rin kanina sa yung mga modifiable traits, sa non-modifiable traits. Pero how to identify? So, ginamitan natin ng Cincinnati Pre-Hospital Stroke Scale. Cincinnati Pre-Hospital Stroke Scale. Ano ibig sabihin noon? FAST. Yan po yung Cincinnati. Pero dinagdagan nila ng dalawa. BFAST. So, hindi na siya purely Cincinnati. Parang it's a modified Cincinnati. Plus. Yan. So, BFAST ang tawag nila. Number 1. B, loss of balance. Suddenly, biglaan, may nawala ang balance. Another B, behavioral change. Sudden, all of a sudden, parang nangyari dito na parang blunt, no? Tapos irritable. Yun pala, merong minute stroke. And or, hindi pwedeng nandiyan na. Behavioral change, saka loss of balance, saka brain fog. Ano yung brain fog? Parang, sir, nakatingin lang sa'yo, sir, anong name niyo? Hindi niya makuha, naglingo-lingo lang siya, yun pala, meron ng stroke doon na nagpo-progress. So yung B, tatlo yung B. Balance, loss of balance, brain fog, and or, behavioral change. And or, blurring of vision. Hindi naman lahat ng stroke may blurring of vision. And or, facial asymmetry. Bumagsak yung isang gilid ng muka. And or, arm and leg weakness on one side. And or, slurring of speech. So, and or lang lahat yan. It does not mean na pag may stroke, present yan lahat. Then, consider the time. Please, bring it to the hospital. Ito po ay, kaya ang tawag Cincinnati Pre-Hospital Stroke Scale, kasi pang outside the hospital. Okay. So, ganyan lang ang pag-ano natin sa stroke. So, usually sa BLS book, hindi nabigyan ng emphasis. Pero merong, natutunan ko rito nung attended ako ng Maritime Emergency sa Singapore. They were discussing about this as incorporated in basic life support. So this is a patient I did a medevac from kasagsagan ng COVID from Dumaguete to Manila para kasi may AV malformation. Kawawa na bata. Pero nabuhay naman. Sige siya seizure, status epilepticus na nabuhay. So, interim guidelines, yun lang yung natin, yun yung pagbabago ngayon. At kailangan alam natin, ito kasi pang ACLS na. Dati, sa BLS, airway, compression, defibrillator, team leader. 4, ngayon 3. Siyempre walang IV meds kasi advanced cardiovascular life support. Sino ang team leader? Ang team leader can be nasa compression, defibrillator, or airway. Kaya sa training, pare-pareho tayo para you can command. Ang pagkakaiba lang din, si compressor, pag-compress, habang nagko-command si AED, analyzing. Pag-analyzing, itong si defibrillator, tatakbo dito sa pupunta kay compression. Shock advice. Pag shock advice, kasi dapat ang defibrillator ay nasa left side palagi. Left side. Kasi pag nag-manual ka, maganda ang lapat ng paddles when you're on the left side. Kumpara pag when you are on the right side. Kasi nga sa apex, on the left yung apex. So si defibrillator na, yung dating kompresor, siya yung magkukuman sa warang clear, to your clear, 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 sisigaw to si airway sa kasi compressor ng clear. Until pag dumating na si code blue, mag-start ka na ng IV. Kung marami ng mag-start ka ng IV, ang ACLS ngayon, maximum 4 lang din. Saan si team leader? It's either compressor or defibrillator. So, ganun ang ating assembly. Kasi sabi ng interim guideline, dapat konti lang yung tao. O, ito yung ideal na pre-pandemic. Pero ACLS configuration. So, kailan ako hinto ng CPR? So, merong mnemonics na stops. Ano yun? S, spontaneous return of breathing and circulation. Kung nasa out of hospital, i-recovery position natin. Sa atin, hindi. Hindi tayo nag-recover. Case-to-case basis. Sa atin, dapat ito ay nasa ICU or CCU. Intubated na dapat. Yun ang ating mga tipong expectation. Na after, biglang biglang spontaneous return of breathing or circulation, it does not mean na step down. Obserbahan pa rin yan. Kung nasa ICU, obserbahan pa rin natin. Pwedeng i-extubate siya, pero it takes time. Titingnan lang muna. Transfer to higher level of care. Siyempre, ikaw, kunwari, nurse ka, tapos dumating ang doktor na ang maghawak, ibigay mo na. Unless, sabihin niya, tuloy niya lang, mag-oversee lang ako. Then, ituloy niya. Operator is exhausted. Ito yung sinasabi ko kanina, kailangan galaw-galaw para hindi pumanaw, kailangan tayo mga responder, malakas din. No? Then, physician's advice, siyempre, doktor yan, o sabihin ng physician, terminate na, wala na tayong magawa. And then, yung S, scene becomes unsafe. Anong ibig sabihin nun? Kunwari, nagsi-CPR ka, tapos may sumabog na oxygen sa kabilang ward na sunog, masusunog ng ospital, CPR ka pa rin. So, you will evacuate muna. Okay? So, ganun ang style. Stops. What if you break a rib? Anong patakaran? So, under sa Article 12, Paragraph 4 sa Revised Penal Code, any person who, while performing a lawful act with due care, causes an injury by mere accident without fault or intention of causing it. What do I mean with that? So, sa jurisprudence nakitaan na ikaw ay trained, pero sa kasamang palad may na-break na it's a circumstance, but it will exempt you from criminal liability. We will be subject under investigation. Pero kung nagawa mo naman lahat, sakto ka, you know what to do, hindi ka makakasuhan. I mean, you will be exempt from criminal liability. Okay, so 85 to 90% of arresting patients will show ventricular fibrillation. Ibig sabihin yung heart nagkirig-kirig, kirig siya. Yun. So, treatment line natin, drug, no, kasi ACLS. Shock, CPR, shock, CPR, shock, CPR, CPR, shock, CPR, shock, pero lang. So, this person nag-collapse, live to. He is a surgeon, nag-proficiency swimming, naligo, bumagsak sa toilet. So, nung naabutan ko, tinawag ako, arresting heart siya, nag-start CPR ako. May sarili kasi akong AED. Kinabit ko sa AED ko, nag-shock ako, CPR, tapos drive adrenaline. Kasi meron ako sa sasakyan, drug, CPR, biglang nabuhay. Pagbuhay na, biglang nag-arrest ulit, tuloy. Nabuhay ulit pag second round, tuloy-tuloy na siyang nabuhay. So recovery position, dinala sa Tondo Hospital yata yun. So nakashock ako dalawa, totally nakabawi yung heart niya. Pinadala ko lang kasi baka yung hemodynamics mabagal pa. Nangitim yung dibdib. Pinakasuhan niya ako kasi nangitim yung dibdib niya. So namatay siya saglit, nabuhay siya, pero pinakasuhan niya ako kasi nangitim yung dibdib. Kung nasa US or Canada ako, makakasuhan talaga. Kahit binuhay ko siya, kakasuhan talaga. Yan yung reality. So, hindi naman napustro yung kaso niya kasi kinausap siya ng mga counter-terrorist unit na binuhay ka na nga. So that's one of the lessons na natutunan ko na defibrillator is I have my own, kaya uh, dito sa bahay, kampante ako na meron akong gamit. And number two, you have to do it properly, pero may mga bagay di maiwasan. Katulad dito, na nangitim yung dibdib sa defibrillation sa CPR. So pwede kang balikan. Wala tayong magawa. That's the price we have to pay. Pero sa Pilipinas, hindi pa uso yan. Kapag nasa US, madadali tayo. Now, nabuhay siya. Tapos, just 2 weeks ago, galing akong, well, Bacolod. Yeah, Bacolod. I was in the airport and this guy approached me. Kayo po si si Sir Esguera. Ay, yes po. Sabi niya, ako si, kalimutan ko pangalan niya. Special Operations Group ako, Special Forces. Kayo po kasi bumuhay sa bunkmate ko. Kasama niya sa kampo. Bunkmate. Si Sosya. Sosya apelyido. Sabi ko, sino doon? Yung nasa PR niyo, yung term niya, kinurientehan. Parang anong isda, kinurientehan. Sa madaling salita, nagpasalamat siya. Sabi niya, kumusta siya ngayon? Okay naman, retired na, nagpapahinga. Na operahan din sa dibdib na stent yata. Or what. And the guy, that patient did not thank me. His friend thanked me. Sabi niya, sir, I saw your effort and I give you my salute first. Tapos narinig ng mga kasamahan ko na speaker kasi ako sa DRR ng Bacolod. Kasama ko sa airport. Sabi niya, grabe doc, no? Sabi niya, sabi ko, yeah, mga hindi ko alam na somewhere along the way, nakalimutan ko. And here it is. So, the lesson here, ladies and gentlemen, I need you to learn this, not because it's a compliance. Remove it because it's a compliance. Ni-require ng DOH kasi. Kailangan matutunan yan kasi pag may bumagsak dyan sa pamamahay ninyo at hindi nyo nabuhay, mahirap patawarin ang sarili ninyo. Tandaan niyo. Kailangan make it personal to you pag natuto kayo ng basic life support. It is because your family might need it. And your family knows what to do. Turuan nyo rin sila. Parang ako, yung mga anak ko, kayo professional na, itong mga anak ko, maliit pa yan. Nag-heart attack yung mother-in-law ko. Ang nakabuhay, mga anak ko. Huwag niyong sabihin na, sila nag-defib, sila nag-CPR, sila naglagay ng oxygen. Hindi yan doktor, hindi yan nurse. Tandaan niyo. It's because it's a life skill. Kaya I don't want you to consider it na, compliance. Forget it. Always learn life skills because it is between death and you. Diyan nakasalalay kung ano mangyari sa family niyo. So make it personal to you. This learning, make it personal. Not because your director wants you to have it. It is because your family might need it. And there you are. In the middle of life and death is you. Your skills, your wits, and your strength to save your family. Now, if you are good in saving your family, ladies and gentlemen, it's easy to save the world. Yan lang ang prinsipyo sa buhay. Turuan ko muna ang bahay bago ko turuan ang mundo. Okay? So, that's the end of my slide. Give me around 12 minutes to prepare the dummy and I'll do demo. So, pwede namang, you can, if you have question, you can ask questions bago ko, kasi nasa kabilang bahay, dadalhin ko pa rito. Question? So, walang tanong. Mag-ayos kasi ako ng, magdadalawang camera ako para two-way yung style na panood natin. Magbubukas lang ako ng isang so walang tanong.
Recording in progress.
Okay. Sorry. So kung walang tanong, kunin ko lang yung mga gamit. I'll start with airway. Liwanag. Masyadong maliwanag. Yan. For one, paano ang system on bagging? So meron tayong tinatawag na cyclone. This is a valve mask. Yan. Ang valve mask dapat nakakabit sa oxygen tank release at 15 liters per minute. Ano ibig sabihin? Yung kanyang yan. Hindi ko na makikita. 15. Ito na, kabit siya. 15 liters per minute. No? Bago mag-compress, ay nakakabit. So, apex, base. Apex is to the nose. Tapos letter C and E. Itong E ay nasa brim. Brim. Ano na? Dito sa kabilang brim. So, tanggalin ko si mask. Ang position niya dapat ganito. Brim. Dito sa margin, bony margin of your mandible. Tapos ito C ay nakasil. Tapos, naka-hyperextend. Okay, hyperextend. Para pag naka-hyperextend ako, nag-lock yung aking esophagus. Okay? Esophagus. Pag nag-lock yung esophagus, because may ipit siya, pag nag-hyperextend, may ipit siya ng cartilaginous cricothyroid cartilage, mapupush posteriorly against the anterior surface of your cervical spine. So may ipit sa esophagus kasi sa esophagus wala siyang cartilage. So hyperextend, pug. So sarado na and you can drive. Sorry, dami kasi ito kaya medyo hindi na-hyperextend. So ito yung single approach. 1,000, 2,000, 3,000, 4,000, 5,000. 1,000. Huwag masyadong manggigil buong baga. Do not hyperventilate. Ganun lang. Yan lang. 1,000. Kailangan nasa 600. 600, pag lalaki 700 ml. No? Kung dalawa kayo nagbabag, which is not encouraged sa interim guidelines, dapat single lang. Pero kung dalawa, pwede kang hahawak. Iba ang nagbabag, dalawa yung kamay naghahawak dito. Dalawang. Tapos, hyperextend. Pag nasa field katulad ko, pwedeng ipitin ng dalawang yan. Dalawa. Ipitin ang noo. Ipitin. Tapos, neck lift, head tilt, neck lift. Lagay ito, bag. 1,000, 2,000, 3,000, 4,000, 5,000. Bag. Ito, nasa mandible. Rim, no? Sa bone. Huwag sa gitna kasi mabablock by impede yung airway. So, dito. 1,000, 1,000, 2,000, 3,000, 5,000. 1,000, 2,000, 3,000, 4,000, 5,000. Yan. Ganyan. Ngayon, pwede tayo gumamit kasi basic life support, pwede tayo gumamit ng airway adjunct. So, ano yung airway adjunct? Mayroong tinatawag na oropharyngeal sa nasopharyngeal. Si oropharyngeal, katulad dito smooth bore, smooth line, Gedel. Itong stellate, ang tawag, Berman. So, dito tayo sa oropharyngeal, una, bago gamitin, susukatin muna natin. Galing sa lobule ng ear hanggang sa tip of the mouth, dito, sa corner of the mouth. So, color-coded siya, katulad dito, kanyang-kanya. Akma na kanyang-kanya ito. So, insert natin sa isang unconscious individual. Ang requirement nito, totally unconscious siya. Kasi pag partly conscious siya, iluluwa niya. Okay? Lagay. Ito, air channel. Shaft or shaft. Ito, channel. Shaft. Sa middle ng shaft, dyan tayo mag-twist. Itong color-coded is the back. Nandito, pag-fix natin para ma-display yung pang, tapos lagay na sa loob, then we can start the bagging. Ito lang umayos. Sa bag. Bag. Okay. Yan. We can also have a nasopharyngeal. So, nasopharyngeal, ganun din ang sukat. Ito medyo mahaba lang, hindi ko pinutulan. Hindi ko naman putulan yung kunting. Huwag na. Mahaba siya. Dalawa ang sukat dito. Yung haba, nasa lobule pa rin ng ear. Nasa lobule pa rin ng ear. Pero, kailangan yung fifth digit, ganun kakapal. What do you call this? The external diameter. So, assuming sukat na siya, pag insert nito, actually, hindi pwedeng ganun. Kailangan ganun ang insert. No? Ganun. Pero dahil dami ito, allow ito insert. Dapat meron, bago ka mag-insert, meron petroleum jelly. So, wala akong petroleum jelly. Ang forma nito, ganito na. Ang maganda naman ito, pwede natin siya ibigay, i-insert sa partly conscious or even a conscious individual that needs airway support, basic. Kaya ito yung meron ako karamihan. Nasa lahat ng bag ko, lahat ng bag ko, first aid kit. Meron talaga yan, meron talaga siyang airway. So yan. Okay, so dalawang sukat dito at saka yung external doon. Bago mag-bag. Yan. Okay. Now, but unless you have any question, you just write it in the chat box. Sabi ko muna to, dali ako over dito. Now, let's go into airway obstruction. So, ano yung sa airway obstruction? Ano yung kailangan gawin? So, numero 1 is, alamin natin anong klaseng airway obstruction meron siya. If it's mild obstruction versus severe obstruction. Ang severe obstruction, mayroong very poor air entry sa total blockage. So, doon tayo sa mild. Pag merong mild, may indicator, no? Bata man yan matanda, patient is in distress. Lalapitan natin, we offer our help, facilitate coughing. Breathing, slow breathe in, and then cough. Ang cough, tapik sa likod. Dito. Nasa side naman ng patient, pasensya ka na, natanggal yung mga dummies ko. Ito, dummy po yun. Para lang ang ulo hindi hiwalay. Nilagyan ng tali. Kasi yung mga dummies ko, hiniram ng United States Special Operations Command. I have lots of dummies. Ginagamit nila, nagtitraining ng mga sundalo sa West Philippine Sea, sa Batanes. Grabe. 7 dummies, 8 dummies nasa kanila. Naiwan sa akin. Ito pa yung may sira. Anyway, sa gilid ako ng pasyente, I'm on the side of the patient. I'm on the side. Sir or ma'am, ubo po. Hinga. Slowly lang. Sige lang. Slowly. Sige. Ubo. Hindi pwedeng sa harap ako. Kasi ayaw ko pa ubuhin sa harap. Cup. Yan. Hindi slap. Kundi tapik lang. Konti. Sige. Cup. Good. Cup. Sige lang. Ganun siya. Sige. Sige ma'am. Sige. Hinga. Sige. Buga. Hinga ulit. Hinga. Very good. Buga. Sige. Hinga. Lapit ka. Tingnan mo kung may sound. Ubo mo. Ganon. Sige lang. Iko, konti. That's all you can do. What if the patient has poor air entry? Distress talaga, hawak yan dito. Or hahawak sa'yo. Pag humawak yan sa'yo, ang tawag yan, sense of doom. Parang mamamatay na siya. So, pag hindi na talaga makahinga, position ka. Dito ka ngayon sa likod ng pasyente, yung binti mo, dapat nasa gitna ng dalawang paa niya. Nakatayo kaming dalawa, para in case pag matumba siya, slide down lang siya. Okay? Slide pa atlas ka, mag-slide. Okay? Position yourself here. 2 finger breaths. Bigay mo to. Point of the 2. Papunta sa scapula niya. 45 degrees up. Okay? Sige, hinga. Sige, iubo mo. Sige, sabay ganun. 1, 2. Grabe, luha-luhain tao. Nakailang ganito na. Yan. Tapos pag lumampas, very good. Pero pag lumabas, no, tapos nasuka siya, hilap siya, paupuin mo lang, huwag mo kagad painumin ng tubig, baka hindi pa niya makuha yung cadence, aspirate siya. Karamihan, pinapainom ng tubig. Huwag. Hinga lang malalim. Sige, hinga malalim. Sige, hinga. Okay, hinga. Yan. So, ulit kung hindi na, what if the patient becomes unconscious? Then, we perform basic life support. So, lagay siya. Lagay na natin. Down. Down, easy. Down, easy. Then, tapik. Tingnan yung tapik, ha. Pag ako, nandito ko sa left side ng pasyente, merong tapik na left to left. Left to left. Left of the patient. Or right to right. Right to right. Yan. No? So, mas malayo ako, ang mouth ko mas malayo sa mouth mo. Or nose. Pwede pa rin ganito, pero ito variation. Kapit, sir. And then trapezius pinch. Ito, tingnan nyo paano mag-trapezius pinch. Yan. Trapezius pinch, yan ha. Yan. So, masakit po yan. Pero kung gawin nyo sa sarili ninyo, hindi yan masakit. Ipagawa nyo sa iba, masakit yan. So, kung kunan kayo ng video, hindi siya very aggressive tingnan. So, ayan. Alin, ulit. So, tapik. Sir. Hospital ako. Patient is unconscious. Lagay ang tama ito, daliri. Activate code blue. Slowly, pag nag-command, activate code blue, bed number 2, surgical ward. Code blue, bed number 2, surgical ward. 4,000, 5,000, 6,000, 7,000, 9,000, 10,000. Ngayon, pag 10,000, mabilisan, nababa ko na yung lagay ng cardiac board. Pasensya na kung hindi sasangayan ang dam. Kasi, syempre, rigid ang dami. Cardiac board, tapos non-rebreather mask. Kuha lang ako non-rebreather mask. Ay kung magbukas ng bago, kuha ko luma. So, si non-rebreather mask ay naka-attach sa oxygen 15 liters per minute. So, ito po si non-rebreather mask. Meron siyang reservoir, meron siyang mask, one-way valve, natanggal na yung valve. Okay, kakabit ko siya. Pasyente, yan. Bago ako mag-start, mag-CPR. So, nakakabit na, open 15 liters per minute, CPR. 3, 4, 5, 6, 1, 0, 1, 2, 3, 2-0, 1-2-3. Kailangan may breathing in ka. 3-0. Walang 30:2 kasi solo ka pa lang. Tuloy lang. Until may dumating na kasamahan mo, may airway ka na. So, okay, stop mo na. Palit siya ng bag valve mask. Okay. So, may kasamahan ako. Siya nagbabag mask. Hirap naman walang kasamahan. Kunwari lang, meron. 1, 2, 29, 30. Bigay siya ng dalawa. 1 and 2. Ngayon, dumating si AED. So, tuloy-tuloy pa rin. Huwag ka maghinto ng kompresyon. Okay? Katulad dito, Zol pads to. Lagay sa AED. No? Tuloy lang. Si Zol pads, merong sensor sa gitna. Sapawan mo lang yung sensor ganyan. Patong to, tanggal to, didikit sa katawan. Itong apex, didikit. Katawan. Yan. Tuloy-tuloy. Biglang sabi ni AED, analyzing. Bitaw ka. So, ito si AED. Dalawang klaseng AED, yung isang lead activated saka button activated. Ito, button activated. Yung iba, pagbukas ng lead, unit, okay, apply patch. Ito, hindi. I-push mo siya. So there are 3 buttons sa modern AED. On and off button, pediatric mode, para mag-shift siya into pediatric mode. Saka, fire, yung shock. So naglagay na ng pads, biglang sabi ni AED, analyzing, bitaw. Shock advice, stand clear. So, 1 and clear, habang nagta-charge siya. 2, you're clear. Clear, sisigaw si airway, nakapatay ng clear. 3, everyone is clear. Yung ibang kasama, sigaw, clear. So, pindutin ko ngayon. Shock given. Check responsiveness. So, pag check responsiveness, hindi si airway mag-check. Ako mag-check. 1,000, 2,000, 3,000. Or check pulse. Still no pulse. Tapos pag sabi din siya, after 10 seconds, continue CPR. CPR. Yung magsi-CPR na, panibagong tao na naman. 30, bigay ng hangin. 1 and 2. 30, 1 and 2. After 2 minutes, analyzing. Palit na ng tao. Papalitan na. Shot advice, stand clear. Yung nag-compress kanina, siya yung magkakuhan. 1 and clear. 2 you're clear, away. Clear. 3 everybody's clear. Clear. Indot shot. Boom. Shot given. Check for pulse. Yan. 1,000. Uy, may pulse na. 2,000, 3,000, 4,000. Yan. Nasaan na yung, ano natin? Nasaan na yung cardio? Nasaan siya? O, send na to sa ICU. Kung ayun yung mag-ACLS doon sa ward. ICU or wherever. Or bypass ER kung ayun sa ward. So, depende sa internal protocol mo. So, ang mangyayari, compression, AED compression, 2 minutes interval. So, sa 2 minutes, kakain ako ng 30 is to 2 na 5. So, ganyan lang ang mechanics ng CPR. Ang kailangan lang sa CPR, huwag niyo lang guluhin ang sarili niyo. So, yung iba nagsusukat ganyan na importante, ang pinaka-safe is kilikili. Yan, yan. Interlaced, straight ang braso. Straight ang elbow. Tapos, huwag sa gilid. Walang puwersa. Kailangan ang puwersa ay nasa shoulder. Ganyan. Okay? And then, hindi jerking. Hindi jerking. Ganyan talaga. Kailangan ang compression natin nasa 2 inches deep. Dito. Ganyan kalalim. Para mapansin nyo na maganda ang compression nyo, tumatapon po yung tiyan. Ang tawag, bawat presyo, tataas yan. Kahit pa flat abdominal yan, flat abdomen yan, makikita mo sa sayaw yan. Yan yung makikita nyo yung good CPR. Yan. Okay? Straight. Wag ganon. Mapapagod kayo. Pwedeng interlace, pwedeng ganyan. Okay lang, basta carotid CPR, pwedeng isa. Kung bata. Pag baby naman, same approach, except thumb lang. Kung wala kang cardiac board, pwede ito ang cardiac board. Hawakan mo, dito ka sa occiput, gano'n. Hawak. Post compress. Okay? 120 pa rin. Choking for baby, same. Baby, wala, nakikita mo noon, nangingitim. Tapos, merong, pwedeng sabihin na nanay, may check. Pag may nakitang obstruction, tanggal, do not blind sweep. Pag sa tingin mo, wala, uy, you may start, depende sa pabor, yung iba, magsisip pa. Yung mabilisan, hawak, kailangan naka-clip dito, ang papunta sa'yo, kung hindi hospital, para tatakbo ka papunta sa tricycle. No? Pag ganun, ang hawak. Compress mo 5, 1, 2, 3, 4, 5, hawak dito sa mentum. Ganyan. Laylay, yung back slap. Ganun. 1, 2, 3, 4, 5. Hawak ulit. Ganyan. Slide. Or, ganun. 1, 2, 3, 4, 5. Pero kung gusto mo mag-CPR running, tinatawag kong running CPR, papunta sa tricycle o sa sasakyan. Ganun mag-CPR. Laylay to. Ito ang cardiac board. Ito. Cardiac board. Laylay yung paa. Ang pata naka-incline sa'yo. Nakaganon. Malabong ganon. Sa dami, madaling gawin. Pero sa totoong buhay, hindi mali. Kasi ang ulo niya, huhulog. Naku po, masisira ang cervical spine. Kaya ito, isi-swing out. Ang tawag nito, chicken wing formation. Ganyan. Mahirap po ito, mabigat. Patakbo. 1, 2, 3, 4. Pagdating sa salakyan, kung nasa kotse, compress ko lang, tuloy-tuloy. Pagdating sa kotse, dito ka sa lap. Hawakan to. Nakaupo sa kotse sa lap. Ganito. Yan. Hawak. Press lang. Okay? Ngayon, dahil bata to, kamag-anak ko or anak or what, pwede ka mag-mouth to mouth. Hawak, angat lang, ito, bunganga sa ilong, 1, 2. So ito yung revision nila, hindi minention gaano ni American Heart, pero sa Arizona, kasi bata siya, just to jumpstart. Balik ulit,
1, 2, 3, 4, 5, 6, tuloy-tuloy lang, papunta sa ospital. Okay? Ganyan lang ang style pag pre-hospital care. Sa hospital, sa platform lang. Sa bed or sa any, kahit sa cardiac board ng adult, lagay mo lang, tuloy-tuloy ka lang. Tapos, infant or neonate na bagbal mask, 1 and 2, tira ka per 2. Hanggang darating yung mga NICU staff mo na code blue for NICU. Pang neonate man yan o pang infant. Okay? Yes. Wala akong pang ano ng naloxone, kaya hindi ko ma-demo yung naloxone, pero doon sa picture, andun siya.
Question. Any question? Walang tanong? Okay. So you will have your exam, and while taking your exam, there will be a video show. No? Papakita sa inyo. It's not yet new. Hindi pa siya masabi natin under the interim guideline of 2022. Kasi wala pa ako makitang video na available for interim guideline. Panoorin nyo lang. Pero yung pinaka-latest, yung lecture ko, there's not much discrepancy naman except na more on the PPEs or personal protective equipment lang yung in-emphasize ng interim. And then yung bilis. Yung ano kasi, sa AED dapat naka-format yan ng 2020. Yung AED binabago yan. Para yung metronome mabilis. Tit, 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 yan ang 120. Okay? Unless magaling ka na, kahit 2015 pa yung AED mo, pero pag magaling ka, hindi mo sinusunod yan. Kasi ang 2015, ganyan, tit, 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 tit. Ang 2022, tit, 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 yan. Okay? Ganun lang naman yung adjustment yan. Okay? Dinadala yun sa bioengineering. Pero, I want you to watch it while taking your exam. And, for those who will take ACLS, I'll be seeing you at 1 o'clock in the afternoon. For those who will, you can, I don't know how, paano kayo invite Ma'am Joy, but if you don't have any question, I wish you the best in your exam. And thank you for advocating WIPAM. So medyo sanay lang kami sa virtual, but we can conduct it face-to-face naman. Except na medyo logistical nightmare if we need to fly to your location, lalo na pag PHDLS. So I'm an instructor for WIPAM, and at the same time, with the help of WIPAM, I'm with American Safety and Health Institute. Formerly, I was an instructor of American Heart Association. California registry talaga ako for basic life support, advanced cardiovascular life support, pediatric advanced life support, and neonatal resuscitation program. I did not renew because una, mahal talaga ang ahas. Saka wala na akong plan mag-apply ng trabaho. Why would I need to, you know. So nagtuturo pa rin ako pero informal lang until sa WIPAM, kinuha nila ako and they made me instructor for us. So I'm honored. Just in case you have any questions or verifications on aspects of CPR, if you cannot post it right now, wala pang lumalabas sa utak ninyo. Well, you can find me in Facebook. Makikita niyo ako, naka-flight uniform ako. Merong isang saying on the wall. So ako yun. Kasi may mga accounts although hindi naman ako sinisiraan. Pero iba yung accounts, pero pangalan ko, mukha ko, pero ang nagmamanage iba. Hindi naman ako sinisiraan. Mayroon na mga accounts na lumilitaw na actually it's not. I only have one active Facebook. So, yun lang yung naka-flight suit ako. You can push your questions there and I'll find time to answer because that's how people contact me also. Or else you can push it to WIPAM forwards it to me and we'll get back to your concern ASAP. Marami kaming courses. We have basic life support, advanced cardiovascular life support, basic trauma life support, wilderness. We have quite a number of courses na medyo timely din siya for new normal challenges. Okay? So, best wishes in your exam, and I'll be seeing you this 1 o'clock if you intend to pursue advanced cardiovascular life support. Okay? Back to you, Ma'am Joy.
Thank you so much po, Doc. Hello po, good morning po. I-send ko po sa meeting chat yung BLS exam po. Ayan, nasa meeting chat na po yung BLS exam. You can take your exam na po. Then, I'll be playing some videos po. You can watch it po while taking your exam. Thank you po.
Basic life support, or BLS, is emergency medical care provided by first responders, healthcare providers, and public safety professionals to persons experiencing respiratory or cardiac arrest or an obstructed airway. It requires knowledge and proficiency in cardiopulmonary resuscitation, or CPR, use of automated external defibrillators, or AEDs, and techniques to relieve airway obstruction in patients of every age. This BLS training program is intended for healthcare providers and other public safety professionals working in a wide variety of occupational settings, in and out of hospital, and individuals enrolled in healthcare and public safety career courses. The purpose of this BLS training program is for participants to gain or improve knowledge and skill proficiency in high-quality CPR skills for the adult, child, and infant. This training program will allow you, the BLS provider, to learn and practice skills according to your experience and in the context of your setting, utilizing different practice methods such as video-guided and scenario practices. Cardiac arrest is the loss of the heart's ability to pump blood through the body due to inadequate or absent cardiac function. The most dramatic occurrence, sudden cardiac arrest, or SCA, can happen anywhere with little or no warning.
It was a beautiful, sunny, warm July 31st, and Lynn, my wife, and I had gone grocery shopping.
It was otherwise kind of a typical summer day.
We were unloading the groceries. Lynn and I schlepped some in, and then I went out to get the rest.
We can tell by retracing my steps that I had put some things in the pantry and was headed back out to the car, but I never made it because I went down.
Was only gone about 60 seconds. In that small amount of time, my world changed. I turned over on her back, and her face was turning blue, and I heard these sounds like she was trying to breathe. Sound like she was gasping for air. And it's a sound you just don't want to hear your wife have. You just don't want to hear that sound.
How did you think?
Hello? Hi, I need an ambulance right away.
At what address?
I dialed 911 right away, and I put the phone down next to her and proceeded with the chest compressions and the breaths.
It's my wife. She's turning blue. She's turning blue. I gotta give her CPR.
Is she breathing?
No.
Okay, lay her flat on the ground with nothing under her head. Do you know how to do CPR?
Yes, a little bit. Okay, I'm pushing.
When the call came in and we heard the information, it was a cardiac arrest. If I knew that the crew was not here, they were out training at another station. Knowing it was a cardiac arrest and the importance of getting there quickly and starting care, myself and the battalion chief made the decision to respond to that.
Is your door unlocked?
Yes, I'm right in the
Many
living room
minutes went by while I was administering CPR before I heard sirens outside.
I entered through the front door and I was able to see CPR being performed in the living room.
I found her laying on the floor.
Quickly encouraged the husband to continue doing CPR and push hard and push fast on the chest.
No, I found her. She was loading groceries from the car into the house. She was helping load them. And then I found her just like this. Please check the pulse. Keep going, push hard.
These last moments of my opportunity to give CPR, and that's how I regarded it, was a great opportunity to actually participate in the rescue. My neighbor, who's a physician's assistant, heard the sirens and she came over to see what was going on.
As I was putting the AED on, the patches, the neighbor identified herself as medically trained.
Yeah, you know CPR? No, yes, I'm a PA. Hey, go.
I asked her to go ahead and to relieve the husband from doing chest compressions at that point and had her start performing CPR.
So she hopped in there to take over because I was kind of freaking out. I mean, right now, even thinking about it is really bringing back the memories. It was terrifying. I felt helpless. I mean, it was now all in their hands. I had done all I could do.
Analyzing heart rhythm.
After analyzing the rhythm of the patient, the AED identified that it was a shockable rhythm, and we delivered a one shock. At that point, I went ahead and took over CPR compressions, and Annie started giving airway assist. And after giving CPR for about a minute, I noticed Lynn starting to make noises with my chest compressions.
I asked him, "Do you have a pulse?" And he said, "Yes, we have a pulse." And I tell you, that was a beautiful sound to hear that.
So we stopped doing chest compressions and we continued breathing for her. That's when the crew, the paramedics, and the firefighters were coming through the front door. And I was able to then step back and give a report to the lead medic that was coming in and that was going to do the transport.
And they got my heart started again, loaded me onto the gurney, and rushed me to Corvallis Samaritan Regional Medical Center, where they continued to save my life. When I woke up, they had put posters on the wall in front of me, and it was very orienting. It said, "Kent called 911, did CPR, he saved your life. You're at Corvallis Good Samaritan Regional Medical Center."
The CPR being performed by the husband was huge. I'm sure it was probably 2 to 3 minutes. And during that time, if CPR wasn't being performed, that's 2 to 3 minutes that she's not receiving blood. A lot of things went right for this call and for Lynn, the chain of survival.
So it was a team effort, a chain, and that includes our dear neighbor, Annie.
Learning CPR, knowing how to do it, and then actually doing it are really important because you can literally save somebody's life.
BLS providers play a key role in the resuscitation effort following cardiac arrest, both out of hospital and in hospital or clinic settings. By training and practicing, BLS providers can help ensure the links in the chain of survival are strong in any setting for every patient. In order to clearly demonstrate high-quality skills, BLS providers in this training program may not always be shown wearing appropriate personal protective equipment. Local medical protocols are emergency medical service treatment guidelines approved by the local EMS medical director. Local protocols outline the permissible medical treatments that may be given by EMS providers outside the hospital to patients experiencing a medical emergency. EMS providers should always follow their local physician-directed medical protocols.
so sweet. I'm kidding. Marcus, you need to come here, move to Eugene, go to the university.
Think about dropping out.
Sudden cardiac arrest occurs when the normal electrical impulses in the heart cause it to beat too quickly, inefficiently, or in an unsynchronized manner. When the lower chambers of the heart beat too quickly or quiver, the heart cannot pump blood. These abnormal heart rhythms, or dysrhythmias, are known as pulseless ventricular tachycardia and ventricular fibrillation. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen. A victim of SCA may suddenly collapse.
Grandpa, hey, stay with me. Hey, I need some help. Grandpa, stay with me. Grandpa, don't.
What's going on? Is he okay?
I don't know, he just fell out. I need you to call
Occasionally,
911, please.
SCA victims will experience 10 to 20 seconds of seizure activity when the brain
Hey, I need
stops
some help.
receiving oxygen.
Hey, I need some help.
Normal breathing stops. Abnormal gasping may last for several
I have no
minutes.
clue what happened till he just fell down.
Okay. Let's get his back. Can you hear me? Sir, can you hear me? I have one person down in the main lobby. He's unresponsive. Start me 911, get an AED. We'll start CPR. He's not breathing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
CPR is the immediate treatment for suspected SCA. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions, an open airway, and rescue breaths. However, CPR alone is not enough. The most effective way to end pulseless ventricular tachycardia and ventricular fibrillation is defibrillation.
Remove clothes from patient's chest.
Using a defibrillator and electropads adhered to the chest. An electrical shock passed through the chest can restore the heart's normal contractions.
Analyzing heart rhythm. Stay clear of patient.
Immediate, high-quality CPR and early defibrillation with an AED can more than double the likelihood for survival. These two elements are parts of the adult chain of survival, a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 adult chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of early recognition of cardiac arrest and prompt activation of EMS, immediate high-quality CPR beginning with chest compressions, early defibrillation with an AED when indicated, effective advanced life support treatment, effective post-cardiac arrest care at a hospital, and recovery. The adult out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest, prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR beginning with chest compressions, prompt defibrillation when indicated, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. The majority of cardiac arrests happen at home or in the workplace. Early recognition of SCA and activation of EMS or an emergency action plan gets help coming right away. Immediate high-quality CPR improves the victim's chance of survival by providing oxygen to the heart and brain. After activating EMS, an untrained layperson should provide chest compression-only CPR, ideally with their phone on speaker mode and with the assistance of an EMS dispatcher. Attaching an AED as soon as it becomes available speeds up the time to defibrillation if indicated. Effective advanced life support treatment with a focus on return of spontaneous circulation, or ROSC, and transport to a hospital for all patients with a chance of survival supports the most favorable outcome. Effective post-cardiac care, including monitoring and the use of medication, helps prevent the return of cardiac arrest and improves the likelihood of long-term survival. Recovery supports the patient's physical and emotional needs that are ongoing after hospital discharge.
BLS providers should follow the adult BLS procedure, a step-by-step guide for responding to a potential adult cardiac arrest. The adult BLS procedure is a process composed of tasks that can be performed in a step-by-step manner by a single BLS provider or performed simultaneously by multiple providers working as a team. There are three main elements of the adult BLS procedure: assessment of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. As a single BLS provider, upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. This includes taking standard precautions. In this program, take standard precautions means use appropriate personal protective equipment, or PPE, to protect against possible exposure to infectious agents. Appropriate PPE may include gloves, goggles or face shields, surgical masks, gowns, respirators, CPR masks, and bag mask devices. Experience putting on and taking off PPE, also called donning and doffing, is critical for your safety and to minimize potential delays in emergency treatment. Train and practice according to local medical protocol or your healthcare facility's established PPE procedures. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
Sir, sir, are you okay?
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. After activating, get an AED and your emergency response equipment, or if someone else is available, send them to get it. Simultaneously assess breathing and the carotid pulse. Place 2 or 3 fingers in the groove on the patient's neck, between the trachea and the muscles at the side of the neck. Look at the patient's chest and face for signs of normal breathing. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, snoring, or gurgling sounds are known as agonal breaths. This is not normal breathing. It is a sign of cardiac arrest. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then, take action based on the presence or absence of normal breathing and pulse. If the pulse is not felt and the unresponsive patient is not breathing normally, or only gasping, immediately start CPR, beginning with chest compressions.
1, 2, 3, 4, 5, 6, 7, 8.
If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway.
High-quality CPR is the primary influence on survival from cardiac arrest. High-quality chest compressions are the foundation of high-quality CPR. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. When chest compressions stop, blood flow decreases significantly. When compressions start again, it takes several compressions to restore blood flow. The more times chest compressions are interrupted and the longer the interruption, the less the blood flow to the brain, heart, and other organs. Minimal interruption improves blood flow. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, immediately start CPR, beginning with chest compressions. CPR should be performed where a victim is found as long as it is safe to do so. To deliver adult chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. Place the heel of one hand on the center of the chest, on the lower half of the breastbone. Place the heel of the other hand on top of and parallel to the first. Interlock your fingers if necessary to keep them off the chest. Alternatively, you can place one hand on the center of the chest and use your other hand to grasp your wrist for support. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Push hard and deep, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. Chest compressions are most often performed too shallowly. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position, but do not lose contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Push fast. Compress the chest at a rate of 100 to 120 compressions per minute. CPR feedback devices transmit information on compression rate, depth, and recoil. Providers can significantly improve chest compression quality by adjusting technique based on data from a feedback device. Using a CPR feedback device is shown to improve patient outcomes and is recommended during CPR training and in real-life resuscitation attempts, both in and out of hospital. Fewer and shorter interruptions in chest compressions are associated with better outcomes. Time spent during a resuscitation attempt without chest compression, called hands-off time, should be kept as short as possible. Chest compression fraction, or CCF, is the proportion of time that chest compressions are performed during a cardiac arrest resuscitation effort. Higher CCF percentages are associated with high-quality CPR and greater rates of survival. A CCF of at least 60% is recommended, but higher percentages are desirable and achievable.
Rescue breathing is an artificial ventilation of the lungs. It provides oxygenation of the blood and removal of carbon dioxide. It is an important component for successful resuscitation. Conventional CPR with rescue breathing should be performed by all BLS providers, both in and outside the hospital. To give rescue breaths, there must be an open airway. The airway is the only path for getting air into the lungs. When an unresponsive patient is lying flat on their back, decreased muscle tone and the pull of gravity causes the back of the tongue to obstruct the upper airway. The tongue is connected to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat, relieving the obstruction and opening the airway. Two methods to open the airway are the head tilt chin lift and the jaw thrust. Use the head tilt chin lift maneuver to open the airway of a patient when head or neck injury is not suspected. To open the airway with the head tilt chin lift maneuver, position yourself at the patient's side. Place one hand on their forehead. Place the fingertips of your other hand under the bony part of the lower jaw. Near the chin, apply firm backward pressure on the forehead while lifting the chin upward. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Leave the mouth slightly open. If the BLS provider suspects a spinal injury, open the airway using a jaw thrust without head tilt. To open the airway with a jaw thrust, position yourself at the patient's head. Place one hand on each side of the patient's head. Place your fingertips under the angle of the lower jaw and lift it upwards until the lower teeth are higher than the upper teeth. If the patient's lips close, use your thumbs to push the lower lip open. An open airway is a higher priority than protecting a possible spinal injury. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. Both the head tilt chin lift and jaw thrust maneuvers should be performed correctly and quickly to minimize interruptions in chest compressions.
Rescue breaths are critically important in BLS care, as they provide life-sustaining oxygen and ventilation directly to the patient's lungs. In addition to SCA patients, BLS providers are likely to provide care for victims of respiratory arrest and secondary cardiac arrest, for whom effective rescue breaths are essential. Rescue breaths are given by blowing the BLS provider's exhaled air into the valve of a CPR mask, or by pushing air into the lungs through the airway using a bag mask device. Gasping in SCA is common but is not normal breathing. If the pulse is not felt and the unresponsive patient is not breathing or is gasping, immediately start CPR, beginning with high-quality chest compressions. After 30 compressions, open the airway and give 2 rescue breaths. Perform cycles of 30 chest compressions and 2 rescue breaths. In respiratory arrest, breathing has stopped, but the heart continues to beat. This is a life-threatening medical emergency caused by diseases such as pneumonia or other conditions such as stroke, choking, drowning, and drug or alcohol overdose. If rescue breathing is not provided during respiratory arrest, the patient's heart will stop within minutes. This is secondary cardiac arrest. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 6 seconds or 10 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. Check the pulse about every 2 minutes. If the pulse is not felt and the unresponsive patient is still not breathing, immediately start CPR. Excessive ventilation, too many breaths or breaths that are too large, can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Air in the stomach can also cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the patient's chest rise, but no more than that. Take standard precautions when providing adult rescue breaths. Use a CPR mask or bag mask device in addition to other appropriate PPE. Some CPR masks and bag mask devices allow you to attach a high-efficiency particulate air, or HEPA, filter to provide further protection during CPR. The HEPA filter fits between the valve and mask, in the path of the patient's exhaled gas. HEPA filters can trap airborne virus particles. BLS providers can give rescue breathing using their own exhaled breath and a CPR mask. Room air contains about 21% oxygen. Exhaled air contains between 16 and 17% oxygen. This exhaled oxygen is enough to support life. To use a CPR mask, position yourself at the patient's side. Place the Mask flat on the person's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your other hand, lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Lift the patient's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of the chest, but no more. Stop ventilating as soon as you see the chest rise. Remove your mouth and let the patient exhale. A bag mask is a handheld device used to inflate the lungs. The device consists of a bag attached to a face mask. BLS providers can give rescue breathing using a bag mask and room air. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. To use a bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use the remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise.
An automated external defibrillator, or AED, is a portable computerized device that is simple to operate. It can identify pulseless ventricular tachycardia and ventricular fibrillation and deliver an electric shock to restore the heart's normal contractions. If the electric shock is effective, there will be a return to spontaneous circulation, or ROSC. The heart will be able to pump blood, and the patient will have a pulse that can be felt by the BLS provider. The patient may also start breathing, moving, or reacting in other ways. If you have an AED in your workplace, be familiar with its operation. AED design varies by model and manufacturer, but they all operate in a similar manner. Proper AED operation requires direct contact between the pads and the patient's skin. Any clothing in the way must be removed. This includes swimsuits, bras, and any other clothing covering a patient's chest. If necessary, cut through clothing with the shears that are typically included with a CPR and AED response kit. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice prompts and readies the device for use.
Plug-in pads connector.
Use adult AED pads for patients 8 years or older. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each according to the pictures. Press the pads firmly in place. Avoid placing pads over medication patches or implanted devices. Try to apply the pads within 30 seconds after the AED arrives. When the AED voice prompts you,
Do not touch patient.
clear the patient. Be certain that no one is touching the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If the AED advises a shock, it will prompt you to clear the patient again.
Clear. Press flashing button.
If directed by the AED, deliver a shock.
Shock delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR,
Do not
the AED will prompt you again to analyze the heart rhythm. Follow the voice prompts.
Do not touch patient.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
James?
Oh, you know, kids.
James?
Busy doing it.
Are you out here? James? James? James! James! Oh no! No! Somebody help! Somebody help me! James! James! James, honey! James! James!
What happened?
I don't think he's breathing.
Oh, come on.
Call him. All right, help me get him to the ground. All right, James. Come on, James. Gently, gently. All right, gently. Okay, come on.
Hello? Yes.
All right, watch out.
We had a kid drown in the hot tub.
James. James, can you hear me?
Sudden cardiac arrest in children is not typical, but it can and does occur in children of all ages. More often, though, cardiac arrest in a child results from asphyxia, a lack of oxygen caused by respiratory failure or respiratory arrest. When breathing slows or stops, it leads to bradycardia, a slow heart rhythm of fewer than 60 beats per minute. At that rate, the heart is not able to pump enough oxygen-rich blood to the body. The lack of oxygen causes the heart to stop within minutes. Causes of respiratory failure or respiratory arrest and subsequent cardiac arrest include airway obstruction, lung infections or diseases, drowning, choking, and shock resulting from injuries, such as motor vehicle accidents, burns, falls, and child abuse. Prevention is critical in reducing pediatric cardiac arrest deaths. In the out-of-hospital setting, prevention includes the use of essential safety equipment, such as child passenger safety seats and bicycle helmets, and proper supervision. In the hospital, cardiac arrest prevention focuses on early recognition and treatment of at-risk children. In this BLS class, a child is defined as 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. For those with signs of puberty, provide adult BLS. Like the adult chain of survival, the pediatric chain of survival consists of a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 pediatric chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of prevention of causes of cardiac arrest, respiratory failure or respiratory arrest, prompt activation of EMS, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care at a hospital, and recovery. The pediatric out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens. So the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest. Prompt activation of the emergency action plan and response by teams of medical professionals. Immediate high-quality CPR and defibrillation. Advanced resuscitation. Effective post-cardiac arrest care. And recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. one that is seen or heard, or an arrest that occurs when the patient is connected to a heart monitor. If the sudden collapse of a child was witnessed, you may assume that the child has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Activate EMS or your facility's occupational emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in children is most frequently caused by asphyxia, about 2 minutes of CPR is recommended before leaving the child to get an AED and activate EMS. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival.
As in the adult procedure, high-quality chest compressions are the foundation of high-quality CPR. To deliver child chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. For child compressions, place 1 or 2 hands on the center of the chest. For a small child, 1 hand may be enough. For most children, the compression technique is the same as for the adult. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Whether you use 1 or 2 hands, push hard, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position without losing contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruption in chest compressions.
As with an adult, there must be an open airway to give rescue breaths to a child. The 2 methods to open the airway are the same: head tilt, chin lift, and jaw thrust. Use the head tilt, chin lift maneuver to open the airway of a child when head or neck injury is not suspected. Rescue breaths are extremely important for children because cardiac arrest typically results from asphyxia. If the pulse is definitely felt, but an unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 2 to 3 seconds, or 20 to 30 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Excessive ventilation, too many breaths, or breaths that are too large can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Take standard precautions when providing child rescue breaths. Use a pediatric CPR mask or bag mask device in addition to other appropriate PPE. Use a child-sized mask as you would for an adult. Position yourself at the patient's side. Place the mask flat on the child's face, with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Tilt the head and lift the chin to open the airway. Lift the child's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. Pediatric bag mask devices are available in child and infant sizes. Select a child-sized bag mask. To use a pediatric bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise. Check the pulse every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR.
Most AEDs are designed for both adult and pediatric use. The energy level of the shock for pediatric use is reduced from the standard adult energy setting. The shock is reduced by an electronic device called an attenuator, which frequently comes with pre-connected pediatric pads. The attenuator may also be built into the AED and activated using a button, key, or another type of switching mechanism. Pediatric pads are recommended for children below 8 years of age. If the child pads are not available, use the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Do not apply child pads to patients 8 years of age and older because the energy level of the shock will be too low. Turn on the AED and bare the patient's chest.
Remove all clothing from patient's.
If there is a button, key, or another type of mechanism for switching to child use, activate it.
Child mode.
Peel the pads from the backing sheet one at a time and place each according to the pictures. Some pads require a front and back position. Others require a left-right position. Press the pads firmly in place. Do not allow them to touch each other. When the AED voice prompts you,
Do not touch patient.
clear the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If directed by the AED,
Everyone clear.
be certain that no one is touching the patient.
Press flashing button.
Deliver a shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR,
Do not touch patient.
the AED will prompt you again to analyze the heart rhythm.
Analyzing heart rhythm.
Follow the voice prompts.
Press flashing button. Shock delivered.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
In BLS, an infant is defined as younger than 1 year of age, excluding newly born infants. Like the child BLS procedure, there are 3 main elements of the infant BLS procedure: assessment of the scene and patient, actions based on the presence or absence of normal breathing and pulse, and use of an AED. First, assess scene safety. This includes taking standard precautions. If the scene is safe, Assess responsiveness. Gently tap the victim and ask loudly.
Are you okay?
If the infant is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. If you don't have a mobile phone nearby, bring the infant with you to activate. Simultaneously assess breathing and pulse. Check the infant's brachial pulse. Place 2 or 3 fingers on the inside of the upper arm, midway between the elbow and shoulder. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly assess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. If the sudden collapse of an infant was witnessed, you may assume that the infant has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Quickly return to the patient, use an AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in infants is most frequently caused by asphyxia, 2 minutes of CPR is recommended before activating EMS or your facility's emergency action plan if you haven't done so already. As with the adult and child, there must be an open airway to give rescue breaths to an infant. The 2 methods to open the airway are the same: head tilt chin lift and jaw thrust. Use the head tilt chin lift maneuver to open the airway of an infant when head or neck injury is not suspected. Keep an infant's head in a neutral sniffing position. Tilting the head beyond a neutral position that results in hyperflexion or hyperextension may block the airway. Rescue breaths are extremely important for infants because infant cardiac arrest typically results from asphyxia. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Air in the stomach can cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see chest rise. Take standard precautions when providing infant rescue breaths. Use an infant CPR mask or bag mask device in addition to other appropriate PPE. Use an infant-sized pocket mask in the same manner as you would for an adult or child. Position yourself at the patient's side. Place the mask flat on the infant's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Tilt the head and lift the chin to open the airway. Maintain a neutral sniffing position. Lift the infant's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. To use an infant bag mask device as a single provider, select an infant-sized bag mask device. Position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger of one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Maintain a neutral sniffing position. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Check the pulse about every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, or there is no pulse, start high-quality CPR. There may be a rare or extraordinary circumstance when a barrier device is not available, and a BLS provider is willing to provide artificial ventilation without a barrier. For infants, the preferred technique is mouth-to-mouth and nose rescue breathing. To give mouth-to-mouth and nose rescue breathing to an infant, open the airway with a head tilt chin lift. Take a regular sized breath and place your mouth over the infant's mouth and nose, creating an airtight seal. Give enough air to make the chest visibly rise, but no more than that. If you have difficulty making an effective seal over the mouth and nose, try using the mouth-to-mouth technique.
As in the adult and child procedure, high-quality chest compressions are the foundation of high-quality infant CPR. To deliver infant chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. For infant compressions, use one of 3 hand position techniques: the 2-finger, 2-thumb encircling hands, or the heel of one hand. For the 2-finger technique, place 2 fingertips in the center of the infant's chest, just below the nipple line on the lower half of the breastbone. Do not press the tip of the breastbone. Use both fingers to compress the chest. For the 2-thumb encircling technique, place the pads of both thumbs side by side in the center of the infant's chest, on the lower half of the breastbone. Your thumbs may overlap on very small infants. With the fingers of both hands, encircle the infant's chest and support the back. Use both thumbs to compress the chest. For the heel of one hand technique, place the heel of one hand on the center of the chest, on the lower half of the breastbone. Position your shoulder directly above your hand and straighten your arm to lock your elbow. Use the heel of one hand to compress the chest. This technique may be useful for larger infants, or when the BLS provider has difficulty compressing to the appropriate depth using fingers or thumbs. Whichever technique you use, push hard, straight down, compress the chest approximately 1 1/2 inches or 4 centimeters. This depth should be at least 1/3 of the diameter of the infant's chest. At the end of each compression, allow complete chest recoil. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruptions. pediatric pads are recommended when choosing AED pads for an infant. If pediatric pads are not available, choose the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Turn on the AED and bare the patient's chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Peel the pads from the backing sheet one at a time and place each according to the pictures. The front and back pad position is common for infants. Press the pads firmly in place. Make sure the pads do not overlap or touch each other.
Not touch patient. Analyzing
When the
heart
AED
rhythm.
voice prompts you, make sure no one is touching the patient.
Everyone clear.
If
Press
directed by the
flashing
AED,
button.
deliver a shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions.
Choking, also known as foreign body airway obstruction, can occur when a solid object, such as a piece of food or a small object, becomes stuck in the upper airway. The person cannot breathe. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop out the obstruction. Chest compressions can also create enough pressure to expel a foreign body airway obstruction.
I'm exhausted.
To provide the appropriate care, you must be able to recognize the difference between a mild and a severe airway obstruction. With a mild obstruction, the patient can speak and cough. They may wheeze between coughs. A mild obstruction is typically cleared naturally by the patient through forceful coughing.
Cough it out. Come on.
If the person can inhale and exhale, encourage the patient to continue coughing. Watch for signs of the airway obstruction becoming severe.
That was scary.
Morning, Chrissy. How are you feeling?
Much better.
I need to get another set of your vital signs.
When a severe airway obstruction occurs, the patient cannot get air in or out of the lungs.
Are you choking?
This is a life-threatening medical emergency. If the foreign body is not removed, the patient will quickly become unresponsive and suffer a secondary cardiac arrest within minutes. Signs of a severe airway obstruction include the inability to speak, a weak cough, or no cough at all. The patient may make a high-pitched noise when trying to inhale or make no sound at all. They may hold their hands to the throat.
Try and get your breath.
If the patient is an adult or child, ask, "Are you choking?" If the person nods yes or is unable to speak or cough, act quickly. If you are not alone, have someone use a mobile device to call 911 to activate EMS or activate your facility's emergency action plan. Stand behind the patient. If needed, kneel behind a child. Reach around and locate the navel. Make a fist with the other hand and place it thumb side against the abdomen, just above the navel and below the ribs. Grasp your fist with the other hand. Quickly thrust inward and upward into the abdomen. Repeat. Each thrust needs to be given with the intent of dislodging and expelling the object. Continue until the patient can breathe normally or becomes unresponsive. If the object is expelled and there is good air exchange, encourage the patient to be seen by a healthcare professional. Infrequent but serious complications from abdominal thrusts can occur. If the patient becomes unresponsive, carefully lower the patient to the ground. Begin CPR starting with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the patient's mouth wide. If you see an object, remove it with your fingers. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If an infant appears to be choking but is responsive, watch for signs of the obstruction becoming severe. If there is good air exchange with a mild airway obstruction, The infant is coughing forcefully, has a strong cry, and can inhale and exhale, stand ready to help if things get worse. With a severe airway obstruction, the infant may cough weakly, be unable to cry, or unable to make any sound at all. There may be a high-pitched noise when the patient tries to inhale. If the infant is responsive and you are not alone, have someone call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Kneel or sit with the infant in your lap. Hold the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Rest your forearm on your lap or thigh to support the infant. Using the heel of the other hand, give up to 5 back slaps between the shoulder blades. Give each back slap forcefully with the intent of dislodging and expelling the object. Sandwich the patient between your forearms and turn the infant over, using the palm of one hand to support the face and the palm of the other hand to support the back of the head. Place 2 fingers on the breastbone, just below the nipple line, and give up to 5 chest thrusts. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the sequence of back slaps and chest thrusts until the object is expelled and the infant can breathe or becomes unresponsive. If the patient becomes unresponsive, place the infant on a firm, flat surface. Begin CPR with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the mouth wide. If you see an object, carefully remove it with your fingers. Don't stick your finger blindly in an infant's throat and attempt to sweep out an object. This can cause injury or push the object further down the throat, worsening the obstruction. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient is pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the patient. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with the other hand and thrust straight backward. Try to not put pressure on the ribs. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the chest thrusts until the object is expelled and the patient can breathe or becomes unresponsive.
Hello po, good afternoon po. You can take your lunch na po. We will resume at 1 o'clock p.m. po for ACLS lecture. Thank you po.
So welcome to the Advanced Cardiovascular Life Support virtual course staged by WIPAM. The ACLS program is supposed to be like face-to-face initially. And during the surge of the coronavirus, we developed a system on doing it online. The only thing that is defeated is for you to have hands-on skills in doing code blue, in doing advanced airway, intraosseous. Although there was a situation wherein we conducted it live and in color sa Catanduanes. No? Pwede naman siya, pero medyo logistical nightmare lang, depende sa arrangement with WIPAP. But we can conduct it. Yun lang, kailangan mahahaba lang yung headroom kasi on my end, medyo busy din. Kaya we can do it. But for the program of ACLS, doon sa practical side, ay katulad din sa BLS, no? Dinidemo ko. Nagkataon lang na one-man army lang ako, but I need your imagination on how it's being done. Paano ginagawa yung code blue run. So anyway, like our basic life support, yung ating ACLS is also under the interim guidelines of 2022. So magugulat kayo, yung pinaka-highlight lang naman dito is yung advanced airway maneuver na dati nasa third level siya, ngayon naging second level. Kasi yung first level, hindi pa yun ACLS. But if we can perform it on the second level na kasama na sa IV or intraosseous or intravenous, sabay na si airway, mas yun ang ina-achieve ng interim guideline ng 2022. Pero sa reality, bumagsak naman ang ano, hindi naman wala naman tayong surges, kaya na ng katawan as long as we have adequate PPEs or personal protective equipment. Baka kaya na ng mga kahit level 3 up to level 2, no? Lalo na pag ang pasyente, alam natin, negative, nasa ospital natin, kaya na siguro level 2, nagsi-CPR ka, naka-level 2 ka lang. Kasi siyempre, nahirap din mag-CPR na naka-full suit, mainit masyado. Lalo na kapag ang ospital pinagtatrabaho natin, government, no, hindi adequate yung air conditioning units, siyempre mainit. Kawawa naman si frontline natin. Now, what are the objectives? So first is what is ACLS and revisit the chain of survival. Then pupunta tayo sa agonizing, agonizing, ECG. Kasi ito talaga yung medyo nahirap. Sa lahat ng turo ko, talagang nalalaglag, kahit doktor nalalaglag sa ECG. But don't worry people, the ECG that I will be teaching you is pathological ECG related to ACLS. Hindi naman pwede magturo ng mga pang-cardio. First and foremost, hindi ako cardio. Nagbabasa lang talaga. Marunong na ako magbasa. Kasi sa type of job ko, sa flight med, naturuan din kami. So medyo, kahit pa paano, nakaka-engage talaga ako ng ECG reading. Like ER doctors. No? So, ganun din. Although, ang pagkakaiba lang namin, mas matikas sila kasi medyo nakaka-critical care. Kami sa field, hindi kami gaanong nakakababad sa critical care na matagal. So, attach to it lang kasi hindi naman tatagal sa kamay namin sa loob ng aeroplano, sa loob ng barko, kasi hindi kami hospital. Pre-hospital kami. Kaya, ang medyo unique lang sa amin is, mas grabe yung excitement sa amin sa field. Kasi, I am my own doctor and I am my own nurse. Wala akong mahuutusan. Hindi katulad pag nasa ospital ako, I can command people. No? Dito, solo flight ka lang. No? Ang pangit din sa job namin is grabe yung gamit. Tulad ditong nasa tabi ko, makikita nyo. Yung mga bags na yan, puro life support kits yan. Yan ang mga laman niya. Yan lang pangit, maraming gamit talaga. Then we will go into advanced ALS skills, airway, tapos yung mga electrical therapy, no? Therapeutic electricity, defibrillation versus cardioversion, tapos ano ang transcutaneous spacing. Tapos paano ginagawa ang megacode? Yung pag sinabi ko megacode, pag hindi nyo ginagamit yung word, yan po yung how to address to a patient na grupo kayo, who does this and who does that. No? So, advanced cardiovascular life support. Ganyan ang tamang pag-define. Cardiovascular. Advanced. ED yan. Hindi pwedeng walang D. Advanced cardiovascular life support. Hindi lang cardiac. Kasi actually, ang main problem is the vessel. Ang vessel ang sumabog sa brain. Ang vessel ang bumara sa brain. Ang vessel ang bumara sa heart. Actually, the problem is the vessel. Kasunod lang yung si heart. No? Now, the ACLS is mainly algorithm lang siya. Parang the rundown. Swerte nga kayo ngayon, mas kukunti lang yung algorithm kumpara sa mga startup ng ACLS. I have my ACLS.
as early as 1999. Ganyan na po katagal. Bilang isang doktor, more than 20 years na po. Pero bilang isang rescuer, 30 years na. Kasi bago ako nagmedisina, nagre-rescue na. So, doctor, more than 20 years. Tapos, I had my first ACLS 1999, 1998, 1999 sa abroad. Medyo daming algorithm pa. The algorithm is about cardiac arrest, shockable versus non-shockable, tapos stroke, advanced acute coronary syndrome, ACS, and other life-threatening cardiovascular emergencies. Naghiwa lang dito, ang hindi sinama dito is hypertension, hypertensive crisis. Hindi sinama sa ACLS kasi hindi kagad siya mamamatay. Pag kumuha ka ng AMLS, Advanced Medical Life Support, masasagasaan mo sa hypertensive crisis, mga metabolic problems of metabolism, kidney diseases, puro advanced medical, puro drugs lang siya. Para ka nag-IM sa AMLS. Psychiatric emergency, gustong lumukso sa building. Yan. Si AMLS, actually mahirap. Kasi napakaraming gamot. Pero hindi siya requirement. Hindi siya requirement. Selective ang karamihan ginagamit talaga para sa immediate life immediate life support is ACLS, tapos for doctors, advanced trauma life support. For nurses and EMTs, ITLS, international trauma life support, sa pre-hospital trauma life support. There is like the ACLS course also talks about drugs, mga pharmacology, talks about electrical therapies, tapos airway maneuver. So ang airway ituturo ko sa inyo, kasi bias ako sa field, ituturo ko yung hospital, of course yung classic na endotracheal. But tuturuan ko rin kayo ng mga non-laryngoscope aided advanced airway. Ginagamit din yan sa inyo. Hindi ko alam sa protocol nyo. Halimbawa, nag-intubate kayo, hindi kayo naka-intubate. I mean, the intubation is not successful. Then you have to resort into supraglottic, like the ones being used in the hospitals right now is the iGel. I don't know if you're using iGel or yung iba, they're using LMAs or laryngeal mass airway. So yan. Sa unsuccessful endotracheal tube insertion using laryngoscope, twice. Ang alam ko kasi pag 2 times, supraglottic. Hindi ko alam sa inyo anong patakaran niya kasi hindi naman siya masabi natin. National regulation kasi wala pa tayong regulating body on that. Hindi katulad sa ibang bansa. Unless ang ACLS maging totally a law na required siya, tapos part siya ng PPG or Policies and Procedure Guideline, then that's it. Then magkakaroon tayo ng national PPG, Policies and Procedure Guideline on, for example, doing intubation and you failed, again, you re-intubate and you failed, and then the third time is you do supraglottic. Yan. The code blue, the ones who will perform the ACLS must be trained. Ito tayo ngayon. Kaya meron kayong certification sa isang legit na outfit like we pump, no? So, either you are a doctor, or whatever, specialty, requirements. And then, kung kayo ay nurses or paramedic, no? Yung mga pre-hospital care provider. So, sa Pilipinas, wala pa kasi tayong school for paramedic. Ang meron lang tayo ay EMT basic. Hindi pa tayo nakapaggawa ng isang ladderized or ng isang progressive courses from EMT basic into not intermediate, but that's intermediate town. But there is the second level, advanced EMT yata, and then you have the paramedic level. Or dati in the days of old, tinatawag siyang EMT paramedic.
Ngayon, simply paramedic. Tapos sa paramedic, marami siyang courses, pwedeng critical care paramedic, flight paramedic, physician assistant, mga ganyan. And they're invasive. They're like doctors. They can even prescribe few drugs na as long as it's an emergency. So ACLS is the mother of all, the cornerstone of all courses. So ito yung matutunan natin, ECG reading, pharmacology, advanced airway. Ang ituturo ko hindi IB kasi marunong lahat ng IB. Nasa nursing school kayo, nag-IB kayo. So ang ituturo ko lang ay intraosseous. So I will do a demo. Tingnan ko kung may mga video pero nasa Facebook ko, hindi ko alam kung mahanap ko pa. Nag-live talaga ako ng intraosseous. And then defibrillators versus cardioversion, tapos capnography para ipaintindi ko kasi yan talaga yung patakaran. Kahit alam ko sa Pilipinas, hindi siya ginagamit, pero yan yung patakaran. Tapos transcutaneous spacing, megacode, lecture on advanced acute coronary syndrome and cerebrovascular accident. Pulse and NRP are different course. Hindi siya matatagal dito because it's a different course by itself. Then hypothermia management, ituturo ko kasi isa siya sa reversible age. Tapos main topic din siya sa ACLS handbook. So as you see here, ACLS is the cornerstone of all ALS courses. Ano ba yung mga advanced life support? Meron tayong advanced trauma for doctors, for nurses and EMTs, merong pre-hospital trauma life support, saka international trauma life support. Merong PALS, Pediatric Advanced Life Support, and NRP, Neonatal Resuscitation Program. Merong Management of Obstetric Emergency, Advanced Disaster Life Support, Advanced Medical Life Support, saka Wilderness Advanced Life Support. Itong Wilderness Advanced Life Support, pinakamatikas to. Bakit? Nagpe-perform ka ng ACLS saka Advanced Trauma sa field. Mas ano to. Itong walls, kung kukunin mo tong walls, hybrid siya. Hindi pwedeng ituro siya online. Hybrid. Meron kang lecture on, I think 4 days straight lecture, tapos mag face to face ng 2 days. Ang problema lang ngayon, medyo nagmahal yung kasi ang trauma, para matuto kayo mag-tube, mag-creek, so magbabayad tayo sa ospital. Ang 4 na baboy cost 290,000. So, paghahati-hatian niyo ng ilang estudyante, halimbawa, 40 kayo, paghahati-hatian niyo. 10 sa isang baboy, 10 kayo. Yan ganyan. Other than, bayad pa sa walls, kasi ang babayaran yun, kunwari, Cardinal Santos, gagamitin natin yun. So, sila yung ini-intubate yung baboy, nilalagay sa mechanical ventilator. Tapos, whole day na bakbakan yun. Bakbakan na whole day yun. Kasi meron na tayong training eh. Meron ng mga didactics. Tapos, ginawa na namin yan. ACLS muna. Pag ACLS, cold blue. Cold blue lang lahat yun. ECG reading, tapos bumbugan yun. Tapos the next day, trauma, bumbugan talaga. Inaabot kaming gabi. Kasi minsan, na bumabagal sa ECG. Anyway, ganyan ang walls. Ang pinakamalupit dyan is the walls eh. Tapos yung ADLS, halos ganun din. Mas matindi. Depende kasi na yun ang ADLS, Advanced Disaster Life Support. Ang kanyang tindi is the logistic nomenclature. Napakadaming gamit. Kasi magsiset up ka ng command center mo. Yung command system mo. Tapos magsiset ka ng treatment area, red. Sa red yan. Ano ang scenario sa red? Maraming casualty. Tapos depende sa scenario, halimbawa, yan ay vehicular accident, tapos i-address mo, tapos warak-warak, halo ang trauma sa cardiac. But mainly, this is around 90% trauma in a multiple casualty incident. So nakakatuwa siya, mahirap lang siyang gawin kasi there is some sort of what we call the logistical nightmare. Daming kakailanganin, tapos mag-aarkila ka ng mga tao na live, na sugatan, in-mulage mo yun. Ginagawa namin yun way back before. Grabe yun. Malaki ang gastos. Usually, it's either government run siya. Minsan, ang ginagawa namin sa schools, the school will sponsor it. Halimbawa, sa nursing school, half of that casualty and half responder, babakapan lang may ng mga volunteer responder para matuto. Tapos nagmamanage sa field, merong mga intubation, dami, doon nag-intubate, merong doon nagpa-fire, merong nag-wound management, mga ganun. In a multi-casualty scenario. So, what are the 10 core ACLS cases? One is respiratory emergency, para anong gawin natin. Tapos, how do we address to VF, ventricular fibrillation, ventricular tachycardia, pulseless, mag-defib, saka sa PIA and asystole, no? PIA and asystole. Tapos 4 types of pre-arrest emergencies, yung brady, stable tachy, unstable tachy, and then ACS, at saka stroke. So ito lang yung evolution ng ACLS. So wala siyang hypertensive crisis. Now, laging babalikan to. Sa exam, kung mag-exam kayo, no, yung AHA standard, halos idodrawing mo to lahat eh. Idodrawing mo yan. Ulit-ulit sila dyan. Kailangan magaling ka talaga sa chain of survival kasi hindi ka pwedeng shortcut eh. Dyan talaga, himay-himayin mo yan. Ano yung, what is the fourth link in the chain of survival? O, in hospital, cardiac arrest, IHCA. Alam mo, that is defibrillation. Yan. So, yan ang sa PIDIA. And then, ito yung pinaka-highlight ng ACLS para maintindihan natin ano ang evidence-based medicine. So, titingnan natin ang dito sa kaliwa ko. Ang tawag nito COR or Class of Recommendation. So, pag nagbasa kayo ng ACLS libro, lagi niyong masasagasaan ng COR. Halimbawa, compression. Pag unang minention ang compression, doon sa book, may COR yan, Class of Recommendation. Ang compression is Class 1. Level, I think level A yun. Level A. Yan. Ibig sabihin, high quality. So, yung Class of Recommendation dito sa kanan ko ay yung LOE, Level of Evidence. Kasi evidence-based medicine. So, ibig sabihin, ang compression, undisputed, all benefit talaga siya. At wala kang makikitang risk. Although, pwedeng maano, pero very nil. Lahat naman ang gagawin mo, may risk. Pero, kinonsider siyang class 1. Halimbawa, si defibrillation, saan siya? Si defibrillation, nasa class 2 siya. So, moderate siya, benefit is benefit is more than twice greater than risk, no? Very reasonable, can be useful, effective, dito siya. Si epinephrine, 1 mg per ml is class 2A siya. So, mga ganyan. May mga pag nakakita ka ng gamot na consider na class 3 or saglit ha. Nakita kayo ng gamot, sorry class 3, matatakot na kayo ibigay. Kasi halos equal na si benefit sa kasi risk. So, usually, hindi na natin in-encourage. Or, pag na dito sa level of evidence na limited data, mukhang awag na hindi na binibigay yan. Ganun lang yan siya. So, sa lahat ng gamot, lahat ng intervention, no? Gamot ng intervention, yan ang maano niya. Yan ang masasagasaan niya. So, hindi tayo pwedeng mag-ACLS na hindi tayo class of recommendation. Okay? So, may kinalaman ba yan sa practice ko? Hindi. Wala. Kasi sa practice nyo, algorithm. Pero, bakit ko ini-emphasize? Kasi evidence-based medicine, pag nag-present kayo, kahit basic life support lang yan, kailangan meron kayong COR. Okay, people, when we do compression to a cardiac arrest, this is how we do it. By the way, compressing the sternum is categorized as COR class 1. So mga students din, nanonood siya. Anong ibig sabihin? So explain mo ang class 1. No? It is recommended, it is indicated, very useful, no, effective, gano'n, no? And the benefit is 3 times greater than risk. Kasi it makes you more of an academe. No? Yan ang kailangan i-ano natin, i-emphasize. Kaya, hindi ibig sabihin na
totally ano siya. Para ang Pilipino, alam mo, ang problema dito sa Pilipinas, sa harap ng mundo, nakakaloko din talaga sila sa Pilipino kasi minsan tayo, kulang tayo sa evidence eh. Hindi tayo people of research and science. Hindi ganun. Para tayong mga marites. Kaya minsan nakakawala ng respeto sa ibang counterparts natin sa ibang panig ng mundo. What do I mean with that? Parang ano siya, hindi siya uh, hindi siya yung kulang tayo sa data pag nag-explain. Hindi yung kasindak-sindak na ano. Understandable naman kasi ang Pilipinas wala talaga tayong research unit na malalim. Hindi katulad sa ibang bansa. Kaya ako nag-emphasize dyan guys kasi una, lagi po ako nasa ibang bansa. Tapos, naiinis ako pag mababa ang tingin nila sa Pilipino. Naiinis ako doon. Kailan, napaka-competitive ko. Pag speaker ako sa ibang bansa, ginagalingan ko na tauban ko talaga ibang bansa. Yan yung laging objective ko. Kailangan tauban ko. Kasi, yun naman lang yung way na makabangon tayo baka. So, pero signal light. Kinakabit sa helmet sa rescue. So ito yung ating backbone. This is our backbone on when you read even the soft copy of it, masasagasaan nyo itong COR or class of recommendation and then the LOE or levels of evidence. So kung magbasa kayo sa to, pag nag-attend kayo ng mga medical conferences, laging may word na evidence-based medicine, blah, blah, blah. Yan yun. That's your blah, blah, blah. Okay? Here, I will not discuss about abbreviations. So, hindi na kailangan. Now, this is our ACLS in history. Para lang medyo maintindihan nyo saan nagsimula tayo. Sa matagal na yung ACLS na yun. Yung iba sa inyo, hindi pa pinanak, may ACLS na. So, ito naman, nung nasa abroad, nung nasa Pilipinas ako, medyo alien sa akin to. Sa abroad ko nakuha kasi very ano sila. They are very focused on quality. And this is the old ACLS, the recent, bago mag-pandemic. So yan po ang tinuturo ko bago mag-pandemic. And this is the ACLS after the surges. Walang after the pandemic. No? Kasi COVID is still there. Although wala na yung pandemic, like a health emergency, but the corona is still there. So ito yung ating 2020, agreed on April 2020, but remodified for the sake of COVID. COVID started, nag-full-blown siya, nataranta buong mundo is 2019, late 2019, particularly December. February, isa ako sa first batch po ako ng COVID, muntik akong namatay. Pero hindi ako nagpa-intubate. Kung hindi lang ako, kasi medyo mataas yung yung VO max ko kasi siyempre makategorize ko yung sarili ko on high altitude athlete, no, being kasama ko umakyat sa Mount Everest, being a doctor doon sa high altitude. Kaya alam ko, so yung aking stamina mataas talaga. Kung hindi lang, patay na ako ngayon. It's just, being a doctor, I don't like being intubated. Kumuha akong paraan para hindi na-intubate. Pero I was foolish enough to do that. Pero sige lang. Makita niyo as the lecture, from the lecture I had this morning, no? Ang pinakauna talaga, ang emphasis dito sa updated 2020 and then interim guideline. Actually, nang na-drop nila to actually 2022. Kaya ginawang interim guideline. So, limit personnel sa Code Blue. So, ang optimal team ng Code Blue, ang tao na mag-address sa isang arresting patient is 6. Airway, compression, electrical therapy, IV, team leader, documentation officer. Yung documentation is
Siya yung tagalagay ng oras na, halimbawa, 1 milligram epinephrine, post 20 cc NSS. Titingin ka sa relo, 13:27 or alauna 27, 1:27 in the afternoon, lagay mo doon, epinephrine plus 20 cc NSS given. Ikaw yung tagasulat. Okay, going to defibrillate the patient to 200 joules, 1 I'm clear. Charging now, 1 I'm clear. 2 you're clear? Clear. Everybody's clear? Clear. Shock given. Check for pulse. Ikaw naman sulat ka at 1:28, nag-defib sila at 200 joules. Yun si documentation officer. Ngayon, yung 6 na yon nahulog sa 4. Yan yung ibig sabihin na limited personnel. Yan. Wala na. Sino ang documentation? Usually si airway na. By utak. Tingin lang siya, pwede siyang kumuha ng ballpen na ilalagay lang niya, defib, markahan lang niya. Isa lang doon. Nagbabag lang siya, boom, kasi naka-intubate yung pasyente or naka-short ka sa mech bed. Or pwede rin ang mag-docu is yung compressor. No? Nagbabantay lang siya kasi para hintayin ng compressor. Tapos nagdo-docu siya. Bakit? Bakit di siya nagko-compress? Kasi meron na siyang tamper, yung machine na nagtatamp. Again, then consider resuscitation appropriateness, limit personnel, don't PPE. Yan yung ano. Pag sinabing consider resuscitation appropriateness, ano ibig sabihin nito? Sige, ano ko na lang ha. Dalawa to. Dalawa. Meron tayo tinatawag na behavioral change. Ano yung behavioral change? Na ang bawat operator doon, mga doctors and nurse, kung sino ka man conducting, dapat hindi tayo nagbabanggaan. Pag nagkaka-switch places tayo, magdidistansya, parang sa OR, parang tayo sa OR, na hindi mag-touch yung mga kamay kasi pwedeng merong mga COVID particles, no? Nakuha natin sa pasyente. Yun, no? Yun yung tinatawag appropriate test. Na hindi nagwawasiwas ka doon ng mga ambubag, ng mga kung ano-ano, no? Tapos ano pa, behavioral, no? Lahat nakamas, tapos yung N95 ay naka-fit na hindi nag-flare. Anong hindi nag-flare? Parang karamihan sa atin, mali. Alam mo saan kayo nagkamali? 1, naglagay ng surgical mask, nilagyan pa ng another surgical mask. Dalawang surgical mask, niloloko nyo sarili nyo. Hindi dadaan ng hangin doon sa surgical mask, dito dadaan yan sa flare. Kasi ang area of resistance tinaasan niya. Ang hangin babay doon sa area of least resistance. Tinatawag nating easy corridor. The easy corridor. Yan. So doon nagkamali. No? Kung basahin ninyo, tatawanan tayo ng buong mundo kasi hindi dinesign ang surgical mask na doblehin mo siya. Okay. That's one. Number 2, anong behavioral change na nagkamali tayo? Surgical mask, pinatungan ng N95, naloko na. So si surgical mask, lumalabas yung mga gilid-gilid niya, tapos nag-N95 ka, yung mga hangin maliliit, pumapasok doon sa gilid-gilid. Kasi area of strong resistance to, dadaan siya sa area of least resistance. Kung mag-aral tayo ng physics, no, you have to love physics. You will understand that what we were doing with our mask is totally wrong. Ayun yun. So yun yung mga behavioral changes. Yun yung sinasabi dito sa consider resuscitation appropriateness. Ano pa ba kailangan? Ano pa? Sa mask, sa donning, we do it so well naman. Doon tayo sa structural appropriateness. No? Behavioral appropriateness tapos structural appropriateness. Sino-shortcut ko na lang yung interim guideline. Ano yung structural appropriateness? Ang kama ng pasyente ay hindi nakatumbok doon sa wall. Para may airway. Merong corridors airway mag-move. No? At nandun lahat. Ito medyo masakit sa bulsa itong structural. Ni-require na per bed sana ng pasyente ay may ambubag na naka-standby doon. Ang sakit mo, no? Parang hindi mangyari kasi si ambubag ay sa cross cart lang. Kung isang government hospital ako doon sa periphery, tapos walang gano'n, no? So, yun. Tapos, kailangan ang pout sa wall, suction, may suction ka, meron kang medical oxygen with humidifier, saka meron kang emergency oxygen that can reach into 15 liters per minute. Diyos mio, ang mga ospital sa Pilipinas ay walang ganon. Sino lang may ganon? Na mga government hospital, PGH, yung mga matitikas, wow ang Southern Philippines, wow talaga yan. Tikas talaga Southern Philippines sa Davao. Sino pa?
Of course, mga private hospitals like St. Luke's, meron talaga silang emergency line. Ano pa ba? Ito, paulit-ulit ko sinasabi, wind corridor. So merong kang mga HEPA filter, tapos meron kang wind corridor, hangin. Ang hangin mo nagmo-move dapat sa loob, hindi pwedeng standby. So nagmo-move siya, meron siyang entry, meron siyang exit para hindi tumatagal ang microparticulates sa loob ng what we call this, sa isang room. Yan. Yan yung structural appropriateness. Tandaan niyo dalawa, behavioral appropriateness, structural appropriateness. Okay, then you start CPR. Pag-start ng CPR, unahin mo na malagyan ng bag mask. Yeah, pwedeng mask, pwede siya. Or non-rebreather mask to limit the flying off of aerosols from the patient. Siyempre, pag huminga siya, nagsi-CPR ka, bug, lumalabas yung hangin. Kung may COVID dyan, liparan si COVID. Lagyan ng mask. Okay. Tapos, attach ka agad sa cardiac monitor para makuha natin yung limb leads. Tapos, prepare to intubate. Pwede mo pang maunahan, depende yan, no? Pwedeng unahan pa si IV bago mag-intubate. Hindi na siya issue. Kasi dati, habang nagsi-CPR ako, on the first 2 minutes, ideal on the first 2 minutes, sa isang pasyente, kunwari, out of nowhere, nag-cardiac arrest, pero wala siyang swero. So, habang nagsi-CPR ka, nagdadatingan si cold blue, naubos mo yung 1 minute or 2 minutes. Pagdating na, start na ng IV, bigay mo ng drugs, fire ka. Ganun ang schematic. Hala, CPR, drug shock. After 2 minutes, ideal, airway ka ngayon to satisfy your oxygenation. Third level siya. Ngayon, hindi. Pasyente nag-arrest, address ka ngayon, CPR, bab. The chain of survival, susundin ko, dipib, boo! Pag dipib mo ngayon, prepare ka na into intubate. Kung pwede, sabay kay IV. Or mauna konti si IV, intubate on the second run. Pinakamatagal on the second run. I mean, after 2 minutes, kailangan magawa mo na si IV and intubation. Yan yung emphasis ng 2022 interim guidelines for ACLS. Ginawa ko lang shortcut para sa inyo. Pero basahin mo sa libro, lintik, pinahaba pa explanation. So, intubate ka agad. Bakit? Kasi para ma-achieve natin yung tinatawag nating cross the contamination, no? Kasi pag hindi naka-close circuit lahat, the aerosol will be, mas madaling dispense, I don't know if it's the right English, mag-spread, in the internal atmosphere of the room. So pag naka-intubate siya, tapos nakakabit doon sa valve mask mo na merong HEPA filter, sarado siya doon. Ang tawag doon ay closed circuit, yung closed circuit connection. Kung naka-closed circuit na. So lahat ng aerosol mo may entrapment. Yun yung ina-achieve. Pero ito naman ang nakaka-visit, no? Sorry with the word. Kailangan, ang valve mask mo ay may HEPA filter. Patay ka na naman. Kasi karamihan valve mask na hinawakan nyo ngayon, walang HEPA filter. Patay na naman tayo. Daming requirement. Kaya sinasabi ko sa inyo, in the adjustment to the interim guidelines, luluwa talaga tayo ng pera, bumili ng mga gamit na tama, appropriate for COVID. No? So, mayroong siya. Actually, mayroong pinag-uusapan kami na yun. No? Ayoko lang i-preempt, no? Pero I'm not trying to scare. Merong another pandemic darating. Kasi sa side ng military medicine, there is another, dalawa kasing medicine sa mundo. Civilian medicine, yun yung kayo, saka military medicine. Sa military medicine, medyo kakaiba yung outlook niya. Kakaiba yung paningin kaysa sa civilian medicine. So there might be another pandemic, but it's not gonna be a virus daw. It's not gonna be bacterial, baka more fungal, yan ang sinasabi nila. Well, let's see. Okay. So ngayon, prepare to intubate. Habang nagpe-prepare to intubate, nakita natin sa Kabul rhythm, so magsashock ka. Dito, post-chest compression for intubation. Hindi katulad dati. Pinakauna, mag-post, intubate. Noong 2010, nauso na yung 2015, nauso na yung huwag ka nang huminto. Kasi habang nagko-compress, nakikita mo, bumubula yung laryngeal opening eh. Doon mo isuksok yung endotracheal tube habang in-open mo laryngoscope. Kitang-kita mo. So walang hinto na. Ngayon, hinto ulit. Siyempre, kawawa naman si airway. No? Kahit pa naka-video laryngoscope yan, ang hangin lilipad pa rin. Okay, so pause ka muna, chest compression. Tapos, intubation delayed, consider supraglottic. Halimbawa, hindi talaga ma-insert. So, pwede ka ngayon mag-supraglottic. So, depende sa protocol ninyo kung anong klaseng, kung ilan. Isang one failed intubation, endotracheal, using laryngoscope, tapos supraglottic, or two failed intubation. I really don't know what's your principle. But if you have to ask me, kami, hindi kami gaanong nagla-laryngoscope. Although ako may laryngoscope sa field. Kasi sa field, as much as possible, ayaw namin magdala ng laryngoscope. Bakit? Pabigat eh. Pero ako as a backup, kasi expedition, meron ako. Pero mas marami akong laryngeal mass airway, mas marami akong gano'n. Kesa mas marami akong endotracheal tube. Yung endotracheal tube, para gusto ko lang secured tube talaga, okay sa akin. Pero as much as possible, kung military medicine, no laryngoscope. Supraglottic lang lahat yan, military. Halimbawa ako, kasi dati po ako nasa uniform service bilang sabihin nating military doctor, yun talaga yung training ko. Supraglottic kami lahat, hindi kami gumagamit ng laryngoscope. Kasi ang principle, kung laryngoscope, dagdag pabigat, may baterya pa, bala na lang. Kasi siyempre, sa combat medicine, the first rule is superiority of firepower. Kailangan baka kaputok ka talaga ng marami sa kalaban. Kasi kahit pa magaling ka, tapos pinuputukan ka, hindi ka makaperform. Putukan mo na marami yung kalaban para makaperform ka. Kung ma-neutralize mo kalaban, makaperform ka na. So, yan po. Tapos, connect to ventilator with filter when possible. Kunwari, ang neck vent nyo, sa amin naman, meron kaming tinatawag na IMV, Intermittent Mandatory Ventilator. No? ATV, Automated Transport Ventilator. So, I have it with me. So, nakakonect yung pasyente, siya magbibigay. No? Tapos, yung kanyang exit, kailangan may HEPA filter. May attachment pong nilalagay doon para hindi kumalat. Tapos, napapalitan yon in time. Palitan, para panibago ulit. Tapos, i-dispose yun. Kasi, siyempre, baka punong-puno ng COVID yun. So, 2 minutes rundown, then gamot. No? So, depende yan. So, kung shockable versus non-shockable. Nandito na ako ngayon. So, shockable ba? Tapos, habang nagsi-CPR, bigay ako ng epinephrine. Tapos, pwede ko i-convert into tamper or mechanical compression device. No? MCD, mechanical compression device. Yung siya nagpapa-CPR sa'yo. Tapos, after 2 minutes, ulitin shockable ba? Then, kung na-shock ulit, tapos bigay ako mag-drugs, pwede ulit akong epinephrine or pwede ako mag-amiodarone 300 or mag-lidocaine 100 mg. If the patient is non-shockable, epinephrine, tapos mechanical compression device, tapos CPR 2 minutes, hanapin natin, tapos drugs ulit, epinephrine, no? Hanapin natin kung ano ang mga reversible H&Ts nandito. Ano ibig sabihin ng H&Ts? Hypovolemia, no? Kung may blood loss ba, no? Hypoxia, kinokorek natin yon. Hydrogen ion or the acidosis, no? Hypokalemia, hyperkalemia, hypothermia. Then sa T, tension pneumothorax, cardiac tamponade, toxins, tablets, trauma, thrombosis pulmonary, thrombosis coronary. So, pag na-reverse natin, at kunwari, nasa 20 minutes na tayo ginagawa, no? Flatline siya, ni-reverse na natin, nakita natin, ginawa naman, in-intervene natin, wala pa rin, titingnan natin ang capnometer. Pag ang capnometer hindi na lumampas ng 10 millimeters of mercury, ibig sabihin, the cell cannot anymore, there's no more metabolism, not metabolism, there's no more activity in the cell. The mitochondria is not functioning. So, patay na siya, cell death. Wala nang pag-asa. So, tayo sa ACLS, magdi-declare tayong patay kung ang ating capnometer
nagsasabi na hindi na lumalampas ng 10. Kasi ang normal is 35 to 45. Ibig sabihin, merong carboxylation na nangyayari doon sa cell, nagpo-produce ng carbon dioxide. Alam natin ang cell buhay, no? Alam niyo yung Krebs cycle. Pero during sa CPR, sinettle ko yung H on T's. Flatline ako, 20 minutes na. Tapos hindi umaakyat ng 10. Ibig sabihin, no more carbon dioxide. Therefore, the cell is dead. That's the time we declare dead. Hindi po tayo nagdi-declare dead mata-mata na nagko-constrict yung mata sa ECG because a flat line is not an indicator that the patient is absolutely dead. Kasi dalawang klaseng dead. Probable sign of death and the definitive sign of death. Flat line is not definitive. Baka ma-reverse pa yan in CPR, in drugs. Yun po yun ha. Nasanay tayo sa Pilipinas, luma na pong tugtugin yung flatline na, wala. Tapos stethoscope. Wala ka talaga marinig sa stethoscope. My golly, hindi yan ang indicator. So sundin mo talaga ang evidence-based medicine. Ang flatline is not an indicator the patient is dead. The indicator that the patient is dead is capnometry. Sir, wala naman tayong ganyan sa Pilipinas. Bumili kayo sa Shopee, 19,000 lang. Meron pa nga nagbebenta, 12,000 capnometer, yeah. Huwag kayo bumili ng EMA, 90,000 yun. Di bumili ako ng Contel, it works, pareho lang, pero nasa 17 or 15 or 12, depende kung sino nagbebenta. Capnometer is the future. That is the future. It's more definitive than your pulse oximeter. So dito sa airway, anong emphasis? Minimize close circuit disconnection. Anong ibig sabihin nun? As much as possible, ang daanan ng hangin papunta sa patient at saka palabas, meron siyang dinadaan ng sakto, walang spillage, no? And then, ang exit ng hangin, yung exhaust, ang exhalation niya must pass through HEPA filter. Grabe, no? Yeah, ganyan po ang interim guideline. So, nakakatakot sa interim guideline, kaya kailangan meron tayong budget. Pangalawa, kailangan use intubator, no? Yung nag-intubate, ang tawag intubator, with highest likelihood of first pass success. Anong ibig sabihin first pass success, ladies and gentlemen? First pass success means, isang intubate, suksok agad. Hindi yung pamali-mali. So, kailangan ang intubator or yung airway guy, napakagaling. Walang palpak. Yun yung tinatawag na first pass success. Consider video laryngoscope. Agree. Since 2001, meron pa akong video laryngoscope. Hindi niyo alam, no? So, nasira lang siya, black and white. Gumagamit na akong video. Kasi galing akong abroad, nagdala ako noon. So, wala na, sira na. 2001 pa yun. So, natuwa ako, grabe kahuli ang Pilipinas. It took COVID for us to realize na meron palang video laryngoscopy. Hindi ko sinasabing magaling ako. Nagkataon lang, galing ako sa abroad. Matagal na po ang video laryngoscopy. Yung telemed nga, na nauso ngayon sa COVID, telemed, nung umakyat kami sa Everest 2006, I was using telemed. Kausap ko po ang Stanford University sa US. So kung ano yung findings ko doon sa base camp ng Everest, mga deep vein thrombosis, pulmonary edema, nakikita ko ng Stanford University at 5 to 6 second delay. Kasi tinatransmit lang via satellite. So napapakinggan nila yung garalgal ng pulmonary edema, nakikita nila ultrasound, yung mga findings ko sa field, no? Meron akong portable x-ray, ultrasound, portable lahat yon, portable ECG, yung ECG ng hypothermia na merong Osborne wave, nakikita nila 5 to 6 second delay. Ngayong COVID, nauso ang telemed. Nalungkot ako. Ganun pala kalayo na huli ang Pilipinas. 2006, ginagamit ko telemed. Only 2020, grabe, nauso ang telemed. Na dapat ang telemed ay nandito sa Pilipinas kasi marami tayong isla, no? How many islands in the Philippines? Ang sagot, low tide ba or high tide? Grabe, no? So, dapat mayroon tayong telemed kasi hindi lahat ng mga barangay na nasa isla ay may doktor at may hospital. Kailangan may telemed capability ang mga naiwan na barangay health workers. So, nakakalungkot at hindi tayo ganun na-update. So, ito ngayon, ito yung program ng ACLS. So, kailangan, pareho lang siya except na mauna talaga ang airway. And we still employ the 3 major drugs, epinephrine 1 mg per ml, amiodarone 150 times 2,
and then lidocaine 1 to 1.5 mg per kilogram. So ang available na lidocaine is 100 milligrams, tama lang yun sa isang adult. So ito yung interim guideline. Hindi ko na siya isa-isahin. No? Ito na yung ACLS. Use HEPA filter if available for all ventilation. Ang HEPA filter, meron doon sa bag valve mask. Ang HEPA filter ay merong machine. Ito yung tinatawag na structural changes. Ang HEPA filter ay yung nandoon sa roof or wherever saan na-exit. Pinipilter para wala kang COVID sa loob ng ospital. Kinalat mo naman sa community. Kailangan naka-HEPA filter doon. No? Tapos, kailangan yung ating airway guy or yung intubator kayang mag-achieve ng first pass success. Tapos, huwag mag-compress during intubation. Visual laryngoscopy ang para malayo, hindi yung sisilip-silip ka na tinatawag na atlanto-occipital position of the patient. No? Then, before intubation, bag mask device or TPs in units with a HEPA filter and tight seal. Saan si HEPA filter? Doon po yung kinakabit sa exhaust na naman, sa exhalation port ng patient. For adults, consider passive oxygenation with non-rebreather face mask. No? Para kung wala pang bag valve mask, yun muna ilagay mo bago ka mag-compress. Pag hindi kaya or delayed ang intubation, go to supraglottic airway like using LMA or IGEL. Tapos minimize closed circuit disconnection. Ibig sabihin, yung tube, doon na siya. No? Pag naka-tube, huwag yung patanggal-tanggal ang tube. Kaya pag nag-defibrillate ka, pinapatay mo na yung airway, pero nakahawak ka sa BBM. Hindi ka naman makuryente kasi plastic naman yun sa silicone, non-conductor yan. Yan. No? So, hindi ko nabasahin to ha. Pwede nyo lang, I want you to read it in your available time. Ito yung mga interim guidelines of 2022. Ito po yung luma na ACLS rundown. Yan. So, kinumpara ko, halos walang pagkakaiba except sa bungad, Don't PPE, limit personnel, and yung tinatawag nating Code Blue appropriateness. Ano yung Code Blue appropriateness? Behavioral appropriateness, saka structural appropriateness. Yan. Ito pa yung mas medyo luma, 2015, down. So ito, ang 2020. Huwag kayong mataranta dyan sa nakalagay na date. Yan po yung pagtayo ng 1998, hindi po yan. Yan po yung ACLS Training Center, itinayo 1998. So ito yung 2020 algorithm. Saglit lang ha, kukuha lang ang tubig. Okay. So, itong 2020, himayin lang natin to. Na kayong algorithm, ito talaga yung susundin natin. Ito yung susundin natin. Pero doon sa non-arresting heart, yan, no? Yan ang susundin natin. Wala kayong ibang susundin kundi itong updated April 2020 with interim guidelines of 2022. Yan siya. Itong dalawa lang ha. Yan. Para nyo malalaman, mapapansin nyo sa itaas, merong Don't PPE. Makikita nyo pag luma yan. Yan. Scene safety. Scene safety. Yan yung luma. Yan yung luma. Check for responsiveness. Shout for nearby help. Blah, blah, blah. And blah, blah, blah. So ito, Don't PPE. Pag nakakita yung ganyan, yung yellow, ibig sabihin, full emphasis. Sa color coding, full emphasis. Tapos, start CPR,
Ito yung another pagbabago, another yellow, ito naman full emphasis. So, dito tayo ngayon sa paano ni-rundown yung ACLS. Okay? So, same. No? Drug shock lang siya. Ang ina-achieve natin, 100 to 120, 2 to 2.5 inches. Lalim with adequate recoil. Ito yung 2020 guideline. No? Number 1, push at least 2 inches. 100 to 120 rates and allow complete chest recoil. Dati si chest recoil hiwalay. Ngayon pinag-isa nila sa rule number 1. Okay, pag tanungin kayo sa exam, what is the rule number 1 in achieving quality CPR? Push at least 2 inches. Adult 2 inches at 100 to 120 rate per minute and allow complete chest recoil. Yan ang sagot. Pero ang pangit sa exam ninyo, ang dali-dali na. Bakit? Hindi na kayo nag-i-exam ng fill in the blanks. Ako gusto ko talaga fill in the blanks para walang daya. Kasi kung multiple choice, pwede niyong i-mini-money mo. No? Wala, hindi niyo alam. Hula-hulaan na lang. So hindi mo alam. Tapos nakatama ka pa, nakatsamba. Ang paningin naman ng iba, ang bright-bright ito, yung pala tsamba. Natsamba ng sagot. Pero sa fill in the blanks, walang lusot. No? Tapos number 1. Number 2, minimize interruption in compression. Okay? Kaya sabi ko kanina, pag naglagay ng pads, huwag huminto, tuloy-tuloy lang. Pag nagtanggal ng damit para maglagay ng pads, tuloy-tuloy lang, no interruption. Tapos, avoid excessive ventilation. Tama lang yung pag-collapse ng bag. No? Then, rotate compressor every 2 minutes. Kawawa naman pag hindi nag-rotate. So, yan yung isang emphasis. Tapos, if no advanced airway, 30:2 ang ating compression-ventilation ratio. Compression 30, hinto 2 sa dalawa ha. Ibig sabihin, naka-bag valve mask. Pag hindi naka-bag valve mask, kahit dalawa pa kayo, all hands CPR. Huwag mag-mouth to mouth. Quantitative waveform capnography. Ito po yon ang hinahawakan ko. Yan yung capnometer, capnography yan. Naku, yan pala kailangan. So itong CPR quality, ito yung dumaan sa evidence-based medicine according to the ILCOR, no? At saka AHA. Kaya hindi mo pwedeng i-violate ito. Kung pwede ka, kung ako lang magbigay ng exam, ipapa-enumerate ko pa ito lahat eh. Kasi yan talaga yung pinakadingal ng CPR. Pag hindi mo nakuha ang CPR, we will not be in the business of doing ACLS. We are fooling ourselves. Tandaan yan. So it's always CPR at the backbone of everything. ACLS is useless if your CPR ay hindi quality. Walang silbi. Akala nyo, ang galing-galing ko. Hanggat hindi mo alam ang CPR, hindi ka makapag-produce ng quality CPR, sablay ang ACLS mo. Okay? And the last is, if your partial pressure, if your end-tidal carbon dioxide or yung capnometry mo is less than 10, yun ang display niya, ibig sabihin, there's a problem in your compression. So, i-check mo muna kung quality. So, hindi magsisinguling si end-tidal carbon dioxide or si capnometry. Okay? Then we go into drugs. So, we have epinephrine. Dati si epinephrine, pag binibigay natin, 1:10,000. Ngayon, hindi na po tayo nagbibilang ng dilution. Ibigay na lang natin si epi. Dati, dalawang klaseng epinephrine. 1:10,000 for cardiac arrest and 1:1,000 for anaphylactic shock. So, magkaiba yun. Ngayon, hindi na. We give epinephrine as is. Pangalawa, amiodarone, 150 ang preparation, pero initial bolus mo is 300. Ang second bolus mo is 150. Paano binibigay yan? Okay, ganito, CPR ako. Hindi pwedeng mauna si amiodarone. Epinephrine talaga. So, pinaka-first drug mo always epinephrine. Wala nga akong mas matanggap ko pa na walang amiodarone, puro epinephrine na lang, mas okay pa siya. No? Pero pag may amiodarone ka, may epinephrine, of course, epinephrine, murang-mura lang naman. Ang pinakaayaw ko lang sa epinephrine, guys, alam mo, made in India. Maganda na sana. Ang problema, madali mabasag. Pag baliin mo, durog lahat, no? Yan yung napansin ko, murang-mura. Grabe, sa India ang gamot. Pag nandun ako sa Nepal,
Pag umakyat ka rin, pag pauwi, bumibili ako ng maraming gamot. Kunwari, yung isang vial ng, sampulan ko kaya, Rosepin. Kunwari, isang vial, 80. Naalala ko noon, 80 pesos isang vial. Alam nyo, magkano kung bibilhin ko doon? On same brand, same brand, guys. Ano lang siya, mga 16 pesos. Grabe kalayo. Namili ako maraming gamot. Inuwi ko rito. Naharangan lang ako sa Thailand kasi wala namang direct flight sa Tribhuvan Airport to Manila International Airport. Dadaan ng Thailand. Ngayon, marami nang dadaanan. Pwede ka mag-Hong Kong, pwede ka mag-Malaysia, sa Thailand. Kami Thailand. Galing Everest team. Ang galing Everest, sa Thailand kami. Hinarang ako sa Thailand, buti na lang meron akong listahan ng gamot, expedition doctor ako, pinakita ko lisensya ko, expedition kami, naka-uniforme ako as doctor. Kompletong gamot plus Ricardo. So napalusot naman ako. Kasi marami akong prohibited drugs eh. Meron akong fentanyl. Yeah, I have a fentanyl. Meron akong ketamine, morphine, sangkatutak diazepam, midazolam. So grabe. So nakita ng mga Malaysian authority, ng Thai authority. So in-explain ko naman, I'm a doctor, like this and like that. Pinakita ko, nag-opera ako sa field, pinakita ko, nandiri sila, nag-opera, tinanggal ko yung babae na namatay sa bata, sinuwang ng yak, yung sungay pumasok sa vagina, pumasok sa tiyan, sinuwag siya. Nang tinanggal, patay ng bata, hindi ko masay, pero tiningnan ko lang yung vagina, warak talaga yung internals. No? Wala tayong magawa. Sabi ko, patay na yan. So, may picture naman, pinakita ko. Para sila nandiri, yung mga frostbite, pinakitaan ko talaga ng mga warak-warak na putulin ko yung, gulat si Tay. Hindi ako naharangan. Sinamili ako ng sangkatutak gamot. So, mas maganda, puro ka lang epinephrine, kung wala kang amiodarone or lidocaine, mas make sense. Kesa nag-amiodarone ka na, hindi ka nag-epi. Pinakamaganda, epi ka muna. So kung ako tanongin niyo, paano ang rundown ko? First drug ko, epi. Second drug ko, epi pa rin. Third drug ko, pwedeng amio or lido. Since I have lots of amiodarone ako. Okay? Ang ginagawa ko sa lidocaine, pag nabuhay ko siya, pinapadrip ko si lidocaine. Lalo na medyo hindi pa maganda ang hemodynamics, pinapadrip ko si lido. So, ganun ang aking assembly. Then, advanced airway, pwede kang endotracheal tube or pwedeng supraglottic. Tapos, kapag naka-airway ka na, hindi na 30:2, asynchronous ka na. So, tuloy-tuloy lang yung CPR at 100 to 120 per minute. Tapos, ikaw naman, bag ka every 50 to 60, every 5 to 6 seconds, bag, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 1,000, 2,000, ganun na lang, asynchronous. Sa shock naman, biphasic. Anong ibig sabihin ng biphasic? Yung dalawang pads na nakalagay sa sternum saka sa apex. Dati kasi ang monophasic, 360, ang ceiling joules, no? 360. Nag-fire to, boom! Sasaluin ito. Bakit sasaluin? Kasi pag walang sasalo, ang electricity kakalat sa buong katawan. Bakit? Ang body ng tao, conductor siya kasi mayroong fluid. Di ba? Pag walang fluid ang katawan ng tao, hindi siya conductor. Para lang siyang rubber. No? Pero hindi naman ganon. Like Mother Earth, we are 70% water. Ang water, karamihan, nasaan? Kaya, alam niyo ba, nasaan ang water, karamihan? Intracellularly. Okay? Pinakamataas na water nasa loob ng cells. Of course, people, kasi doon naman kailangan sa metabolism. But what cells ng what? Saan si water mainly? Cells ng muscle. Kasi yung muscle, yun ang ginagamit natin sa araw-araw. So dahil ang muscle nakapalibot sa katawan, so pag nag-fire ako sa heart ko, kakainin ng ibang kasi water. So therefore, pag fire dito, may sasalo dito para meron kang pathway. So fire dito, boom! Salo dito. Yan ang monophasic. Nakita nila, according sa ebidensya, na ang 360 ay nakaka-harm ng heart. Nakaka-harm pala. So nag-invento sila ngayon na bakit hindi gawing dalawa na lang ang mag-fire. So ang ginawa nila, ganito, in a millisecond, fire to, salo to, fire to, salo to. Kaya biphasic. So binabaan na ang joules from 360, naging 200 na lang. So mas hindi siya harmful to cardiac cells. except na it fires two-way. Pero in a second, millisecond ang interval. Fire salo. Hindi pwedeng sabay dalawa salo kasi hindi magta-travel yung electricity. Kailangan ng electricity mag-travel sa heart para yung heart mag-contract. Kasi ang ating heart, ang kanyang cells, muscle cells, ay may self-contractility characteristic, no? So yan, biphasic, tapos monophasic. Ngayon, anong gagawin natin pag merong yung return of spontaneous circulation? So, kukunin natin ang pulse. Kung high-tech kayo, kung kaya niyong i-monitor ang cardiac output, good. May ultrasound kayo, no? Tapos blood pressure, yan ang pinaka-easy. And then, kuha natin ang biglang pag naka-intubate tapos merong capnometer, sisirit ka agad yan of more than 25. No? Ibig sabihin, nagpa-function na yung cell. And the last but not the least, spontaneous arterial pressure waves with intra-arterial monitoring. Kung merong intra-arterial monitoring. So, una, kasi in the absence of intra-arterial monitoring, no, kung wala kang line, pwede, yung pulse oximetry will do the job. Pero hindi talaga siya specific, no? Kung sa COR, parang 2A lang siya or 2B yata. Hindi kasi siya mabilis eh. Hindi katulad ng meron kang intra-arterial catheter para ma-monitor mo, makikita mo na okay na yung sipa ng heart. No? So, the hemodynamics. No? Hindi ibig sabihin na nabuhay ko siya, yung heart ko ay okay. Titingnan nyo, ano ang hemodynamics? Gaano kalakas siya sumipa? Kasi buhay nga siya, pero yung muscle, mahina sumipa. Paano niya ma-oxygenate yung brain? Eh, wala din silbi. Yan yung point dyan, people. Okay? Then we go into reversible causes, hypovolemia. Ito, pag sinabing reversible causes, ito yung, pag ni-reverse mo siya, masisolusyonan ko yung cardiac arrest. Kung anong dahilan. Halimbawa, blood loss ako. Pag may blood loss ako of 1 liter or 1.5, pag nag 1.5 dyan, ako, Diyos mio, hirap habulin yan. Kunwari, mga 70 systolic na lang ako dyan. Palpatory. Ang hirap, no? Yun yung point hanggang mag-cardiac arrest. Kahit anong gawin mo dyan, quality CPR ka, hindi mo ni-resolve yung hypovolemia, patay yan. Hypoxia, the same thing. Hindi ka makapag-advance airway. Hindi maganda yung airway, support. Tapos yung acidosis, hindi mo ma-reverse kasi una, hindi maganda yung airway support. Hypokalemia, hindi ka nakapagbigay ng sodium chloride saka potassium chloride, no? Hyperkalemia, hindi mo nabigyan ng mga calcium gluconate, yung mga glucose plus insulin. Hypothermia, hindi ka nakapagmaganda yung extracorporeal rewarming mo. Tension pneumothorax, hindi ka nakapag-needle decompression. Cardiac tamponade, hindi ka nakapag-pericardiocentesis. Toxins, hindi mo nabigay appropriate antidote. Thrombosis pulmonary, hindi ka wala kang heparin. Thrombosis coronary, kunwari ST elevation MI, hindi mo nabigyan ng appropriate yung mga pang-clot or hindi ka nakapag-PCI. So yan po yung reversible causes. Okay, so ito, another luma na ACLS rundown algorithm. Now we will go into non-arresting. Non-arresting, okay? So unang non-arresting ko ay tachyarrhythmia. Yung paano yung mabilis na puso na more than 150. So ang pasyente dumating sa iyo, hinuk mo sa cardiac sign sa cardiac monitor at more than 150, no? Tachyarrhythmia yan. So kailangan is the airway okay? Kasi bakit nag-tachyarrhythmia yan? May dahilan, may trigger. So nagbigay ka oxygen, then hook to cardiac monitor and identify the rhythm. Kasabay dyan, monitor blood pressure, tapos oximetry, pulse oximetry. Ngayon, hanapin mo, itong pinaka-importante, paulit-ulit to. Memorize this with all your heart. Hindi naman siya mahirap eh. No? Yung HASIA, H-A-S-I-A. H, hypotension. Anong hypotension? Less than 90 millimeters of mercury systolic. And or, altered mental status, responsive only to pain. No? Kunwari. And or, signs of shock. Putla siya, bagsak yung BP, and or ischemic chest discomfort according to the patient and or relative, and or acute heart failure kasi nung nakitaan mo siya, the heart cannot beat so well. So titingnan mo, pag yes, nako, unstable yon, pwede mo siyang ikandidato for synchronized cardioversion. I-explain ko paano, kung hindi pa kayo nakasubok ng cardioversion, i-explain ko paano ginagawa yan. But of course, you should know how to sedate the patient. So sa akin, ang pag-sedate ng patient, ako may ginagamit ko lang midazolam. Mabilis siya makapag-sedate. No? Tapos, habang piniprepare mo, kasi isi-sedate mo pa, it takes time konti, pwede ka mag-start ng adenosine 6 mg. Yan. So yes yan ha, any of those tachyarrhythmia, mga what causes kasama sa tachyarrhythmia mo. Pag hindi naman nakitaan na ganyan, ano ba ang QRS niya? Mamaya pag nag-aral tayo ng ECG, makikita niyo what do I mean by QRS. Wide QRS ba siya? Pag ibig sa wide QRS, hindi lumampas sa 3 small squares sa ECG which is 0.12 of a second. Pag yes, mandatory, i-IV natin, tapos bigyan natin ng adenosine 6 kung regular at monomorphic. Pag sinabing regular yung pagka-tachyarrhythmia, yung sirit-sirit ng BP, ng cardiac rate, tapos isang forma, monomorphic. Pero pag polymorphic, hindi maganda si adenosine dyan. Pwede si amiodarone. Okay? Consider anti-arrhythmic infusion, pwedeng lidocaine. Consider expert consult. Of course, ito kinukonsult talaga sa surgeon. No? Pero ang wide QRS, kunwari sa wide QRS ay hindi. Narrow QRS siya. So, pwede ka magbigay ng adenosine. Pero bago mag-adenosine, tingnan mo muna kung magre-react sa vagal maneuver. So, ang pag-vagal maneuver po ay binamassage to. Pero bago i-massage, lagyan mo na ng, pakinggan mo na sa ECG. No? ECG sa stethoscope. Baliktarin mo yung stethoscope, gamitin mo yung bell, pakinggan mo kung merong carotid bruit. Pag may carotid bruit, matakot ka. Kumpara mo sa kabila wala, dito meron. Ibig sabihin ito, baka may dissecting aneurysm yan. Ako, pag i-massage mo yan, pwedeng sumabog. So, assuming wala, negative. Nang minasage ko, makikita mo yung, kunwari, SVT, supraventricular tachycardia, babagal siya. That is one indicator na, SVT talaga. Yan, sa vagal maneuver. Tapos, you can give adenosine 6. After 3 minutes, persistent pa siya, you can give adenosine 12 mg. Or kung wala kang adenosine kasi namamahalan ka, mahal talaga adenosine pero napakaganda. Pwede ka mag-verapamil. Ako, between adenosine and verapamil, mas marami ako nagamit na verapamil. Lahat naman ang ginamitan kong verapamil nag-reverse. To be honest with you guys, hinahabol talaga ako ng SBT. Kung merong nai-inlove sa beauty, SBT. Ako, habulin talaga ako ng SBT sa pasyente. Lagi, ang pasyente ko, pag nahawakan ko, Diyos mio, mataas yung porsyento SBT. Hindi ako nawawala ng SBT 1 taon. Laging meron. No? Habulin. Kaya medyo tungto ako, home court ako sa SBT. Simula nung nasa abroad ako, hindi ko alam bakit. Parang sa akin natutuka ang SBT. So, kaya medyo nalaro ko si verapamil at saka adenosine. Ang problem lang ni adenosine, mahal. Pangalawa, ituturo ko siya tomorrow. Paano binibigay. Kasi ang problema kay adenosine, hindi mo siya pwedeng ibigay ng mabagal. Kasi 3 seconds na nasa blood vessel yan, pinapatay ng RBC, ng enzymes ng red blood cell. Kaya pag binigay si adenosine, mabilis, boom! Tapos bilis na NSS kaagad. Hindi pa bagal-bagal or else useless. Yan yung ayaw ko kay adenosine. Mahal na, maek-ek pa ibigay. Pangatlo, mas mababa ang kanyang shelf life. Ibig sabihin, magandang gamot siya pero mabilis siya masira. Lalo na kapag sa position ko na nabibilad sa init, minsan maiiwan mo yung drug kit mo sa ambulance, umiinit yon, or sa helicopter, umiinit yung loob, mas madali masira adenosine kumpara sa ibang gamot. So, yun lang yung ayaw. So, yan yung tachyarrhythmia. Then we go into, dito muna tayo sa rundown. Kung magka-cardiovert ka, again, kailan tayo magka-cardiovert? Okay, di ba sinabi ko? And or, presence ng hypotension. And or, altered mental status. And or, signs of shock. And or, ischemic chest discomfort. And or, acute heart failure. So, ika-cardiovert natin. Pero meron tayong dosing ng ating cardioversion. Pero katulad ng defibrillation, yung dosing ng cardioversion is also by joules. Joules din ginagamit. Kaya pareho lang siya ng panel. Pag meron kayong makabagong cardiac monitor kung defibrillator, pareho lang ang panel ng defibrillation sa cardioversion. Pareho lang siya. Pinipindot lang yung sync SYNC doon sa button to make it cardioversion mode. Ang humihiwalay, kasi magkaiba na ang ating ginagamit na power supply, the power unit, energy unit, ay yung transcutaneous spacing. Kasi gumagamit siya ng milliamperage. Okay, balik ako sa cardioversion. Pag narrow regular, ibig sabihin regular, na maganda tingnan, SBT, pwede ka gumamit as low as 50 joules lang. So, na-adjust. Yan yung hindi kayang gawin ng AED. Kaya sabi ko sa inyo, pag hospital, hindi tayo pwede mag-AED. Because AED cannot cardiovert the patient. Ang AED ay pang layman. Hindi naman po tayo layman. Tayo talaga yung professional provider, doctor, nurse. Kaya alam natin yung machine. Maraming nag-actor-actoran. Yan ang sinabi sa libro. Ako, pag pangaralan pa ako, hindi ko naman sinabi magaling ako. Siyempre, specialty mo yun eh. Up to the point, German product, endorser pa ako ng defibrillator. Kaya may sarili akong defibrillator, dalawa. Na AED. Saka meron din akong manual defibrillator, 3. Yung isa, sira na. Dinonate ko lang sa EMTs ko. Yung dalawa, malaunan, kinailangan ng Presidential Security Group, dinonate ko rin. Ako yung nawalan. So, yun. So, pag narrow irregular, narrow siya, masyadong sikip, dikit-dikit yung QRS. Tapos irregular, may pataas, may pababa, pwede ka mag 120 to 200 joules. Kasi ang ceiling niya is 200. No? Pag wide naman, tapos regular, okay yung 100. Pag wide irregular, you don't need to cardiovert. Pwede ka na mag-defib. Kasi usually itong arresting na to. So, anong dosage ng adenosine? Pinaka first drug natin sa tachyarrhythmia. Except kapag wide QRS. Irregular. So, pinakaunang drug is adenosine, which is given at 6 milligrams. Second dose is 12. Tapos mag-third dose, 12 na. 6, 12, 12. Okay. Ngayon, mga infusion, although sa amin, third tier ang prokinamide. No? 20 to 50 milligram per minute hanggang ma-reverse mo yung tachyarrhythmia. Okay? Tapos maintenance infusion mo is 1 to 4 milligram per minute. Ang amiodarone naman, 150 binibigay mo kasi yan yung prep talaga niya. So 10 minutes siya. Hindi mo kailangan ibolus kasi hindi naman siya ka-arresting rhythm. Okay? Sotalol, pag maganda ang BP, okay si Sotalol, 100 milligram, no? Over 5 minutes siya. So yan ang ating tachyarrhythmia. Now let's go into bradyarrhythmia. Less than 50 per minute. So again, ang pasyente, i-assess natin kung okay ba ang oxygenation, airway, i-hook natin sa oxygen, then we hook the patient to cardiac monitor, tapos identify ang rhythm, tingnan ang blood pressure, pulse oximetry, IV access kaagad ha. Ito, IV access tayo. And request for ECG, yung ibang doktor minsan nagre-request pa for X-ray. So, balik ulit ako, ano ang pasyente? Nagbabrady siya, anong meron? Meron ba siyang hypotension? Hasiya ulit. Meron bang altered mental status? Meron bang signs of shock, ischemic chest discomfort, and acute heart failure? Pag wala, monitor lang ang pasyente. Pag meron, we can start up atropine IV dose 1 milligram. So, monitor lang ng monitor, ang interval 3 to 5 minutes. No? Hanggang ma-achieve natin ang 3. Nakita natin na very stubborn, 40 pa rin ako. Pwede ka magbigay ng dopamine. No? Dopamine ka. Pero if the patient becomes more ugly, pwede ka na mag-prepare for transcutaneous spacing. So, hindi ko ile-lecture ang transcutaneous spacing kasi ile-lecture ko siya paano siya ginagawa kapag meron na tayong
kapag nag-lecture na ako on electrical therapy. Yan. So, sa atropine, usually, pag katulad ginawa ko sa pasyente ko, galing Sambales, hindi umubra sa atropine, nagdopa ako. So, ang dopamine ko, dati sa lumang tugtugin, merong 3 dosing. Yung 1 to 5, tinatawag namin renal dose, 5 to 10, cardiac dose, saka 10 to 20, vasopressor dose. Ngayon, hindi na po ginagamit yan. So, meron tayong 5 to 20 mg per kilogram, tinatitrate lang yan. No? So, tinitingnan natin kung umubra, taasan mo hanggang max of 20 microgram per kilogram. Of course, refer to cardiology. Now, ladies and gentlemen, what if the patient is nag-CPR ka, biglang nabuhay na, pero questionable pa yung hemodynamics. So, continue yung ventilation. Ang FiO2 natin, achieve natin 92, yung saturation 92 to 98. Tapos, as much as possible, naka-advance airway na kasi siyempre, interim guidelines of 2022. Tapos, capnometry mo, and always note, do not hyperventilate kung nagbabag ka. Pag ang patient is hypotensive, like less than 90 millimeters of mercury, you can create IV or IO bolus. Ako, ginagawa ko minsan initial 200 ako. Fast drip, 200 yan. Hanggang 1 liter, tinitingnan ko. No? Tapos, pwede ka mag-vasopressor infusion. Tapos, hanapin mo ano yung treatable cause. Pero pag ang pasyente, kunwari, nag-cardiac arrest because of MI, bantayan mo na the MI might still be there. Kaya, tingnan natin kung STEMI siya, hindi siya mag-progress into cardiogenic shock, no? And as much as possible, dalhin natin siya sa ICU para mapuha pa, we can perform other diagnostics and more pronounced, more appropriate intervention. So again, avoid excessive ventilation, 10 breaths per minute ka lang, titrate, target PETCO of 35 to 40, that's the normal range. When feasible, titrate if IO2, na-achieve natin is 92 to 98. IV bolus, sorry pala, hindi 200 ml, 2 liters pala. IV bolus from 1 liter to 2 liters. So, tinatansya ko kung kaya naman 1 liter. Yan. So, 1 liter to 2 liters, no? LR or normal saline. Hindi ko pa nagawa, ayaw ko mag-aktor-aktoran, pero hindi ko pa nagawa yung tinatawag na therapeutic hypothermia. Pero ginagawa yan for stroke, no? Yung meron kang 4 degrees centigrade NSS, binigay mo sa pasyente, lamig yun. Parang kinakryo mo yung pasyente while en route to the hospital. No? Pag gusto mo mag-epinephrine infusion, of which I am not a fan, you can give it a 2 to 10 microgram per minute. Dopamine naman is 5 to 20 microgram per minute. Tapos pag NOR-E, so i-rundown ko na pag pharma. Pag nag-pharma na ako, i-rundown ko. Kaninang umaga, na-discuss ko tong stroke. Be fast. So, ganun lang din initially ang ginagawa natin. Is there loss of balance? Is there like brain foggy? Wala ang memory. Is there like behavioral change? With or without headache or dizziness? And or is there blurring of vision, acute? And or facial asymmetry, biglaan? And or arms and leg weakness on one side? And or slurring of speech? So this patient must be brought directly to the hospital. Pag nasa hospital ka, di ba kanina sabi ko cold blue team? I don't know if you have stroke team. So tatawagin mo stroke team. Though it is under ACLS, but stroke is a whole wide world all by itself. So hindi cold blue team ang tinatawag mo dito. Ang tinatawag mo ay stroke team. So anong management sa stroke? Ito ngayon yung medyo problema ngayon kasi hindi tugma sa Pilipinas. Kasi dito pa lang sa EMS, Emergency Medical Services, ito po yung ambulance. Ang tikas na. Ang patient may stroke, ina-achieve natin yung tinatawag ng mga time goals natin. Makikita yung time goals na dito sa left. I-explain ko yan a little bit later. Sa ambulansya pa lang, ladies and gentlemen,
meron ka ng ABC. Bigay ka ng oxygen, nasal cannula. Tapos, pre-hospital stroke assessment. Yun yung binigay ko kanina, yung BFAS. So, niraradyo mo sa hospital. Present po, meron po siyang facial asymmetry, merong arm and leg weakness on one side, left side, kunwari ganun. Tapos, glucometer. Then, tingnan mo kung kailan sa kamag-anak, time of onset of symptom. Titingnan natin ito mamaya. Kasi sa onset of symptoms, hanggang dito sa ER kung ilang oras, minomonitor natin ito kasi we are trying to save the brain. Tapos, the ambulance, siyempre may radyo yan, inactivate na po yung stroke unit sa ospital. Okay? Stroke team, no? Pagdating sa ER, within 10 minutes dapat nasa ER, no? Katawat-tawat. Hindi mangyayari sa Pilipinas, no? Baka 10 hours. So 10 minutes dapat nasa ER, no? Baka imposible, no? With 10 minutes, kailangan may nagawa to ang ER. Anong ginawa ng ER? May IV access, kung walang IV access, glucose, 12-lead ECG, neurologic screening, DEC-4 CT scan of the brain. So nagawa to. 10 minutes ulit. Okay? Then, after 10 minutes, endorsed na CT scan, diagnostic, with no hemorrhage. Ito yung ina-achieve natin. Ideal, dapat no hemorrhage. Pag may hemorrhage, medyo madugo siya. So dito muna ako sa no hemorrhage. Check fibrinolytic exclusion. Sino magche-check nito? Yun na yung neurologist. Ongoing neurologic exam kung merong deficit or deficiency, disability, nag-improve ba or normal after initial treatment mo kanina, no? Tapos patient remains candidate for fibrinolytic therapy. So bahala na si neurologist kung bahala ka anong ginawa, no? Yung RTPA. So from CT scan, meron tayong naubos na 60 minutes. Within 1 hour, tapos to lahat. And within 3 hours, dapat ang pasyente ay nasa fibrinolytic therapy na. Okay? Yan yung tinatawag nating door to admission, stroke admission. 3 hours. Grabe, no? 3 hours. Kaya ba sa Pilipinas yun? Assuming may hemorrhage siya, neuro pa rin, tapos titingnan natin kung ano ang nakita sa CT scan through ICU. So, bahala na. Depende, case-to-case basis. Pwede mong decompress with mannitol or what. Let's go into acute coronary syndrome. Sa acute coronary syndrome, ambulance ulit. So makikita natin, ambulance ulit, oh. EMS ulit, oh. Grabe. Tikas, no? So, the patient has chest pain. Kinuha ng ambulansya. Pagdating sa ambulansya, MONA. Tingnan nyo, ha? Hindi kaya ng Pilipinas tong MONA. Una, ang MONA, MONA, ginawa ng ambulance, may oxygen kaagad. Tingnan mo, oras din to. Binigyan ng aspirin ng 160 to 325 milligrams. Chew, ha? Chew. Ichuchu mo. Hinok sa 12-lead ECG while en route to the hospital. Tinawagan ng hospital, bypassing papunta sa cardiac cath lab. Pwede pong bypass tab yan. Tapos, may morphine, nagbigay ng morphine for pain control, saka pabagsakin ng preload. Tapos, nitroglycerin of 4 microgram or 5 microgram sublingually. Wow! Yan po ang ginagawa ng ambulance, which is not in the country. Yan pa lang, hindi na obra. Pagdating sa ER, dapat nasa ER less than 10 minutes to 10 minutes. Grabe, no? Pangalawang hindi naman possible sa Pilipinas. No? Sa pagdating sa ER, mabilisan, recheck ng vital signs, pwedeng gawin ulit yung MONA, IV access siya, tapos perform ng cardiac markers, activate cardiac cath lab kung hindi pa natawag. Pero kung nag-usap na maayos, pwedeng diretso sa cath lab, same thing. Gagamutin ng oxygen, aspirin, morphine, nitroglycerin. Okay? Tapos P2Y inhibitor. So, dalawa. Ngayon, lumabas sa ECG, nasa 3 lang. Pinakagusto natin ay ST elevation MI. Bakit? Marami kang malaro sa ST elevation MI. Ang tingnan nyo start adjunctive therapies. Do not delay reperfusion. Okay, take note, reperfusion. Time from onset of symptoms, tinanong sa kamag-anak, hanggang nandito ngayon, papunta sa ospital, papunta na sa CU. Less than 12 hours ba? Pag less than 12 hours, kayang-kaya sa reperfusion goals na tinatawag nating door to balloon or medical contact to balloon. Yan dati door to balloon, ngayon medical contact. Ang medical contact, by the time na tumawag ka doon ang starting, hindi starting kinuha mo sa bahay. Sa lumang tugtugin, nung panahon ko, door to balloon. Ngayon, tinatawag na medical contact to balloon. So, para ma-PCI natin siya, no? So, ang ating achievement is 90 minutes. Grabe. So, door to needle, goal of 30 minutes. Tindi, no? Pero sa more than 12 hours na, monitor lang natin yung trop I, tapos tingnan natin kung ano ang pwedeng ibigay natin, magna-nitroglycerin ba? So depende gaano kalaki yung MI or mag-ultra low molecular weight or mag-H inhibitor, depende. Depende sa cardiologist. Meron ding tinatawag na low intermediate risk ACS. Yung wala kang halos makita, pero may chest pain. So repeat mo lang si ECG, tingnan mo kung mayroon ka makita sa mga clinical high-risk features, no? Tapos tingnan mo kung troponin indicated, troponin elevated ba, sorry. So pag abnormal diagnostic, pwede ka mag non-invasive imaging. So case-to-case basis kasi ito yung algorithm natin for ACS. So high quality CPR is 100 to 120 compression, 2 inches deep. Okay? Push hard, push fast. Yan, 2 to 2.4 inches with adequate recoil. Minimize interruption or compression. Avoid hyperventilation. Then yung ACLS, you can do advanced airway na. Now, this is your capnometry. I will discuss about it pagdating natin sa airway. Okay? So yan si capnometry. Now, yung ating mechanical CPR devices or tamper, maraming klase. Depende kung anong preference din, no? So, ito yung nagbibigay ng compression. So, merong Zoll, merong Lucas, no? And this make things easy. No? Currently available devices include the Lund University, yung tinatawag na Lucas, Lund University, Cardiopulmonary Assist System. Stryker, gumawa din, Kalamazoo. Tapos si Zoll na Autopulse. Okay? So yung ginagamit ko ay si Autopulse at saka yung tamper nung lumang panahon. So optimizing the quality of CPR remains a crucial factor. So si tamper will help you with that. Para si tamper kasi machine lang siya. Nakokontrol niya yung rate saka yung lalim. Kasi machine. No? Program siya sa ganun. So katulad dito sa picture. Ngayon, meron ding pinag-aaralan kung pwede magamit si extracorporeal membrane oxygenation si ECMO. So hindi pa talaga naka-take off to sa pre-hospital care. Pero na maganda to kasi na-oxygenate niya, para siyang dialysis, na-oxygenate niya yung blood. No? So, ganyan ang mechanics. Ginamit to sa pre-hospital care, nakalimutan ko kung Germany or France. Galing nito. Nag-ECMO sila sa field. So ayan yung mga pre-hospital extracorporeal cardiopulmonary station. Meron din tayo for trauma, yung tinatawag na erythromer. Ano yung erythromer? Ito yung artificial blood. Hindi na kailangan ng O negative para ibigay. So itong artificial blood, pwede siya mag-carry ng oxygen. Ang galing, no? Tapos mahaba ang shelf life niya kasi powder lang, sa kanila lagyan mo na lang ng liquid. Okay? Actually, this is a military item. Artificial blood, kaya mag-deliver na oxygen. Bioengineered siya to mimic red blood cells. Galing na. Tapos freeze, dried, sterilized powder. Tapos i-reconstitution with IV fluids lang, magiging blood na siya. Temporary transfusion, lalo na sa battlefield. Okay? I'll give you a break muna, mga 7 minutes. Tapos pupunta tayo sa ECG. At tapusin ko lang to reversible contact. O tapusin ko na lang ha, tapusin ko na lang. Saglit. So hypoxia, ang objective natin, PaO2 of 55 to 60 millimeters of mercury, which corresponds to 90 up, no? And then, hypovolemia, kailangan ma-treat natin sa hypovolemic shock para hindi tayo magkaroon ng end organ damage, particularly brain. Ito si hydrogen ion, kailangan lang good oxygenation. So, yan lang naman. So, I'll give you a break. Then, pupunta na tayo sa ECG. Okay? Unless you have any questions. After ECG, meron tayong macron, parang exam sa ECG, kung may natutunan. Pero sasagot kayo dito sa chat. So, minomonitor lang ni WIPAM kung sino ang nakapasa. Okay, so sige. 7 minutes break, then go back for ECG reading. Now, let's go ECG. Natakot sa ECG ah. Saan na yung iba? Okay. So, medyo now let's go into ECG. This is one of the separate evaluation program, skills program. Napaka-unique dito kasi actually there are 3 exams supposedly sa ideal ACLS. Yung general ACLS program, ECG reading, at saka mega code. 3 exam. Pag dinagsak mo yung general ACLS, uulit ka sa buong ACLS. Pag binagsak mo yung ECG, sa ECG ka lang uulit. Pag binagsak mo yung mega code, sa mega code ka lang uulit. Yan, mga ganun lang yan. So, let's start our ECG by clarifying na yung slides ko ay 2003, wala namang nagbago sa ECG. Ang nagbago lang, naging sophisticated lang yung machine. So our objective is to interpret ECG and 5 steps to know what to find in ECG. Okay, yung heart rate, interval, QRS complex, tapos paano magbasa ng heart rate using the 6-second lead. As you can see, that our heart is, it's a 3-organ thing. First is a mechanical organ, meaning it's a muscle, it pumps. Nami-measure natin sa blood pressure. Then it's a chemical organ. Pag distress siya, nagre-release siya ng mga chemicals na ma-indicate na sa distress siya, katulad ng TROP-I, LDH. No? Then it's an electrical organ na nakikita natin siya via ECG. So ngayon, titignan natin siya as a mechanical or as an electrical organ. So CSA node, pag hiwa-hiwain ko yung ECG ko, CSA node, it's the primary pacemaker of the heart. By the way, of the 3 classes of muscle cells sa katawan, you have the skeletal muscle cells, skeletal muscle, which is a voluntary muscle, no? Mautusan mo, yan, striated siya, makikita mo sa microscope. Parang ganun din si cardiac muscle, except si cardiac muscle, self-excitatory siya. Tanggalin ko yung aking muscle dito sa arm or sa forearm, ilagay ko dito sa harap niyo, wala siya. Tanggalin ko yung heart ko, ilagay ko sa harap niyo, magugulat kayo, wala na sa katawan ko, nagpipit siya. Kasi self-excitatory. And of course, we have the soft muscle. So, yan po yung naglaline sa ating blood vessels, naglaline sa vaginal canal, naglaline sa airway, yung mga soft muscle. I cannot control it. It reacts on stretching, it reacts on hormone, it reacts on chemicals no, that innervates it. So, the electrical pathway, parang Meralco ng ating heart, magsisimula sa SA node or sinoatrial node. So, siya yung, ang firing rate niya is 60 to 100 beats per minute. So, tatanggalin ko siya, yan siya. Okay? Then, si AB node is 40 to 60 per minute. Kasama si bundle of his. Then, yung pinakadulo, si Purkinje fibers, 20 to 40. Aba, kung wala na pala akong mga SA node, hindi pala ako mabubuhay. Kaya ka pang buhay ng Purkinje fiber. Bakit? Yung 20 to 40, hindi lang siya 20 to 40. Pwede po siya mag-accelerate. Ang tawag dyan, accelerated beat, no? Wide QRS siya kasi Purkinje siya, wide QRS. Pero accelerated to as instructed by the brain to provide adequate oxygenation to the brain, no? Ganyan. Now, ang ECG natin can detect heart rate, regularity and irregularity of the rhythm, and of course time interval. Babasahin natin yung horizontal niya, hindi yung vertical deflections, no? Horizontal lang, which is measured in seconds. So yung conduction time intervals, and then makikita natin yung conduction pathways, heart block and others, no? Hindi natin makikita ang pump action, cardiac output, blood pressure. That's not easy. Although, in very good eyes, lalo na mga cardiologists, nakikita nila kapag merong hypertrophy. Dito, doon lang tayo sa baseline na hindi natin alam. So, ECG is the graphic representation of the electrical activity of the heart. And it is recorded, no, doon sa strip. Hindi katulad sa inyo ngayon, computerized na lahat. Sa amin noon, strip lang talaga, tuloy-tuloy lang yung strip din. Tapos, ang nagbibigay ng marker ay yung stylus. Mainit po yung stylus paghawakan. Now, if we go here, dito muna tayo. So, itong linya na to, nakikita niyo ang cursor ko. Ang tawag dyan, baseline. Ang significance dyan is, yan yung ating susukatan kung ano ang deflection. Pag positive deflection pataas, negative deflection pababa. Pag nakakita kayo ng pataas, ang tawag dyan waveform. Okay? Then, pababa, another waveform. Tapos pataas, waveform. Pababa, waveform. Tapos balik sa baseline, waveform. Ngayon, waveform. Tapos mayroong linya. Tapos may waveform. Ang tawag sa linya na yan, segment. Okay? Tandaan yung word segment. Meron akong waveform Q, merong waveform R, merong waveform S. Anong ibig sabihin nun? So, series of waveform, ang tawag dyan ay complex. Katulad ng QRS complex, tinawag sa kasi series of waveform siya. Then, the waveform plus segment, ang tawag dyan interval. Katulad ng PR interval. So, one waveform plus another segment, ang tawag is interval. That's why it's called PR interval. Eh, bakit PR interval? It's a Q siya huminto. Okay, ganito po yan ha. We have the Q, the R, and the S. Pero tanungin ko kayo, sa QRS waveforms, sino ang pinaka-dominant? Si R. So, siya yung parang sa dinosaurian principle, kung sino yung pinakamalakas or pinakamalaki, pinakamalakas mag-growl, parang si lion, nakikaya sa King of the Jungle. So, tinawag siyang R, kaya PR interval. So, mamaya pag-usapan natin yung PR interval, particularly pag sa heart block. So, again, waveform, segment. Ang waveform plus segment is called interval. Then, we have the QRS, series of waveforms is called a complex. Then, another segment. Papunta sa T, which is a waveform. By the way, si P is your atrial depolarization. Nag-contract si atrium. After less than a second, mako-contract si ventricles. Tapos ito, si repolarization of the heart manifested in your T, meaning there's no activity in the heart. At the moment, the heart cannot be activated except externally. Pag nag-fire ka ng defibrillator, dyan siya nag-fire, wala tayong magawa. So yan ha, PQRST. Lipat ako sa kanan. Itong ECG, merong big square or big box at merong small squares or small box. So I'll just call it squares. Itong big square has 25 small boxes. Pero ang i-measure ko lang ay yung 5 horizontally. So si big box na yan, kung i-measure ko yan, tatakbo horizontally, it's around 0.20 of a seconds pag tumakbo siya. So kailangan 5 nito, 1, 2, 3, 4, 5. Pagtakbo ng 5 na yan, nasagasaan yung 5 na yan ng stylus sa pitik ng 1 segundo. Within 1 second, 5 haba ng 5 big boxes. Okay? Therefore, inside the 0.02 width by time, no? I-breakdown ko yung 5, naging 0.04 na lang siya. Ganyan tayo mag-measure. Papakialaman natin yan kasi dyan natin makikita kapag may heart block, dyan natin makikita kapag merong YQRS complex. Okay. So, question, bago umusad. Wala akong pakialam pataas ha. Huwag ka munang magpataas. Out muna si pataas. Horizontal lang, hindi vertical. Pag horizontal, time. Pag pataas, it talks about voltage. Hindi pinag-uusapan pa si voltage dito. Saka na yan. No question. Okay. Usap tayo. So, ayan. First, makikita niyo yung upward deflection or positive deflection. That's your P wave, which is nag-fire si SA node at the same time nag-contract si auricles or si atria. Tapos PR interval, yung PR interval, ito yung time frame from 3 small squares, yung small squares, 3 small squares to 5 small squares. So 3 small squares, 3 times 0.04 is 0.12. into 5 small squares, 5 times 0.04 is 20. So 12 to 20 of a second, yan lang yung PR interval mo. More than 20 of a second, there is already a problem. It's already like a heart block sa PR interval. Okay. Anong purpose noon? To allow the travel of the blood from the atria towards the ventricles. Yan yun. Now here comes the QRS complex. Ang QRS natin, to say that it is narrow, dapat hindi lalampas ng 3 small squares. Ibig sabihin, 0.12, di ba? 0.04 times 3. Kasi 0.04 ang small squares eh. So hindi siya lalampas. Pag lumampas sa 0.12, ang tawag doon wide QRS. Okay. Now we have the T wave now ito, which is the repolarization of the heart. No? Resting phase siya ng cardiac cycle to prepare for another cardiac cycle. So, pahinga si heart. Now let's go into identifying heart rate, rhythm, P wave, the presence of P wave. Hanapin natin pag may P wave kasi pag walang P wave, therefore it is not a sinus rhythm. Kasi hindi ang heart nagko-contract. Pag hindi na sinus rhythm, papangalanan natin siya kung saan galing. Pero pag nakakita ka ng P wave, always put the word sinus. Normal sinus rhythm, sinus tachycardia, sinus arrhythmia, sinus bradycardia. The word sinus there signifies that the impulse comes from the sinoatrial node. Okay. So heart rate, heart rhythm, P wave, PR interval, at saka QRS complex. Okay, tingnan natin. Si heart rate, bago natin malalaman si heart rate, tingnan nyo, hanapin nyo sa ibaba itong broad mark. Broad mark, broad mark. Per 1 second, ito broad mark, 1 second, 2 seconds, 3 seconds. Tapos 4 seconds, 5 seconds, 6 seconds. So kailangan meron akong 3 broad marks to say that we have a 6-second lead. Okay? So anong gagawin natin? So pag may 6-second lead, bibilangin ko lang yung R. 1, 2, 3, 4, 5, 6, 7, 8. I-times 10 ko lang, then I have 80. 6-second method, 6-second strip, o 6 second, no? Bawat 5, isang segundo, di ba? 0.20, 0.20, 0.20, 0.20, 0.20, that's 100 or 1 second. So 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. Bilangin mo yung R, 80 times 10, this is 80 beats per minute. In the context of ECG, ganyan po tayo. Multiplication by R in 6 seconds. Hindi po tayo gumagamit ng division method. Kasi kapag merong irregular rhythm, hindi po uubra si division method. O ngayon, ilang heart rate nito? Kagad kayo sumagot, tingnan nyo muna kung 6 second. O, 6 second. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 100 po yan. That's 100 beats per minute. Oh, ang dali lang pala ng ECG, no? Sisiw. Kayang-kaya ng grade 1. Pag kayang basahin ng grade 1 at hindi nyo kayang basahin yan, may problema na kayo sa mundo. So, titingin tayo sa rhythm. Ang sa rhythm naman is simple lang. Mata-mata lang tayo. R to R, equidistant ba siya? So, kuha ka ng papel, markahan mo yung R to R, idugma mo sa kung equidistant dito. So, ito isang tingin lang equidistant yan. So, ang tawag dyan ay regular rhythm. Kailan nagiging irregular rhythm? Kanwari ito, biglang lumapit. Tapos, same distance na naman. Same distance. Biglang ito lumapit dyan. Ang tawag dyan, irregular rhythm. Okay? Pero, pag nakakita kang ganito, biglang lumayo, lumapit, sobrang lapit, biglang sobrang layo, malayo konti, sobrang lapit, malapit, biglang malayo, ganon. Irregular rhythm. Okay? So sa rhythm, R2R or P2P, makikita natin irregular pag more than 0.06 seconds yung variation ng R2R mo. So let's look at the P waves. Balik ulit ako. Katulad dito, P, Q, R, S, T. P, Q, R, S, T. So may P wave siya, therefore it's a sinus rhythm. Ngayon, dahil sinus rhythm siya, regular siya, tapos ang rate niya ay 60 to 100, ang tawag sa kanya, normal sinus rhythm. Let's go into PR interval. Ang PR interval, yung P mo, atrial contraction, ay lumampas ng 0.20. Lumampas siya. From 3 to 5 small squares, naging 6, 7, 8, lumampas siya. Therefore, prolonged PR interval yun. Huwag na natin pag-usapan yung less than 0.12 kasi ang early take-off yun, nakikita natin sa drug addiction or sa Wolff-Parkinson-White syndrome. So, huwag natin pag-usapan kasi hindi siya ACLS topic. QRS, dapat tatlo lang. Sa loob ng QRS, dapat tatlong small squares. Pag lumampas ka sa tatlong small squares, ang tawag sa kanya ay wide QRS. Okay, ito. Para wag tayo ha. Pag nakakita kayong ganito, tapos masyadong sharp yung edges, hindi mabasa, ibig sabihin, artifact yan. May sira ang lead or yung machine ninyo or ang pasyente nagkikilos-kilos. Pansinin nyo, ang R2R equal equidistant. Equidistant siya. Okay? Bakit nagkakaroon ng artifact? Patient movement, loose or defective electrodes. Pag natanggal yung electrode, flatline yan. Natanggal sa akin yung electrode, flatline, diretso yan. Improper grounding, kasi nung lumang panahon ko pa, nung medical student ako, yung ECG namin, kinakabit pa namin sa bakal sa bintana, kung saan ang pasyente doon, no? Ikakabit namin sa bintana para mawala yung grounding. Ganun kami ka-antiquated, no? Improper grounding, tapos faulty ECG apparatus. Okay? Now, types of rhythms, titingnan natin. Meron tayong brady pag below 60. Tapos normal rate, normal rate. Tapos tachycardia of more than 100. Saan galing ang rhythm na yon? Pag nakakita ka ng P-wave, sinus rhythm. Pag hindi na siya P-wave, hanapin mo kung atrial rhythm or ventricular rhythm na siya. Okay, let's go to those rhythms. There are 4 sinus rhythms. Kulang to. Normal sinus rhythm, sinus brady, sinus tachy, saka sinus arrhythmia. Okay. Number 1. Tanong. What is the rate? Babalik ulit tayo sa rate. So, 6 second lead. Okay, 1, 3, 6. Okay, tama yan. 6 second lead. Bibilang ko, nakatago isa. 1, 2, 3, 4, 5, 6, 7, 8. Therefore, my rate is 80. What is the rhythm? Titingnan ko ang layo niya, equidistant o normal rhythm. Titingnan ko presence of P-wave. Aba, may P-wave ako. PR interval, sakto, hindi lumampas ng 0.20. QRS ko, hindi lumampas ng 3 small squares. Ang tawag po dito, ladies and gentlemen, is normal sinus rhythm. Dali lang, no? Lagi mong babalikan si rate, rhythm, PR interval, QRS complex. Of course, presence of P. Balik ako kay sinus arrhythmia. Kunwari ito, sandita. Alam ko medyo mabigat na to. Okay. So, meron akong rhythm. Meron akong rate. Kunwari 80. Pag tinignan ko yung rhythm, guys, kunwari medyo malayo itong isa. Tapos, ano siya, equidistant na. Biglang lumayo yung isa, equidistant. Or biglang malapit yung isa, equidistant. So, ang tawag, tapos may P-wave ako, PR interval, tama lang. QRS narrow. Ang tawag sa kanya is sinus arrhythmia. So wala tayong gagawin dyan kasi minsan common among teenagers, even athletes, they have sinus arrhythmia. So there's no problem. Ngayon, let's go into another, which is the brady. Okay, bilangin natin. Ang rate niya is 40. 6-second lead. 1, 2, and 3. Okay. 40 siya. What is it a regular rhythm? So kung titingnan ko yung distance, equidistant siya. Makikita mo, hindi mo na kailangan i-measure yan. Gaano kalayo ang isa't isa ang R. May P-wave ba? Yes, may P-wave. PR interval, tama lang, hindi lumampas sa 5 small squares. QR interval, QRS, yes, hindi lumampas sa 3 small squares. So, below 60 siya or below 50, ang tawag sa kanya is sinus bradycardia. Sinus kasi may P-wave. Now, let's go into the fourth. Bilangin natin. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Times 10 kasi 6-second lead, that's 120. Rhythm niya, regular kasi equidistant. Is there P-wave? Ayan ang P, PQRST, PQRST, PQRST. So may P-wave. PR interval, within normal range. QRS, narrow. So it's called sinus tachycardia. Ang dali lang pala eh. No? Hindi pala rocket science siya. Hindi pala rocket science. Now, ngayon, pupunta na tayo sa rhythm other than sinus. Hindi na nanggagaling sa sinoatrial node. Atrial rhythm na siya. SA, sinoatrial node, fails to generate an impulse. Wala nang SA, therefore wala na akong P. The atrial tissue or areas in the internodal pathways, doon na nanggagaling yung impulse. These are called atrial dysrhythmias. Hindi naman siya life-threatening, pero kailangan lang laging kasi katulad ng it might cause other problems like embolus, katulad ng ano ito? Grabe ang memory ko. Atrial fibrillation. Pagpabayaan mo yung atrial fibrillation, hindi ka magbigay ng clopidogrel or sa lumang panahon aspirin, pwede siya magkaroon ng embolus. So there are 3 atrial rhythms: atrial flutter, atrial fibrillation, saka SVT. So dito tayo sa atrial flutter. 6-second lead ulit. Balik ulit tayo sa rhythm. 6-second lead. 1, 3, 6. Bilangin ko ang R. 1, 2, 3, 4, 5, 6, 7, 8. 80. Ngayon, is there P? Wala. Hindi mo alam saan si P dyan. So, wala kang PR interval. Diretso ko QRS. Sorry. Equidistant ba? Yes. Automatically, it's equidistant. PR interval is narrow. Makikita nyo, tatlong ngipin na parang lagari. Kaya ang tawag sa kanya, sawtooth in appearance. 3:1 yan. Pag apat, 4:1. No? There is 2:1. Ang 2:1 is rapid ventricular response. Pag 1:1, hindi na po yan flutter. Tawag na po dyan, SVT na po. So, ito. Yan So, wala akong P. Ang impulse yun ang gagaling mismo sa atrial walls or somewhere in the atria pa rin. Ang maganda sa kanya ay ang QRS hindi rapid. Kasi ang kinakatakutan lang natin sa flutter kapag mabilis na yung pag merong rapid ventricular response kasi doon napapagod si heart. Okay? So that's your atrial flutter. The most significant feature is sawtooth, ngipin ng lagari. Okay, let's go into the next, atrial fibrillation. Ito ngayon yung problema.
Bilangin natin sa 6-second lead. 1, 2, 3, 4, 5, 6, 7, 8, 9, 90. Ayos ha. What is the rhythm? O, tingin kayo dito ha, kasi may pagkakaiba dito. Malapit? Malayo? Aba, sobrang layo. Medyo sobrang lapit. Lumayo konti. Sobrang lapit. Lumayo konti. Sobrang layo. So, ibig sabihin, pabago-bago ang sipot ng QRS. Ang tawag sa rhythm na yan ay irregular rhythm. So, napaka-unique niya kasi siya lang yung nagbibigay ng irregular rhythm. Saan si P? Hindi mo alam. Sabay-sabay, mayroong nagbibigay ng impulse sa atrial wall, sa internodal tracts. Di natin alam saan. Pero ang maganda sa kanya, narrow QRS siya. Next is, hindi lumalampas ng 100 ang kanyang ventricular response. Or atrial fibrillation with no rapid ventricular response. Kasi hindi lumampas ng 100. Pag lumampas ng 100 yan, sumirit yan ng 140, yun yung problema. Ang tawag doon, RVR. Atrial fibrillation with rapid ventricular response. Ito, normal. Anong ginagawa natin sa pasyente dito? Binibigyan lang natin siya ng clopidogrel or aspirin kung makaluma ka. Then, we have the SVT. Ito, suki ako dito. Bilangin ko siya, ayoko nang bilangin, sobrang dami. Hindi ko siya bumababa ng 150. That's 150 to 250 po. Equidistant po, yes. Ang tawag nito is monophasic. Merong P, wala. QRS, narrow. Dito tayo magka-cardiovert. Kung unstable siya. Ano yung pagiging unstable? Presence of hasiya, hypotension, and or acute altered mental status, and or signs of shock, and or ischemic chest discomfort, and or acute heart failure. So, kailangan natin ma-reverse to by cardioversion, chemical, or electrical cardioversion. So, yan lang po yung tatlo na atrial rhythm. Number 1 is atrial flutter, then atrial fibrillation, itong SVT. Let's go into ventricular rhythm. So, si SA node or the AV junctional tissues, wala na. Ang electrical impulse ay nagsisimula na sa ventricle. So, ventricular dysrhythmia na siya. So, these are the ventricular rhythm. Merong PVC, may VTAC, torsadipois, or polymorphic VTAC. Ventricular fibrillation, asystole, saka pulseless electrical activity. So, si PVC, ayan. Meron akong NSR with ST depression. Yan. Huwag nyo lang pansinin, pero ST depression. Biglang merong extra systole. Yan po yung premature ventricular contraction. So, pag sumipot siya, isang ganito, tapos sumipot siya, tapos isang ganyan, sumipot siya, ang tawag bifid, every 2. No? Bicuspid. Bicuspid pala, hindi bifid, bicuspid. Ay, no. No. Sorry. Nalito ako sa terminology. Basta by, dalawa. Bifid yata. By Geminal, sorry, by Geminal. By Gemini. Pag sumulpot siya sa every pangatlo, try Gemini. Okay? So, ayan. So, ito medyo normal. Wag lang siya mag-exceed ng sobrang dami. At pwede siya maging beta. Then, we have the ventricular tachycardia. Ito. So, bibilangin natin siya. Umabot siya ng hanggang 200 beats per minute. It does not mean arresting. Pwedeng may pulso pa yan. Pero maya-maya konti, mawawala na pulso dyan. Wala na po siyang P. No more P wave. Wide QRS na siya kasi ventricular. Pero, abulin natin to. Dito tayo nag-amiodarone. Dito tayo nag-lidocaine. Okay. Then we have, monomorphic yan, isang forma. Then we have the polymorphic or the torsadipois. Torsadipois. Polymorphic po yan. Ventricular tachycardia siya, pero torsadipois. Tingnan natin. Aba, maliit, biglang lumaki. Iba-iba. Ito, may isa pa. Ito yung typical na torsadipois. Yan. Pag ganito ang presentation ng patient, bantayan mo na, hindi natatagal yan, mag-a-arrest na yan. Kasi hypomagnesemic na rin siya eh. Wala na siyang ano. So, mabilis mag-arrest yung heart. Then we have the fibrillation. We have the fine ventricular fibrillation saka the coarse ventricular fibrillation. When you have a rhythm like this, the heart is already in an arresting phase. Nag-arrest na yan. Okay?
then asystole. Although hindi ito ideal asystole kasi sa totoong asystole, siguro para makagawa lang ng isang training, tinanggal lang yung lead. Hindi po ganyan ang asystole. Ang asystole po, meron pang mga guhit-guhit content. No? By the way guys, pag nakakita kayo sa patient ninyo ng asystole, makakita kayo sa lead 2, limb lead 2. Pindutin nyo yung lead, lilipat sa limb lead 3. Tingnan mo kung flatline. Pag pindot mo, nasa ano siya, yung tinatawag nating paddle mode or pad mode. Kung nakalagay pads ang pasyente, prepare for defibrillation, kunwari lang nilagyan, yun ang magde-detect. Flatline ulit. Pindot ka pa isa ng lead. Nakalagay sa machine mo, LEAD. Pag pindot mo sa lead, babalik siya sa 1, Roman numeral 1. Flatline ulit. Pindot ka pa isa, balik siya sa Roman numeral 2. Then declare the patient is having asystole. Huwag ka mag-declare ng asystole by looking at one lead. Tandaan yan. Then we have a pulseless electrical activity. Ito po yung merong activity siya as long as it is not fibrillation, ventricular fibrillation or atrial tachycardia. Any rhythm ng heart, basta hindi lang ventricular fibrillation or ventricular tachy. Any rhythm pero walang pulso. Ang tawag pulseless electrical activity. Pag-manage natin sa kanya ay katulad ng pag-manage ng asystole. Okay? Question? Now let's go into heart blocks. Heart blocks are 4. First degree, second degree Mobitz 1, second degree Mobitz 2, and then the third degree or the complete heart block. So let's look again at the ECG. Okay, tingin kayo. 6-second lead. Ayan o, 1, 3, 6. What is the rate? 1, 2, 3, 4, 5, 6, 7. Aba, 70. What is the rhythm? Equidistant ang R2R. Is there P-wave? Aba, may P-wave. QRS, narrow. Bantayan nyo si P-wave, ang PR interval ang haba, more than 5 squares. 1, 2, 3, 4, 5, 6, 7. Parang 8 pa nga eh. So, prolonged PR interval, more than 5 small squares. Ang tawag dyan is first degree heart block or first degree AV block. May problema ang pasyente? Wala. No problema. The patient can still play football. Let's go into the second degree AV block. Okay. Tingin tayo. Dito na merong lumilitaw na bradycardia. So bilangin ko 1, 2, 3, 4, 5, 6. Oh, demarcation siya. 6 siya at 6-second lead. Regular, biglang humaba. Regular, biglang humaba. Aba, kakaiba no? Is there P-wave? Yes. P. QRS narrow. Pero bantayan niya, tingin-tingin sa cursor ko. Tingin sa cursor ko. P-wave, P, QRS. Aba, lumayo si P. Lumayo siya. Sa pangatlo, aba, sobrang layo na. Then sa pang-apat, wala ng QRS. There is a drop. Okay? So the explanation is progressively prolonging PR interval until a QRS is not conducted. So may P wave which progressively prolongs itself, and then there is some sort of a P wave with no QRS response. Okay, so yan po yung first degree or the Wente back. May problema ba pasyente dito? Wala. Okay lang siya, basta may namomonitor lang. Huwag lang mag-progress into second degree type 2. Okay, dito tayo sa type 1. So makikita mo, 3:1. 1, 2, 3, may drop. 1, 2, 3, merong non-conducting. Dito tayo sa kabila. 1, 2, 3, 4, 5, 6, 7. 70. Rhythm. Aba, regularly, irregular. Kanina, irregularly, irregular. Ngayon, regularly, irregular. Okay? So, is there P-wave? Yes, pero may gradual
prolongation of P wave until merong P wave with no conduction. PQRST, PQRST, P none, PQRST, PQRST, P none. Okay? Ang tawag dito 2:1. Dito tayo medyo mahaba. 1, 2, 3, 4, 5. Nako, bradycardia. PQRST, 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 P none. So ang tawag dito 4:1. Ayan. So yan, si first degree heart block. Huwag kayong malito, basta may progressive na prolongation of PR interval until there is a P with no conduction to ventricular response or QRS. Now let's go into type 2. Dito na tayo sa type 2 magkakaproblema. Simple lang po ang type 2. PQRST, P wala, P wala, PQRST, P wala, or PQRST, PQRST, P wala. May interval. Minsan makakita yung PQRST, P wala, PQRST, P wala, PQRST, P none, PQRST, P none. That's a second degree type 2. Dito, hospitalize the patient kasi kandidato na yan, ito magiging ganito. Or worst case, baka mag third degree heart block. Yan yung potential nilalagyan ng implant ng pacer. Okay? Second degree type 1, gradual prolongation in the progress of ECG, gradual prolongation of PR interval until there is a P with no conduction to QRS. Si second degree type 2 is there are P waves with no conduction to QRS. No? Ang term doon is some P waves are not followed by a QRS complex. Okay? So yan. Now let's go into third degree. Pansinin niyo third degree, kakaiba na. Meron akong P, usually ito sobrang brady na to. 30. Pasyente, pag hindi mo bantayan, mamamatay siya dyan. Tingnan niyo si P ha, tingnan niyo ang cursor ko ha. P wave, equidistant si P wave, equidistant siya. Si P wave nasa T, P wave, P wave, P wave, equidistant, P wave. Si P wave nasa QRS. Si QRS, equidistant sa QRS, QRS. What do I mean by this, ladies and gentlemen? Si P wave saka si atrium saka si atria saka si ventricle ay nagkanya-kanya na. Wala na silang bayanihan. Parang Kongreso, Senado, biro lang no. Hindi na nag-uusap. Yan ang problem. So mag-heart block yan. Ito pa isa, heart block. Tingnan nyo ha. P, P, ang P nasa QRS, P, ang P nandyan no. P, 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 P. QRS, QRS, almost equidistant. Okay. Dito, P, P, si P nasa ST oh. P, si P nasa QRS, P, and P. Si QRS, naku, ang 6 second lead ko, 30 na lang beats per minute. So, a third degree heart block, hospitalized kasi lalagyan natin ng implant ng pacer kasi hindi na mag-beat yung heart. So, pag nakakita kayo ng ECG ganito, ibig sabihin, merong pacemaker or pacer, internal pacemaker. So, yan po yung machine na nagbibigay ng electricity tapos meron akong electrical capture. So, yung heart ko nagbibit. Yan. Okay. So, katulad dito, meron akong PBC plus irregular rhythm, walang P-wave, atrial fibrillation yan. Although, medyo pangit yung ano. So, ito, NSR, kita mo, may P-wave ako, equidistant, narrow QRS. Sa isang tingin, ito naman, less than 60, sinus brady. Okay. Third degree heart block. Ito yung asystole. Tamang asystole yan. Now, let's go into exam. Okay, exam tayo. So, i-monitor ng, ang sasagutin nyo lang ay sa chat. Sagot ka agad, within 10 seconds may sagot.
Okay, pabilisan sagot ha. Magka-count ako ng 10 seconds ha. Or 12 seconds na lang. Okay, number 1. Huwag niyo nang ilagay yung rate. 6 second din yan, huwag niya sa rhythm. Diretso, ano yan. Okay, number 1, 1,000. So, sulat sa chat. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000. Okay, cut. Walang sumasagot. Grabe. Ni isa man lang? Huwag kayong matakot magkamali. Sumagot lang kayo para makorek natin. Huwag po natin sabihin yung beats per minute. Sabihin niyo lang kung ano siya, first degree, sinus na NSR, yun po. Huwag na yung mga 60 beats per minute. Hindi ko na kailangan yun. Diretso. O sige, bigyan ko pa ng another 12. Nagkakaintindihan. Diretso na kung anong ECG yan. Hindi ko anong beat, kung regular or what. No, that's not what I'm asking. Okay, 1,000, 2,000, 3,000, 4,000, 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000. Walang nakasagot? Kumpletuhin nyo kasi sa second degree may type 1, may type 2. Okay, sige, close na. Sige, consider ko tong si Joy saka si Jason ha, sa ngayon lang. Pero tama po sagot niyo, pero type 2 po 'yan. Okay? Bakit? May P, QRST, P drop, P, QRST, P no conduction, P, QRST, P no conduction. Okay? Tama kayo. Okay, next slide. Dalawa lang nakasagot. O, ano yan? Kadi-discuss lang natin. 1,000, 2,000, 3,000, 4,000, 6,000, 7,000, 8,000, 9,000. Sinus brady. Yes, it's a brady, pero kitang-kita ko ano yan. Okay, close. Wrong answer. Brady talaga siya. Pero asan P-wave ko? Asan ang P-wave mo? P, ayan o. P, 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 P. Si QRS, kanya-kanya rin. That's a third degree heart block. Nagkanya-kanya yan. May mga P-wave oh. Sunod si P-wave oh. P, P, P. Si QRS, kanya-kanya din sila. Hindi sila nag-uusap. Okay, next. Ito. Irregular rhythm. 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 10,000, 11,000, 12,000. Okay, close. That's not a sinus tachycardia. Wala nga akong P-wave. Hindi riyan PVC. It's an atrial fibrillation. Walang P-wave mo, tapos irregular yung rhythm mo. Pabago-bago. Next. O, ito. Ewan ko, hindi niya pa makuha yan. $4,000, $5,000, $6,000, $7,000, $8,000, $9,000, $10,000, $11,000, $12,000. Okay, very good, Jason. NSR po yan. Si Jason lang, ang estudyante dito. O si Joy din. Okay, close. Dalawa lang estudyante. Paano tayo mag-ECLS? Okay, ito. $1,000, $2,000, $3,000, $4,000, $5,000, $9,000, $10,000, $11,000, $12,000. Very good, Jason. Sinus tachy.
Okay, next slide. Umabol din si Joy. Bilisan yung pagsagot. O sige, consider natin. Parang dalawa lang yung makakapasa sa isa. Ito. Tingnan natin. 5 points yan, 5 points. $3,000, $4,000, $5,000, $6,000, $7,000, $9,000, $10,000, $11,000, $12,000. Okay. Okay. So walang nakakuha. It's not Torsad, it's not SVT. Artifact po yan, no? Very sharp, sharp edges, oh. Artifact yan. Sira ang lead ng ECG mo dyan. Next, yan, ang dali-dali. $4,000, $5,000, $6,000, $7,000, $8,000, $12,000. Okay. Very good. Ilan na nakasagot? Oh, may nagdagdag pa. 3 na. Okay. Atrial flutter. Is nagdagdag na. Oh, ito ano to? 3,000, 4,000, 5,000, 6,000, 7,000, 9,000, 10,000, 11,000, 12,000. Okay, close. So, walang nakasagot sa napakadali. It's pacer. May pacing ECG na, may facial. Yan, guhit, pacer yan, no? Next. Ano ba yan? Oh, ito, 17. Oh, silent ako mag-count, ha? Close. It's not PVC. It's a third degree heart block. P wave, P wave, P wave, P wave, P wave, P wave, P wave. Equally distant. Ito, a little bit variation ng QRS, pero the QRS narrow, except na so it's third degree heart block. Kanya-kanya sila. Oh. Iba si P wave, iba si QRS. O yan. $2,000, $3,000, $8,000, $9,000, $10,000, $11,000, $12,000. Okay. Wala na ako ha. Meron. Okay, NSR. Very good. Next slide. O yan, ano yan? $10,000, $11,000, $12,000. Sige, sabihin kong sinus brady, pero NSR okay pa rin yan. Kasi ang brady is 50. Pero sige lang, i-honor ko yung sinus brady. So, at least, NSR or sinus brady. Pero tandaan niyo, sinus brady dapat ay less than 50. O, ito. Polymorphic beta. Completohin ha. Torsa di pois. Okay, very good. Next slide. O, yan. Okay. Kuha, SVT, supraventricular tachycardia. Next slide. Bypass natin yan. Ito, bonus. $10,000, $11,000, $12,000. Okay. Asystole. O yan. So, PVC, very good. Dalawa nakasagot. Ang dalawa lang yung makakapasa ng ACLS. O, ito. Okay, 12,000. Sinus tachycardia, kumpletuhin nyo. Sinus tachy. Okay. Very good. Next. Yan, dalawang sagot yan. Ito at saka ito. Dalawang sagot ito. Good for 5 points. Yan at saka ito. Knock. Okay. That's not a third degree AV block, my golly. That is a ventricular fibrillation. Tapos ito, defibrillation. Yan, no? Electric yan. So, walang nakakuha. O, ito. Okay, very good. Atrial fibrillation is not a flutter. Okay. Yan. Bonus points. Okay. Sinus brady. Okay, yan. Okay? That's a second degree type 1 kebak. Second degree, tama, type 1 or 1 kebak. Very good. Last. Ito. Yan. Last. Yan. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Hindi, alam kong sinus bradycardia siya ha. So dalawang sagot siya na. Nabanggit ko na yung isa, pero may isa pa. $10,000, $11,000, $12,000. Okay. So, it's sinus brady and first degree AB block. Bakit? Lampas sa 5 ang small square. So, lampas. So, it's a first degree AB block plus sinus bradycardia. Okay? So, bahala na si Wipam. So, that ends our ECG. Now, stretch a little bit. No? Around 2 minutes, stretch kayo. Timpla kape. Because I will have another topic, which is oxygenation. Ubusin ko lang yung mga didactics ngayon. Tapos few didactics tomorrow before tayo mag ACLS Code Blue. So on oxygen, so bakit kailangan ng oxygen na? Para maintindihan niyo lang kasi medyo hindi sanay pa tayo sa Pilipinas na akala natin dito ko nakakita nagka-cardiac arrest, nakakanyula, may gali. Kita tayo ng mundo, tawanan tayo. No? Huwag niyo nang pansin itong mga cylinders kasi sa lecture lang to pag ikaw ay pre-hospital care provider kasi depende sa size ng oxygen, alam natin kung ilang minuto siya nauubos o ilang oras. So depende yan gaano ang flow rate natin. Time is in hours, no? So ganito din. So kung size D hanggang size G, pag size G kunwari I'm utilizing 4 liters per minute. So yan po yung aking 20 hours po yan. Yung malaki po itong size G. So yan yung mga sizes ng oxygen tanks. Now, oxygen therapy is dalawa po. Isa medical oxygen. Ang medical oxygen is with humidifier, saka emergency oxygen. Ang emergency oxygen is from oxygen, flow rate, diretso, wala nang humidifier. So, ang flow rate can be set on the wall top. Dapat nasa 15 liters per minute for your emergency line. Okay? So, ginagamitan natin ng mga connectors. So, one is nasal cannula, adult and child. So, ang kanyang max is around 30% oxygen. So, isipin mo, ang ating ambient oxygen is 21. So, kaya mong mag-30 at 4 liters per minute. Beyond that, nagdadry yung nose natin. So, ginagamit natin siya sa mga non-acute situations, ACS, even sa stroke, pagpasok sa ospital, cannula mo nang ginagamit. So, yan, everyone knows that. Ang Hudson mask is simple face mask. Ang kanyang percentage na maka-expect ka ng oxygen is 40%. Ang maximum niya is 10 liters. So, pwede din natin ginagamit kung wala kang non-rebreather, okay na yung 40% Hudson mask. Ideally, it's suitable for patients with hypoxemic type 1 respiratory failure. So, ganyan ang forma niya. Walang kinalaman sa ACLS is your Venturi. Ginagamit natin sa COPD. Meron siyang mga color jets. No? Pag blue, kailangan 2 to 4 liters lang para ma-expect natin ang 24. Hanggang green, which is 12 to 15 liters per minute para ma-expect natin yung 60% of oxygen, FiO2. So makikita natin dito guys, makikita yung picture na iba-ibang color. Napapalitan to, natatanggal, palitan natin ng green. So pag green, kailangan ng oxygen ko, ang flow rate ay nasa 12 to 15 liters para ma-achieve ko yung 60%. Gamitin ko yung yellow, dapat 8 to 10 liters lang para ma-achieve ko yung 35% of oxygen. Ngayon, dahil ACLS tayo, ang ginagamit natin is non-rebreather mask. Ang delivery niya is 85 to 90% at 15 liters per minute. So yung forma niya ay ganito, non-rebreather mask. Yan. Yang merong one-way valve. Ito ay partial rebreather, walang one-way valve. Di natin ito ginagamit. Ito ang ginagamit natin, the non-rebreather mask. So simple face mask or Hudson to the non-rebreather mask. Venturi and partial rebreather, hindi natin ginagamit sa ACLS. So, pag nag-arrest yung pasyente, pinakamaganda ay NRM or NRB. So no more CPAP, hindi na natin ano yan. Ganyan lang kaiksi yung lecture na to. Diretso tayo sa fluid. So sa fluid, bakit tayo nagbibigay ng fluid? It is because to resolve the issue of hypovolemia sa reversible, no? Sa reversible factors ng ACLS. Okay? Hindi na ako mag-deep dive into osmotic and oncotic. So we know that we are 70% or 2/3 water. And they are mostly in the cells of the cardiac of the skeletal muscles. So there is around more in by ratio 75 to 80 sa newborn kasi growing years yun sila, no? Very wild ang growth ng panahon na yun. Pag nawalan ka ng 20%, for example, ako adult, mayroon akong 5 liters, nawalan ako ng 1 liter, drama na yan. Pag 1.5, pahirapang buhayin. Pag nag-2 ka na, 2 liters na wala na sa'yo. Point of no return. So, mas serious sa mga bata, lalo na pag nasunog, no, yung kanilang skin or water degree, second degree, ganyan, malaki pa ang area na burn. Kasi ang fluid na ma-evaporate sa environment, mabilis. Problema kasi higher metabolic rate sila, kailangan ng tubig. Kaya mas grabe yung drama, physiological drama ng bata. So the compartments are intracellular fluid dominated by your potassium, and then the extracellular fluid, which is subdivided into intravascular, interstitial, and transcellular, dominated by your sodium, cation. So ito yung tinitingnan natin, but not deep dive into ACLS because this can somehow affect our way of solving shock, which like hypotension. So, yan ang ang intravascular natin, plasma siya, which is protein component, kaya nakaka-hold ng fluid. Then we have the interstitial that's in between cells, in between the cells and cells, in between the cells and the vessel. So, ito yung reservoir natin. And of course, yung transcellular na dual purpose, it serves as a shock absorbent in between two bones. Pangit naman na nagbabanggaan ang buto, masakit yan, hindi tayo makalakad ng maayos. Then we have this osmosis, which is solute potential, water potential. So movement ng water to sa area na medyo malabnaw hanggang sa area na medyo, ano bang opposite ng malabnaw? Malapot. Ganun lang, no? Diffusion naman is solute potential. Ito yung galing sa malapot, yung mga solute doon, hindi tubig, magmamigrate naman or magda-diffuse papunta doon sa lugar na kung saan kulang ang solute. Without us thinking about it, passive lahat to. And diffusion and osmosis occur at the same time until equilibrium is achieved. Meron din tayong active transport which is dominated by your sodium-potassium pump, no? Na kung saan namumove yung mga water and other things na kailangan sa cell, puwersahan kasi kailangan sa metabolism. Isa rin yung insulin glucose, no, transport. Pag may glucose tapos adequate yung insulin, sumasabay si potassium, no, sumasama sa loob. So this is an active transport also. Okay? Hindi ko na pag-usapan yan. Dito tayo sa prescribing fluid. There are two main components ng ating fluid resource. One is crystalloid, yung saline, dextrose, lahat sila kasi may crystal siya. And then the colloids, which is blood, plasma albumin, and yung mga synthetics like dextran,
like plasma sterile, sterile starches. Pero yung breakdown nila ay 4. Blood products, mga NSS products, sugar, at saka isa blood. Kalimutan ko. Mamaya na. Yan. Colloid pala. Yung mga, yung mga colloids, protein component. Kasi sa field or sa atin, replace blood with blood. Hindi katulad sa ibang bansa, mayroong O negative. Sa atin, wala. Mahirap magharap ng O negative. Pag nag-blood loss ka, magpapaano ka muna, mag-undergo ka into tawag nito, cross-matching. Replace plasma with colloid, resuscitate with colloid, replace ECF depletion with saline, and then rehydrate with dextrose. Okay? So alam natin, sa physiology, meron tayong tinatawag na homeostasis na kung saan merong balanse sa loob ng katawan upang ang kanyang optimal function ay napupusto. So tinatawag natin siyang physical equilibrium or the homeostasis. So trabaho mainly ng kidney yan, then the lungs. No? So kailan natin siya ibibigay? So titingnan natin dito, hindi ko na i-discuss yung iso, hypo. So ang ating available IV solution ay water and glucose to rehydrate the cell, crystalloid to fill up the interstitial, colloid is to jack up the BP, and whole blood is to replace the blood loss. So ganun lang tayo. So 4 lang. Now, how do we go around it? Okay, tingin kayo sa akin. Wala. Tapos tingin dito. Itong 30 liters na to ay nasa loob ng cells, intracellular. Ito interstitial. Itong 3 liters assuming nasa loob ng blood vessel. Okay, ha? So makaintindihan tayo, para pag nanood kayo, makikita niyo paano ang action ng mga fluid binibigay. Okay. Nagbigay ako ng 2 liters of blood sa 3 liters. Anong mangyari? Automatic 5 liters. Nagbigay ako ng 2 liters of colloid. Tingnan niyo ha. Ang mangyari, 5 liters. Except colloid siya, napaka-saturated with protein products, kukunin pa niya yung tubig sa cells at sa interstitial. At jack up siya ng 7. Kung 7 liters. Kung gusto niyo makapagpataas ng BP kaagad, kinukolloid yan. So, case-to-case basis. Sa trauma management, meron pa rin mga dispute on that. Bigay ko ng saline. Tataas siya ng 5 liters, except si saline pupunta sa interstitial, pero may maiiwan sa intravascular. Kaya ginagamit pa rin natin siya sa blood loss, bagsak ang BP. Initially, pwede tayo mag-saline kasi nakaka-jack up siya ng BP. Okay. Nagbigay ako ng dextrose. Since dextrose can be converted into it's a sugar na maging glucose kaagad siya, diretso kaagad siya sa cell. Yan. So, ganyan po ang nangyayari when we give fluid. Now, let's go into some highlights on, some issues on the potassium. Kasi si potassium, sa reversible HLTs, hyperkalemia, hypokalemia. Isa sa nagbibigay ng problema is the depletion of potassium or the increase of potassium dahil meron kang kidney disease, no? Nare-retain siya. And both sides are not good for the heart. May hyperkalemia, hypokalemia, reversible siya. Pag may hypokalemia ka, magkakaroon ka ng decreased BP, ECG changes, cardiac arrest. So binibigyan ka ng potassium chloride or sodium, pwede bang sodium bicarb? No, potassium chloride. No? Pag hyperkalemia ka naman, may stages ng hyperkalemia, depende kung anong kataas. So, ECG tape, magkakaroon ka ng tented T waves, magkakaroon ng BTAC, mag-pulseless BTAC, cardiac arrest ulit, no? So, nakakatakot. Kaya dito, gusto natin tingnan paano natin ma-reverse yan. So, depende sa taas, Usually, maraming gamot ang hyperkalemia. Calcium gluconate or calcium carbonate, 10%. Sodium bicarb, although case-to-case basis, sodium bicarb. Dialysis, glucose plus insulin, thiacylate enema, yan. No? And then, sa calcium, huwag na muna gaano. Dito tayo sa hypomagnesemia. So sa magnesium, pag hypomagnesemia ka, magkakaroon ako ng torsa di poa. ECG changes is polymorphic ventricular tachycardia. So yan po yung ating binabantayan. Kaya binibigyan natin ng sodium, magnesium sulfate. Pwedeng IM or IV slowly, 1 gram to 2 grams para ma-reverse natin si polymorphic. Okay? So yun lang dyan, yan lang naman yung gusto kong maintindihan natin dyan sa fluid. Okay. What else we have to discuss? Bigyan ko ng last topic sa inyo, which is therapeutic electricity. Bago tayo let's call it a day. Kasi alam ko, utak ninyo na wendang na. So therapeutic electricity, I'll make it simple to you now. Doon lang sa mga gamit natin. Okay. Now, defibrillation, CPR alone can double the chances of survival. Diba? Nakita nyo kanina sa graph during sa BLS lecture ko. Pero, the use of defibrillator can jump up from 6% to 74%. Ganyan po. So, deploying defibrillator, 3 to 5 minutes of collapse can produce survival rate as high as 50 to 70%. So, napakagaling ng defibrillation. So, who gets defibrillated? This one. Pero itong flatline, no way. Continue CPR. So, ito ngayon, meron akong monomorphic beta, pulseless siya. Biglang nag-defibrillate ako, boom! Biglang bumalik, kumasa ulit siya. Meron ako, may naka-trans-implant pa siya, naka-pacer siya. Implant, pacer. May pacer siya o implant sa loob. So, na-activate. Pero hindi maganda yung capture. The heart fires all by itself, although yung implant nag-fire, the implant fires all by itself, but the heart also fires all by itself. Merong capture pala, sorry, meron. No? Kaya pala nag-fire, may capture. Nagka-capture siya. There are situations na nagpa-fire si patient, nagka-capture siya. So, ganyan ang nangyari. So, defibrillation is parang in-overwhelm mo yung chaotic electrical activity para ma-recalibrate siya into producing the usual rhythm niya. So, hindi siya tinatawag ng mga jump start, no? Na jump start natin yung heart. Hindi po yan ang tamang term. No? So, hindi rin natin gini-defibrillate si flatline. So, ang ating defibrillation ay pwedeng paddle or pwedeng pads. Dati, paddle. Nang ni-replace yung pads, tapos ngayon, binalik ulit yung paddle pero may pads. So, selection ka ngayon. Pag nakapaddle ka, nasa left side ng pasyente, merong bigat. We call it the 25-pound paddle pressure. So maganda siya kasi it can affect the impedance of the transfer of electricity. I am more comfortable with paddle, pero kailangan skillful ka lang. So ang arrangement ng paddle, ng pads usually ay sternal apex position. Okay? Yung anterior position ginagamit natin sa bata. So usually ganyan, no? Yan yung tinatawag nating sternal apex, but this is paddle. You must be on the left side of the patient. So yan po yung pads. Now, we have to know na we have to identify if the rhythm is shockable. Kung manual response, no? I mean, you use manual defibrillation. So, by basic na, pinakabago ngayon, which is 200 joules, yan yung ceiling joules mo. Now, pinakamaganda, kung yung paddles mo ay merong sticky pad, conductor siya, ilagay doon. Kasi nasanay tayo na KY jelly pinapahid sa paddle. Okay. So, AED versus manual. Ang AED ay pang common people, ang manual ay pang mga professional like us. So ladies, pero pinakaluma to, this is pressure control. This is 360 joules. Ito yung gamit ko, year 2000. Maganda yan. This is LifePack 10P. Meron siyang transcutaneous spacer. Tapos ito, zero, naka-off. Pag ipindot mo dyan, i-rotate mo to, boom! Gagamitin niya battery 1, battery 2, battery 3. Dito naman ay cardioversion sa defibrillation. Ito yung paddles niya. Ito ay pacer mode. So meron yung attachment para ilabas yung transcutaneous spacer. Yan yung battery charger plus dito ka nagpa-fire in the morning ng around 20 joules to make sure that your machine is still okay. Ito yung mga bago ngayon, all-in-one. I think 13 parameters. Meron siyang systolic, meron siyang diastolic measurement, mean arterial pressure, cardiac rate, pulse oximetry, respiratory rate, temperature, 12-lead ECG, defibrillation, cardioversion, transcutaneous spacing, capnometry. Yan, 12 pala, 12 parameters. So yan, ganda yan. Mahal lang. Okay, yan yung pads. Ito yung AED ng mga pang layman, depende. Sa cardioversion naman, pareho lang din siya. Ang kailangan lang, meron kang, kanori ito, atrial fibrillation with rapid ventricular response. Kailangan lang align sa QRS. Pag merong algorithm for cardioversion. So, ano ko na lang. So, ito yung tandaan natin. Pag narong regular, 50 joules to 100 joules. SBT, atrial flutter with rapid ventricular response. Pag narong irregular, katulad ng atrial fibrillation with RVER, rapid ventricular response, 120 to 200. Pag wide regular, BTAC, no, monomorphic BTAC, usually may pulso pa to, yan, 100 joules. Pag wide irregular, no need to cardiovert. Synchronize, ano siya, defibrillation. So yan yung mga indicators. SVT, automatic, pag mayroong hasiya, hypotension, and or acute altered mental status, and or signs of shock, and or there is ischemic chest discomfort, and or acute heart failure. Then we also give cardioversion to atrial fibrillation with rapid ventricular response, atrial flutter with rapid ventricular response, monomorphic VT, polymorphic VT, wide complex tachycardia of uncertain type. Okay, so ganito siya. Tingin dito. Kinabit sa cardiac monitor, kinabit na sa pads, ang pasyente binigyan ng midazolam. Pindutin nyo tong sync. Asan ba yung sync? Yan. Pindutin ang sync. To sync. Pag pindot nyo sa sync, makikita nyo ang lahat ng QRS. Katulad dito, this is, anong ECG reading dito? This is atrial fibrillation. Pwedeng may RVR to. Pag pindit nyo sa sync, may makikita kayo mga dots. Ang dots na yan, yan yung timing ng machine na pag kailangan mong i-shock ang pasyente, ito kulay, itong lightning, ang machine will sense it na mag-shock siya during QRS. Nakasynchronize sa QRS. Kaya ang tawag sa kanya, synchronized cardioversion. Yan. No? So, sync lang yan. Pag may ilaw na, pag pinindot mo yan, wala nang sync, mawawala itong dots. So, ganyan lang po ang cardioversion. Pero ang kailangan lang, tulog ang pasyente. Kasi non-arresting si cardioversion. May tachyarrhythmia lang siya. So we go into transcutaneous spacing. So pinaka-latest ginagamit natin is demand rate versus fixed rate. Yung fixed rate, nagbibigay siya ng impulse transcutaneously, wala siyang pakialam ko yung heart mo nagbibit na. Ang demand rate, nagbibigay siya, pag na-sense niya na nagbibit na yung heart mo, mamamatay lang yung machine. And it's categorized as class 2A intervention. For symptomatic idioventricular escape rhythms, third degree heart block, second degree type 2 heart block. Okay? So 2A intervention, 2B siya sa bradyasystolic arrest. So paano natin ginagawa? I-shortcut ko na lang. Picture tayo. Nag-pace ako, ito machine to. Meron akong QRS or electrical response. Binabaan ko ngayon yung milliamperage. Nag-pace. Biglang nakas-detect ang machine na meron ng intrinsic activity of the heart. Namatay na si machine, kusa na yung heart mo nagtatrabaho. Yan yung tinatawag nating demand. No? Biglang nagbagal siya, nag-heart block ulit, babalik ulit si machine mag-fire para magkaroon ng sariling pace niya from the machine itself. Okay? So, si asynchronous naman, fire lang yun sa fire, wala siyang pakialam kung nang si heart ay nag-responde sa kanya, whether meron siyang intrinsic, magpa-fire lang siya ng magpa-fire. So, yan yung problem. That's the old school. So, ngayon, ano ng machine natin? Okay? Saglit lang guys ha. Saglit. I'll just drink water. Nag-dry yung throat ko.